productive and inspiring conference. I now request the dignitaries, Dr. Sabhyata Gupta ma'am, Dr. Michael Grant, Dr. Luis Costa, Dr. Ashok Ved, Dr. Maria Jain, Dr. Jens Huber, Dr. Hemant Malhotra, and Dr. Rakesh Sharma to kindly proceed to dais for the lighting ceremony, which will formally inaugurate the conference.
Dr. Anand, are you hearing? Dr. Anand, are you hearing? Yes, sir, I'm here.
Can you hear me clearly?
Yes, clearly. You are hear me?
Yes, I can hear you.
Clearly, sir?
Yeah, I can hear you.
Okay. Thank you, sir.
Can you hear me clearly?
Yes, sir, clearly here.
Okay.
Okay, thank you.
Okay. Yes. Thank you so much to all the dignitaries. So now let's begin with our agenda. I would like to welcome Dr. Pavan Kumar. Thank you.
Thank you everyone for coming this wonderful morning. So without further delay, I would like to invite the chairperson for the next session, Dr. Ashok Kumar Ved, sir. He is the chairman in the Department of Medical Oncology at the Medanta, the Medicity. Dr. Rakesh Kumar, sir, founder and chief executive officer and president and chairman of the board. Dr. Luis Costa, professor and director of the Medical Oncology, principal investigator, Institute of Molecular Medicine, Lisbon Academy Medical Center, Lisbon, Portugal. And Dr. Sabhyata Gupta ma'am, she is the chairperson in the Department of Gynecology and Gyneo-Oncology in the Medanta, the Medicity. So, I would invite to Dr. Ashok Ved sir for the inaugural speech. Thank you.
Good morning, esteemed colleagues, great pioneering researchers and clinicians who have gathered here this morning and who are passionate advocates of the space of breast cancer treatments and advancing the knowledge. It is a profound honor to welcome you to this critical conference focused on the area of oncology, an area which demands our deepest attention and needs more innovation and a very, very compassionate care, and that is the breast cancer in young women. Each one of you in the room is a fountainhead of knowledge in this space, yet we gather here to sort out the challenges, and the challenges are many, the list is long, and it's the aggressive biology. With a diagnosis in a young woman, life almost comes to a standstill, and going back into life after treatment is even a bigger challenge. I'm sure the next 1.5 days will bring up critical issues around all these aspects of breast cancer in young women. We need to have more data in this age-specific disease, because a lot of times the data is extrapolated from older women to younger women. And we need age-specific clinical trials, better integration of the genomics, and personalization of the medicine. Ladies and gentlemen, I have to thank Professor Rakesh Kumar for catalyzing the whole concept of bringing this conference to Delhi. Very thankful to you, Rakesh, and giving us an opportunity to host this and disseminate the knowledge about this disease entity to our colleagues. And I do trust and hope that this would go a long way in our learnings and application of those learnings in our patients. Welcome once again, and wish a great conference, great learning experience, and mutual exchange, and fostering knowledge and creating collaborations and friendships through the 1.5 days we are gathered here. Thank you, ladies and gentlemen, once again.
Well, I'm Rakesh Kumar from Breast Cancer in Young Women Foundation. I echo all the thoughts, spirit which Dr. Ashok Vaidya had just said, so I'm not going to repeat. But I would like to start by thanking each one of you to come, to travel to Delhi, take out a important part of your life to come to weekend all the way to the New Delhi, especially when there was a terror attack, and to be part of a transforming scientific conference in India, where we will be discussing the challenges and the way to go forward when it comes to the troubling trend of growing breast cancer in young women. For the next 2 days, we'll be hearing from the expert from breast cancer survivors and advocate the challenges and how can we easily overcome if we work together. With that in mind, I will give podium back to Dr. Ashok Vaidya and introduce our first speaker.
So I have the privilege of introducing Aaron. He is a Nobel laureate in chemistry, distinguished research professor, and the Rappaport Family Technion Integrated Cancer Center, and a faculty at the Division of Medicine and Research Institute in Israel. Welcome, Professor Aaron. He'll be delivering his lecture online. He's already connected, and we are well on time to listen to him. The topic for his presentation is the ubiquitin proteolytic system, the journey from a vague hypothesis to efficient anti-cancer drugs. Could we connect, Professor Aaron? Welcome once again. We can see you. Very well.
Can you hear me?
very well. Thank you. Good morning, and a very warm welcome. Thank you.
Thank you very much. It's a very early morning now in Israel, 6 a.m. I just want to know how long time I have, so I will not take time from the following speakers. Can you just let me know, Rakesh, how?
I would say 30 minutes, but you have privilege
Can
to
you let me
go
know
beyond
how
it.
much time I have?
So I would say 25 to 30, 35, but it's up to you, Aaron. You took time. Please got it.
I got it. Thank you very, very much. I just want, before I start my presentation, to let you know I'm a physician and I'm also trained in surgery, but then I decided to go to science and did then my PhD in biochemistry, where we discovered what I'm going to tell you now. I'm not going to go in my talk into technical jargon. I just want to tell you how interesting, probably you know it as much as I know, the road of science. Because we started with a small biological question of how proteins are degraded in cells. And then all of a sudden, took almost 5 decades where we are now. There are many drugs in the market, and most of them against cancer. And I will show you also some of our recent data from our lab on breast cancer. Cancer, as you all know, is on one hand a tissue-specific disease. Your organization and this meeting is concentrating on breast cancer, but cancer hits basically every organ in the body. And there is now a tendency in the world of cancer research not to look into tissue cancer, but rather to look into cancer which are driven by different drivers. So instead of looking at breast cancer and brain cancer and lung cancer, people are starting to look into oncogene-driven cancer. So which cancer are caused by p53 mutations, which cancer are caused by MET mutations, RAS mutations, Jun-FOS, etc. Because the idea is, you know, you can look into breast cancer and you find out that there are many breast cancers, intraductal, and so on and so forth. And the same for any cancer. So each cancer is driven by a different mutation. So there is now a whole idea rather to remove the tissue borders and to look into cancer via its mechanism. So maybe the same drug that we are using for breast cancer can be used into the same cancer that is driven by the same oncogene, like a mutation in the EGF receptor in the lung or in the brain. We know already that EGF receptor mutation, HER2, that is being treated by Herceptin, can be the same mutation can drive glioblastoma multiforme, brain cancer, can drive some of the lung cancer, and so on and so forth. So probably we can treat them with the same disease. So there is a big movement now in the world of oncology. Anyway, we started with a question that doesn't look at all to relate to cancer, but that's the beauty of science, that you can never know. And now there is a multi-billion-dollar market for cancer, mostly for hematological cancer, but it's moved gradually into other cancer. And if I have time at the very end, I'll show you our data from our laboratory. We are developing now a new drug on metastatic brain cancer. Of course, in animal models, we are still not in patients, but hopefully we should be in patients soon. So let me share the presentation with you. Can you see? Can you see the presentation?
Yeah.
Okay, good. So I'm going to tell you the story. And the story started in the early 70s when I was a graduate student. After I departed the operating theater and decided to go to science. And at that time, most of the people in the scientific community were working on protein synthesis, how proteins are made. So at that time, the central dogma of biology was kind of set the information, the flow of information for DNA to RNA to protein. Actually, if you all know that this week passed away Professor James Watson, one of the pair of Watson and Crick, that deciphered this double helix structure of the DNA, and he is regarded as the father, one of the two fathers of modern molecular biology. Because I live in Israel, and it's a very small country, and we didn't want to go into this big competition, we decided to go to the other side, how proteins are destroyed, not how they are synthesized, and I tell you the story. So proteins in the body are destroyed in different locations. They are destroyed in the stomach, but in the stomach it's not really in the body. Not only in the stomach, but also in the intestine. This is not really inside the body because the intestine is a tube that crosses the body from the mouth to the anus. So it's kind of out of the body, and all the protein that we are eating in our diet, let it be dairy, let it be meat, let it be fish. In India, I just was a few weeks ago in southern India. I was in Chennai and in Pune. You are eating a lot of chicken and other types of meat, and we are digesting all the proteins that are contained in the diet in order not to challenge the immune system. We are degrading them into amino acid, absorbing the amino acid and synthesizing our own protein. Then we are moving into the body, we are moving into the blood, into the vascular system, and there we are meeting also several protein-degrading proteins, like the blood clotting system. You know the blood clotting system, when we are being wounded, there is a secretion of tissue factors from the wound, and a cascade of events is starting when at the very end a protein called fibrinogen, which is a protein, cleaves, and is being cleaved to generate fibrin, and fibrin is the blood clot. But there is a whole cascade where one protein cleaves the next protein into a smaller protein, the smaller protein becomes active, go to the next protein and the next protein, and at the end, fibrinogen is cleaved into fibrin. So this is inside the body, intracorporeal, but extracellular. Now we are moving to the lower level, which is the cell itself, and in the cell, proteins are degraded all the time. Actually, the magnitude of protein degradation in the cell is huge. You are sitting now and listening to my lecture, and meanwhile your proteins are being degraded all the time. Every day, we are degrading between 5 to 8% of our protein. 5 to 8%. Some proteins are living longer, like hemoglobin. It's living like 120 days, but most of the proteins are not living even 1 day. And some proteins, like oncogenes, these are the proteins that are very interesting for you, are living only few minutes. Every few minutes, they are degraded and replaced, Take, for example, P53, mutated P53, take MYC, take FOS, take JUL, take NF-kappa B, take RAS. All these proteins are very, very short-lived. They are replaced every few minutes. So the question was, what is the system that degrades this protein? And initially, people said to us, what is the issue? It's probably the lysosome that degrades them, but we thought it's not the lysosome. proteins are so short-lived? Okay, so there are three reasons. And I'm going to talk only on intracellular protein degradation, not on degradation that occurs outside the cell. One reason is quality control. Proteins are very much susceptible. They are susceptible to temperature, not to the high temperature in Delhi, and not to the high temperature in Pakistan or even in Israel. In the body temperature, remember the body degradation. If you leave meat or cheese on the table, in few hours it's gone. And the body and the temperature in the room is only 25 or 26 degrees, not 37 degrees. So the body temperature, which is very high, is deleterious, it's destructive for proteins. There are mutations, chemicals, irradiation of the sun, UV irradiation, air pollutants. So the issue of quality control is a central issue, and the body developed lots of systems in order to handle quality control. Take, for example, the chaperones. So one reason is quality control. Another reason for the destruction of protein, the damage that is occurring to protein, is the oxygen. Oxygen on one hand is necessary, like the high temperature, but on the other hand, we are taking antioxidants because oxygen oxidizes the protein and causes damage to the protein. So they get denatured, they get discolored. So quality control is a big issue in the body. Another reason why we degrade protein is we are degrading normal proteins in order to control processes. Let's talk, for example, on cell division. During cell division, the cell and cell division is fundamental for cancer pathology because in cancer, cells are divided in an uncontrolled manner to generate tumors. So we are losing the control over a very fundamental process, which is cell division. But cells are dividing in the body normally. The gastrointestinal tract lining, the epithelium, is divided every 2 or 3 days. The white blood cell. So cells in the body are dividing normally, but once we are losing control of the process, we get cancer. So during the cell division process, different regulators are degraded and synthesized in order to allow the movement of the cell from one stage to another until we have two cells. Those proteins are called cyclins, cyclin-dependent kinases, cyclin-dependent kinase inhibitors, and we need to control them in a very precise manner. And then, of course, differentiation. Remember the embryo. When the embryo starts, it's a cluster of cells that express all proteins, but then start a process of differentiation. The liver becomes liver, the brain becomes brain, the intestine, the is a measure that experimentalists are using. It's the time that takes to degrade 50% of the proteins of that population and to make the 50% of new ones. So let's say that we have 100 molecules. It's the time that takes to degrade 50 molecules and to synthesize, to replace them with 50 newly synthesized proteins. And look at number 16 or number 15 or 14. They need 12 hours. It's a vast difference between 0.2 hours and 15 hours. And as I told you, there are proteins that are living much longer, like hemoglobin in our red blood cell is living 120 days. So you see that each protein is degraded separately from the other protein because they have different stability. So what did we do? We went to ask ourselves, what will be the appropriate biological question system in which we can study, and we found the reticulocyte. The reticulocyte is the young red blood cell in the bone marrow before it's maturing into the mature blood cell in the circulation. This is the mature red blood cell. You can see the red hemoglobin. And this is the reticulocyte, which still has the hemoglobin synthesizing machinery. Now the maturation process from here to here requires protein degradation. As you all know, the red blood cell is a very primitive cell. It has hemoglobin, it has glycolytic system, cytoskeleton, but all the other systems in the maturing red blood cells have been degraded. So we decided to work on the reticulocyte as our model system for protein degradation. Remember, we are still away from diseases and from cancer and from everything. And we discovered it in the system, and I'm going to show you just the principle. Just to show you a little lesson, we published the first paper in 1978. So it's now almost 50 years to the discovery. And the paper was discovered in a very side journal, I would say, a very low impact factor journal called BBRC, or Biochemical and Biophysical Research Communication. I'm sure that my good friend Rakesh Kumar know about it, and you also know about it. And this paper, which is the founding paper when we discovered the system, was cited by the Nobel Committee. I just draw your attention to it because it tells you that what is important in science, in my opinion, is what you publish and not where you publish. So people are running these days after the New England and Nature and Science and Cell and Lancet, and I think that this is not important. What is important is what you publish and not where you publish. But this is kind of a side issue that I don't want to concentrate on now. And we discovered indeed a proteolytic system. I will not go into detail, but I just show you the principles of the system. Okay, so here we have a protein, we call it target, that needs to be degraded. Let's say that it's a molecule of protein that got mutated, like in sickle cell anemia, like in RAS. Let's say that we have a mutated RAS in the brain cancer, or in lung cancer, or mutated EGF receptor in breast cancer, or estrogen receptor, or progesterone receptor. In triple negative, we still, unfortunately, don't know what's going on, but we are on the way. So something must happen to the protein in order for our system to discover it. And in this case, the double protein gets doubly phosphorylated. So the system identified that something is wrong with the protein, it got a mutation, and it labels it with 2-phosphate. This is just one example. It doesn't happen to all protein. This is one protein that we are working on. So it's 90-kappa B, then it's doubly phosphorylated. Then the system identifies it, and identifies it by a protein called E3 or ubiquitin ligase. Doesn't matter. In parallel, a small protein called ubiquitin is being activated by one enzyme. Everything was discovered by us. And then moving to a second protein, and then bang, it goes to the target. It is being degraded it. It's only got the marker on it that made the system recognize it. Now comes the system, the proteins. Remember, we are talking about proteolysis, about protein degradation. It recognizes not the protein, it recognizes ubiquity. And ubiquity is like the biological question, you are limited in discovering only the function that you are studying. But there are many other functions of the ubiquitin system that were discovered later on by genetic screening and so on and so forth. We didn't know anything about the ubiquitin system. We asked the biological questions of how proteins are degraded. And we discovered, like one avenue, one channel of the ubiquitin system, which then stimulated research by thousands of researchers worldwide, and then discovered the full-blown system. And now we know that the ubiquitin system is involved basically in every important cellular process, from cell cycle to transcription regulation to DNA repair, receptor modulation. We just mentioned the mutated EGF receptor in breast cancer, metabolism, and so on and so forth. Therefore, no wonder that drugs were developed. And if you think about it, why there will be diseases? If we think about the concept, then here is the concept. Proteins, in medicine, you are all physicians. Medicine is a profession, I am a physician too, is a profession of number. We have certain weight, and if we are obese, this is a deviation. We have certain height. We have all the values in our blood, sodium, potassium, hemoglobin, everything, calcium, phosphate, enzymes, alkaline phosphates, X-phosphates, whatever you are looking for has a value. And the deviation from the value is a disease. So proteins have a value. IgG has a value. Albumin, for example, has a value of about 4 grams per cent. Our hemoglobin is between 12 to 14 grams per cent. So proteins are typically in a level. They are kept in a level. If the system doesn't work, the protein deviates from the level. If the system acts excessively, the protein is low level. If the system is inhibited, the protein becomes high level. Now, what this has to do with cancer? Let's go to culture. And we should see a very simple explanation. Normally, there are proteins, normal degradation. patients at a time. You know, I remember as a surgeon, when we went to the operating theater, you know, operation can take 5 hours, 10 hours. You are treating one patient at a time. In science, when you are lucky and you are developing a drug, you have the ability to impact the lives of millions of people. And I think that I was lucky in my life to live in the two worlds. The world of medicine, in which I treated patients one by one, and now the world of drug development that is treating millions of people during the entire world. So I will wrap up here and let the next speaker to enter, and want to thank you very much. I am sorry that I'm not able to participate physically in this meeting. I hope to do it in the future. I have a nice collaboration with Professor Kumar in the university in Dehradun. I visited him in North India, and I am coming to India quite frequently, as I said. A few months ago, I was in southern India, in Chennai, and then Pune, and I hope for the next meeting and to tell you on the progress in our salon and to meet you all physically. So I wish you the best in this meeting and a great success and expansion of knowledge, exchange of ideas for the promotion of treatment of cancer research and drug development in young women that is extremely important, and it happens so tragically in very young people, and we need to solve this problem. And part of it is on your responsibility to do so. Thank you very much.
Standing ovation, Aaron, and we really appreciate you to get up so early and share your story. And there are a lot of young colleagues here who are already inspired what you have just described. Do you want to say something?
Thank you, Aaron, and we are really inspired and grateful to you. Thank you.
The very best. Bye-bye.
Hello. I would like to invite next speaker, Professor Michael Gant, for the next talk, that is endocrine therapy for young early breast cancer patients. Thank you, sir.
1 second. Well, I am back again. It is my distinct privilege to introduce our next distinguished speaker, Professor Michael Gant from Medical University of Vienna in Austria. Dr. Michael is a surgical oncologist of global repute, and he is also the president of National Breast and Colon Study Group, and most importantly, he has been chairing the famous St. Gallen consensus meetings. Dr. Michael has been interested in immunotherapy and targeted therapy at large. His work has really led to a lot of major clinical trials which are now currently used to improve the treatment of breast cancer patients and other cancers. Michael's lab has published more than 800 publications with 120,000 citations and H-index of 111. He has shared his experience and knowledge by giving more than 1,000 invited lectures, and he is a very active person, and we are very thankful to him to find time to come to New Delhi and spend some time with us. He is serving on the editorial board of a large number of leading cancer journals and on the scientific societies. Michael, it's all yours.
Thank you so much, Rakesh, and thank you, Luis, and everybody else, Dr. White, for bringing me to India, back to India. I'm very honored. I applaud this initiative of focusing on young women with breast cancer. and I'm glad I can contribute a little bit. I'm going to talk about the endocrine treatment. Here are my disclosures. This is where I live. It's not my actual house, it's just Vienna. And as you might know, Austria is a tiny country in the heart of Europe. But we have great breast cancer patients, of whom 30,000 have contributed to prospectively randomized breast cancer trials in the last decades. If you could do this in India, you could recruit every trial within 2 weeks. So, I mean, in some trials, we have 2 out of 3 breast cancer patients actually contributing to clinical research. So even tiny countries can contribute a little bit, and you have alluded to, Rakesh, why the St. Gallen International Breast Cancer Conference has moved to Vienna about 10 years ago. This year we could welcome more than 4,000 people from 100 countries around the world, and this is also considered the largest tumor board in the world, and we have eminent faculty members such as Jens Huber, Marie-Jeanne Franken here, who contributed that. And actually, as of last week, now finally, the consensus guidance paper is online, and you can look up what St. Gallen suggests to be the standard of care. Now, this is the agenda of what I'm going to talk about, and I will start with when we discuss endocrine treatment, we obviously discuss luminal breast cancer, and I believe it's time to move to endocrine responsiveness rather than just staining the tumor cells, because as we have already heard, that's not the full story. That's not so easy for me to admit that our German friends have contributed something very substantial, and that's the ADAPT series of trials where they could show that when we actually individually assess the endocrine response of a given patient, then these patients can be spared chemotherapy. And that's relatively easy because you just give a short course, 3 to 4 weeks of an aromatase inhibitor, for example, or maybe together with OFS in young patients, and then you can really spare many, many more patients than we did so far chemotherapy. And even the usually conservative St. Gallen panel already 2 years ago endorsed this and said, well, that's a good idea to do such an assessment. And I'm just showing you where this leads to. 2 months ago, we started in my country this trial, so that's neoadjuvant chemo versus neoadjuvant endocrine. That's essentially the crunch question of sparing the next subpopulation of patients the chemotherapy. However, we are doing this after testing the endocrine responsiveness, and by the way, under the protection of avoiding patients with circulating tumor DNA in their blood. And we have another trial just started 2 weeks ago, ABCHG 63, comparing the most modern combination, that's a SERD versus CDK4/6 inhibitor versus traditional approaches. Now, for the endocrine treatment in itself, it's important to know that AIs are better, but modestly better than tamoxifen. And that's obviously the majority of this data comes from the postmenopausal treatment. And we usually extrapolate everything to younger patients. I think that's one of the purposes of our conference here, to identify that might be a problem, and I will address it also with the duration question. Because one of the things we struggle with still, with all the advances in luminal breast cancer, is the long-term risk. And to me, and you have very kindly mentioned some of my research career, but that's an unresolved mystery, because we know, and this is really pretty well established by Hongxia Pan and all our collaboration with the Oxford process, even after 20 years, the annual relapse rate will depend on the initial stage. Now, the biological question is, how does the dormant tumor stem cell, after 20 years, remember that it originated from a, let's say, 5 centimeter tumor with 5 positive nodes? How does this work? How is that risk increase preserved in the memory of the enemy, so to speak? I think there's a lot of things we need to do. You know, again, postmenopausal, because the risk persists, we increase the duration of treatments, and there is quite a number of trials, and you can see it comes down to risk assessment, and I'm going to focus on this also for younger patients, because when you don't have highest risk, and I realize that you will see different stages of the disease in India than I do in my country, but when you don't have the highest risk, that extension might not be necessary. And we studied this in ABCSG 16 that was published in the New England Journal of Medicine, 7 versus 10 years, and there was no difference. So if you intensify, escalate, increase the duration of treatment without the good cause, then we are actually doing harm, because these patients will suffer more fractures than those with shorter durations. And that's even true for node-positive patients, and St. Gallen has basically adopted that concept. So the conclusion of this is that our individualization also of endocrine treatments, escalation or de-escalation, must follow an individualized risk assessment. And now, these days, everybody at increased risk is discussed for a CDK4/6 inhibitor based on the most recent updates of the monarchE trial and the NATALEE trial. And let's not forget, there is other CDK4/6 inhibitors, the DONA-A from China. Our American friends kind of hit that in a secondary session at ASCO, but it's an equally big trial than our Western trials, I have to say. And St. Gallen panel was very clear. Do not give an indication for adding a CDK4/6 inhibitor based on what the companies would like you to do, just the inclusion-exclusion criteria of the trials, but look for, as accurately as possible, assessment of the individual risk. Because, and that's, I know it's trivial, but I sometimes try to remind myself about the relationship between a hazard ratio we look at, the relative benefit, and the absolute benefit. So let's assume now we have an excellent treatment in the adjuvant setting, hazard ratio of 0.5. That is wonderful. When you apply this to a population of patients with an underlying risk of 50%, and you cut away half of the risk, that means an absolute benefit of 25%. The very same, on the right side, the very same risk reduction of 50% applied to a lower risk patient population, let's say 90%, 10-year survival, only gives you a benefit of 5%. So just because the absolute benefit is small doesn't mean that it's not there. It is all based on the underlying risk. And I think when we have now seen, and personally I consider this spectacular, in Berlin at the ESMO meeting, the first overall survival analysis of the monarchE data was presented, and that showed a statistically significant difference in overall survival. And that's quite significant, because in the whole history of luminal breast cancer, actually we have seen this 3 times. Number 1, and most of you are too young to remember, was tamoxifen versus nothing. That gave a statistically significant overall survival benefit. Number 2, letrozole versus tamoxifen in 2-arm comparison of the Big 198 trial gave a statistically significant. Everything else, we never see an overall survival benefit. And why is that? Because the prognosis of our patients has become so good with multiple line treatment for advanced breast cancer that overall survival difference that starts, it's just fading away, usually, not in this trial. And personally, I believe that's pretty reassuring, because what you can see here, that's now 7-year results, and it's a 2-year intervention. And as you know, I'm a surgeon by training. So what we change in the beginning of the patient's journey is maintained in terms of benefit long term. Now, I personally believe that's very reassuring for the whole concept of primary treatment. We also saw updates on NATALEE for balance, 3 years of ribociclib, not yet a statistically significant overall survival benefit, but everything pointing towards that direction. And the very same reassuring observation, 3 years of treatment, now everybody is off treatment 2 years, and that difference in these curves is still there. I believe that's actually a very positive result. And then you ask the St. Gallen panel a tricky question. So that's a patient with lobular breast cancer, someone whom we usually don't like to treat with chemotherapy. but 6 positive nodes, so by any regard, that would be considered high risk. What do you do in terms of escalation? And as you can see, the St. Gallen panelists said, well, we would like to add a CDK4/6 inhibitor, at least half of them. We have no data whatsoever for that concept, substituting the chemotherapy with the CDK4/6 inhibitor, and unfortunately we'll have to wait for trials such as the ADAPT cycle. That's probably 2 more years when we're going to see whether that concept works. Ahead, I think there is research coming showing us additional subtyping of luminal breast cancer. Just one example, in Nature Genetics, the Fudan group published a suggestion of 4 different subtypes of hormone receptor positive breast cancer. And they claim, and they are currently checking that in their Fascinate series of trials, that there is some subtypes that would particularly benefit from a CDK4/6 inhibitor, and some subtypes, SMF4, that would even by this multi-omic approach be defined as benefiting from the addition of immuno-oncology, meaning a checkpoint inhibitor, which we don't usually use in hormone receptor positive breast cancer. Now, for premenopausal patients, and I know that there's different treatment cultures also in the different regions of the world, but please consider ovarian function suppression. And when you look at the joint analysis of soft and text, and I was honored by the invitation of ASCO of this June to commenting on the oral abstracts in the breast cancer session, and you see these are fantastic trials, soft and text, 15-year results, and you see, yes, there is benefit. Still, after 15 years, distant recurrence-free survival, even over survival, but it's modest in size, 1.97%. However, when you look at the risk, you have the same observation that I already alluded to. Almost no benefit for the comparison AI versus tamoxifen for the low-risk patients. Almost no benefit for intermediate-risk patients. And the whole total benefit is driven by the high-risk patients. So risk assessment matters. And when you translate this, for example, grading, grade 1, not much of a difference. Grade 2, not much of a difference. Look at high-grade tumors, and all of a sudden, the breast cancer-free interval in absolute numbers is improved by 12%. I mean, that's quite significant, but the whole difference based on grade is driven by the high-grade tumors. Young age, absolute high-risk factor. You see the benefits from OFS in patients below the age of 35, and you see that even translates into overall survival difference. So just adding the ovarian function suppression brings you 10% absolute. Adding the combination of OFS and an aromatase inhibitor gives you another 5%. So now we are up to 15% benefit in these very high-risk patients with breast cancer below the age of 35. And ovarian function suppression is also important after chemotherapy. So that's the Korean ASTRA trial. They randomized patients after chemotherapy. When they regained their ovarian function, menstruation was regained, and then they had either ovarian function suppression or not. And when you do that, actually you can see that long-term at 10 years, you see a difference of almost 8%. And again, this is driven mainly by the high-risk patients. So these are all young patients, all have chemotherapy, they regain their menstruation, and then they should get additional ovarian function suppression for 2 years if they are high risk, because that gives an absolute benefit. Now, do we have to use an expensive multigenomic assay such as Oncotype or others? As you can see, the St. Gallen panel is totally split on this. 50% of panelists will say, yes, you need to do that, I do it every day. The other ones say, if you have high quality pathology, I will freely admit I'm in the latter category. I rarely use a multigenomic assay because when I look at Ki67, that's equally good if you have a good pathologist. So to summarize the endocrine message for young patients, for low-risk patients, good old tamoxifen alone is still an adequate treatment. If you have some signals of risk increase, then consider adding ovarian function suppression or NAI. And for high-risk patients, And usually these patients will have chemo anyway, but then also add ovarian function suppression plus an aromatase inhibitor because that's the most effective treatment. And when you look at some additional arguments for the ovarian function suppression, these are all trials, but these are all endocrine trials where we have data on amenorrhea. And as you can see, or probably cannot see because of the small font, but all the trials where we saw amenorrhea eventually ended up with a benefit in overall survival. And there's quite a number of historic trials of endocrine treatment versus chemotherapy, and in all of them, actually, that was quite similar. And it's really a mistake that our American friends usually quote the RxPonder trial and saying, well, that means young patients need chemotherapy. No, that's not true, because they didn't have adequate endocrine treatment. And even the next analysis of RxPonder by my friend Kevin Karlinski, when you look at age and you look at the premenopausal patients at 50, there is no benefit. And why is that? Because you cannot suppress their ovarian function any longer because it's already in natural menopause. And when you look at anti-Mullerian hormone, as they did, you see that the true benefit of chemotherapy in younger patients comes from the side effect of ovarian function suppression. And we can do this more elegantly without blowing away the hair of our patients. I'm truly convinced. However, the final verdict on this question will be given by ongoing trials, such as the NRG trial, where it's plus minus chemotherapy in the presence of optimal endocrine treatment. And that's what I suggested at my ESCO discussion, like a graphical escalation for young patients. So if there is low risk, tamoxifen is good enough. If the risk increases a little bit, start considering changing that to an AI. That means for the majority of young patients adding an ovarian function suppressant, LHRH analog. And then we would like to add as a next step the CDK4/6 inhibitor in the absence of clinical trial data. We'll have to wait for the ADAPT cycle for that. And as the last resort, actually, I would add chemotherapy, and I treat quite many young patients without any chemotherapy if they fulfill those criteria of risk assessment I'm talking about. Let's not forget about the side effects. Obviously, the endocrine side effects can be very cumbersome for some patients, particularly when you use ovarian function suppression. So hot flushes is a huge problem. And it's important that we address this because particularly in younger patients, that's excellent real-world data from our French colleagues published earlier this year, when you have to interrupt your treatment or patients stop the treatment, particularly for the very young, this directly translates into a disadvantage in terms of disease-free survival. So keeping our patients on treatment is an important goal, and it might have become easier because just, I think 2 weeks ago, the FDA approved, based on the OASIS 4 trial, neurokinin-targeted treatment, elinzanetant, which is a new class of drugs that in patients with severe hot flushes can actually reduce that by 80% within several weeks, and it's apparently safe also in breast cancer patients. Now, in closing, a brief outlook into the future. I believe SERDs are the next generation of endocrine things, and that has changed. Like 10 years ago, people were saying that was it with the endocrine treatment of breast cancer. We have AI, we have fulvestrant, no further development. Well, there is now SERDs, PROTACs, CRNs, 50 drugs in clinical development just for anti-hormonal intervention of breast cancer. Quite a number of trials, more than 20,000 patients in these trials, evaluating imlunestrant, camizestrant, all these SERDs that are just approaching the treatment in the metastatic stage, and it apparently will be hopefully not only better efficacy but also better tolerability, because as it appears these SERDs are better tolerated, particularly with fewer hot flashes and all these things, and that's why we use them also in our most recent generation of clinical trials. What I believe will happen is that we are going to use circulating tumor DNA, as I keep calling it. That's the early traces of the enemy in plasma, and I have played around with circulating tumor cells. That unfortunately doesn't work reliably, I have to admit, after decades of doing research, but I think ctDNA is here to stay. We are already using it in advanced stage for identifying mutations and actionable targets. And we are now moving to the early breast cancer setting. So clearance of ctDNA, using it as a prognostic tool. Look at this data from I-SPY, whether there is no ctDNA, very little, a little bit more, or that's really good prognostic separation of the I-SPY population. So I believe that technology is going to be used a little bit more. The St. Gallen panel even suggested, well, if you have a positive MRD test, then you should treat on that. I think it's a little bit too early for that because we need confirmation that we actually can do something in intervening earlier, and there might be discussion about SERENA-6 later in this conference, so I'm not going to dwell into this. But this is data from monarchE, for example, ctDNA, excellent prognostic discrimination between low risk or relative, this is all high risk patients, but lower risk and very high risk. However, we need to observe ctDNA describes the risk early on. So it's all in the first 2 years. When you look at these curves, you see after 2 years, nothing more. But that's also reassuring. Remember, we can change something in the beginning. So if we can eradicate that subclinical generalization, for example, with our neoadjuvant or adjuvant treatment, then I think we have a good chance that our patients will benefit long term. So with that, I think working together, as we try to do also in the foundation, is the concept for the future. This is one of my favorite paintings, self-painting of one of my patients, and we all should always keep our patients in the center. I have a wonderful team to whom I'm immensely grateful, and I would hope to see many of you in Vienna in March 27 for the next edition of the St. Gallen International Conference. Thank you very much again for inviting me.
Michael, I was told I have to ask you some questions. Thank you. Fantastic presentations, always very clear, very scientifically and clinically profound. Jeff, you just told us that you did some research on CTCs, and now you believe more on ctDNA. But for the long-term relapse risk, if I'm not wrong, one of these papers are from Saparano, where patients who had CTCs after 5 years of finishing the endocrine therapy, adjuvant therapy, those were at higher risk for relapse long-term. So the dormant cells, do they have ctDNA available? Not? What do you think?
Yeah, Luis, as always, you will ask the trickiest question. I'm not saying CTC is not a good thing. I mean, we did a lot of research. The problem is that when we say CTC, we mean basically cytokeratin positive cells in the periphery, and they have many sources. So analytically, that has not turned out to be a very reliable method, I'm afraid. So I see patients where CTCs pop up and they never have a relapse, and I see other patients who will show up with metastasis and there is no CTC. I agree with you. The same may be true for ctDNA. We are still waiting for the data. It appears, however, that with these ultra-sensitive methods, I think there is now early indication that the awakening of the dormant, whenever that happens, at least that's, as I know, your and my concept of relapse, that it might occur at a very early stage, that there is some shedding of ctDNA, probably before we can see actually cells traveling around.
Thank you.
So thank you, Professor Michael, for a wonderful talk. My name is Hemant Malhotra. I'm a medical oncologist from Jaipur. My question is, do we have a handle on how long to give the ovarian suppression? 2 years, 3 years, 5 years?
Excellent question.
And what about the perimenopausal patients? Do they need ovarian suppression or do they not need?
Positive, node positive?
Node positive, yeah, high risk.
Yes. That's an excellent question. Again, the duration of endocrine treatment has been extrapolated from postmenopausal patients. There is absolutely no reason why 5 years would be the standard. We just took that from the postmenopausal, and you may remember trials such as the Austrian trial number 5 or number 12, where we used 3 years instead of 5 years. And I believe it's particularly for the younger patients, it's also good to get out of our patients' lives for all kinds of reasons. So I do 3 years a lot, particularly for patients who are suffering when they do not have very high risk. With respect to your node positive question, I am treating patients with limited nodal disease, let's say 1 or 2 positive nodes, without chemotherapy, just endocrine, including OFS, since 25 or 30 years, without damage, because I think that nodal status is more or less an indicator of the time of the diagnosis rather than of the biological aggressiveness. Now, having said that, that's obviously not true in every single case. We all know 5 millimeter tumors with 10 positive nodes, high grade, high proliferating disease. That's an indication for adjuvant chemotherapy. But if you have a patient with high receptor content, grade 1 or grade 2, low proliferation, just because there's 1 or 2 positive nodes, in my center doesn't trigger adjuvant chemo. We will treat these patients endocrine only.
Thank you, sir.
Thank you, Michael, for that wonderful talk. I think in the interest of time, we'll have to move on, and we can have more questions and discussions during the tea break.
Thank you, sir, for your wonderful insight on the endocrine therapy. Now we'll begin our session 1 on epidemiology and risk factors. I would like to invite the chairpersons for the session, Dr. Luis Costa and Dr. Amit Singh. Thank you.
Okay, so my pleasure, honor to be here sharing this session together with Dr. Ashok, and also a big honor to introduce Professor Jens Huber from St. Gallen, Breast Cancer St. Gallen Center. He's part of steering committee of the Comprehensive Cancer Center in Switzerland, and he does a lot of work and research on breast cancer. One of the experts in the area in Europe, definitely. He's going to talk us about breakthroughs in young breast cancer treatment. So let's go hear about treatment in young women.
So, dear Chairman, dear colleagues, it's a big pleasure to be here. So thank you so much for this invitation to this wonderful conference. And, well, also thank you for this exceptional hospitality. So the title of my talk is Breakthroughs in Young Breast Cancer Treatment. And basically, I would say that practice-changing data we do see across all ages. But there are some specialties and special situations in young breast cancer patients I would like to focus on during my talk. So it starts with the definition, what is young breast cancer patient? And probably the definition of young is also dependent on what our own age is. But, you know, for the medical reason, definition of breast cancer young women is below 40 years. We know that in these young women, the incidence varies in different regions of the world, and for Western European countries, roughly 5% of all patients are these young women with breast cancer. Usually these tumors are more aggressive, triple-negative breast cancer and more HER2-positive breast cancer, and we see more frequently BRCA-positive situations. So what are the challenges in young patients with breast cancer? So cancer is not associated usually with younger age, and this may lead to a delay of diagnosis because it's not expected that a young patient or a young woman has breast cancer. We have a different psychosocial situation to older patients. Women are in a family with young children, or women have no children, but they wish to have children. I'll come back to that later. It's a burden for partnership, or patients have no partner or no committed relationship yet. And I think body image is important. Body image is obviously important across all ages, but probably it's more important in younger women. You know, when you have a mastectomy, you're looking for a partner. So this is quite a challenge for young women. Also, you're in a professional activity when you're young. Maybe you're planning a career, and suddenly you are facing a breast cancer disease, having chemotherapy, having endocrine therapy, with all the side effects we heard from Professor Michael Gnant. So fertility and premature menopause is an issue, and we heard about the side effects of endocrine therapy influencing on sexual health. So what about the biology of breast cancer in young women? We know it's different. These are data from the US, and you see that in young women we do have less luminal A tumors, and we do have more triple negative tumors, also somewhat more HER2 positive tumors. And what we also seen is, with regard to prognosis, and this was a kind of surprising to me, that compared to older patients, the prognosis is especially worse in young women in the luminal A-like tumors, not so much in the HER2 positive or in the triple negative tumors. And this is the hazard ratio for mortality in patients with 40 years or less, compared to a reference population between 50 and 60 years. And you can see that in the luminal A tumors, the hazard ratio mortality doubled in those young patients below 40 years. This was not the case actually in the HER2 positive and in the triple negative breast cancer patients. And just recently this has been published in the ESMO Open a year ago, and the observation were quite similar to the US, that in an Asian population, either Asian population in the United States or also Asian population from a Korean group, showed that there are less luminal tumors in those patients who are young and more triple negative and also more HER2 positive tumors. And quite similar to the observation which have been shown by the US observational trial, again, in these young women, compared to women between 40 and 50 years, the prognosis was less favorable in the hormone receptor positive, HER2 negative situation. So this brings me to the adjuvant endocrine therapy, and I think this is really crucial. It's very important that we are giving endocrine therapy to our young patients with breast cancer. It's sometimes working better than chemotherapy, and these are quite old data from the IBCSG, published in 2006, comparing in young premenopausal women, node positive, hormone receptor positive, chemotherapy versus chemotherapy followed by tamoxifen, and you can see that they are doing distinctively better when they have tamoxifen in addition to chemotherapy. So what about local regional treatment? And these are international consensus guidelines for breast cancer in young women, which have been published in 2022 in the Annals of Oncology, and it's basically the same as in older patients. So surgical treatment of young patients should in general not differ from that of older patients. And the same with radiotherapy. Indications for adjuvant radiotherapy are the same as for older patients. And very important, indication for post-operative radiotherapy are independent of the BRCA status. This may be different in patients with ATM mutations, or in particular in patients who have a germline p53 mutation, but in BRCA mutation, you should have the same principles in radiotherapy. So this brings me to the BRCA mutation, which has been seen more frequently in younger patients. And these are data showing that the rate of a contralateral breast cancer event is distinctively higher in those patients with a BRCA mutation and also with a PALB2 mutation. And the 10-year cumulative incidence for a contralateral breast cancer is between 30 to 40%. And this led to the recommendation of the St. Gallen Consensus Conference already in 2023 to discuss a risk-reducing mastectomy in patients with a BRCA1 or BRCA2 mutation, in pre- and postmenopausal women, and also in addition in patients with a PALB2 mutation, in particular those who are premenopausal, and in particular those who have an estrogen receptor negative tumor. And this led also to reflect the recommendation in Germany by the HGO, which are recommending to consider a prophylactic contralateral mastectomy in patients with breast cancer and with a BRCA1 or 2 mutation, because it reduces breast cancer incidence and it also reduces breast cancer mortality. However, I think this is very important. The indication for risk-reducing contralateral mastectomy should consider age at onset of first breast cancer in the affected gene. I think this is very important. And basically, it's the same with patients or with women who are healthy but who have a BRCA1 or 2 mutation. You should consider risk-reducing bilateral mastectomy because it reduces the incidence, and at least for BRCA1 mutation, it also reduces the mortality. So what about systemic adjuvant therapy? And I think it's basically the same as in older patients. And if you look at the triple-negative breast cancer scenario, stage 2 and stage 3, we usually give neoadjuvant therapy with carboplatin, paclitaxel, EC, and immunotherapy with pembrolizumab based on the KEYNOTE-522 trial. And we give post-neoadjuvant treatment according to the response to the neoadjuvant treatment. The situation is somewhat different in triple-negative breast cancer stage 1. I think the optimal treatment needs to be determined. And probably we are doing an over-treatment of a substantial amount of patients with triple-negative breast cancer, also in the young patients. And we do have some very nice data from the colleagues from the Netherlands that if the TILs are very high, even young patients have a very good prognosis with triple-negative breast cancer in stage 1. And you may need not much or even no chemotherapy in those patients. What about HER2-positive stage 2 and 3? It's the same with older patients, also for younger patients. We are using neoadjuvant therapy with chemotherapy and dual blockade. And again, the post-neoadjuvant treatment will be tailored according to the response to the neoadjuvant treatment. In HER2-positive stage 1, surgery first, then if after surgery it's still a stage 1 disease, we give 12 times paclitaxel combined with trastuzumab, the so-called Toleni regimen. With regard to systemic adjuvant therapy in the hormone receptor positive situation, you already heard all the data from Michael Gnand. Endocrine therapy is of utmost importance in those patients. LHRH analogs in the high-risk populations are very important. And the chemotherapy should be tailored according to the risk assessment, which may also include a genetic assay. Another important topic is if you have a BRCA mutation, using olaparib as an adjuvant treatment. We have the wonderful data of the Olympia trial showing not also better disease-free survival, but also showing a better overall survival, giving olaparib in those patients with the BRCA mutations as adjuvant treatment. And maybe we do not have the data of the adjuvant setting, but this may be also true for PALB2 mutations. We do have some very interesting, promising data in the metastatic setting. We probably will never have an adjuvant trial in patients with PALB2 mutation, but it seems to work very well also in patients with a PALB2 mutation. Okay, so what else? In particular, I would like to focus on a trial which has been shown at the ESMO meeting quite recently. which is in particular important in countries where the financial resources in the healthcare system are not so well funded. And in this trial, patients were also neoadjuvantly treated with chemotherapy in addition with immunotherapy with triple-negative disease. However, the pembrolizumab was given only every 6 weeks, and it was given with a much lower dose with only 50 milligrams. And actually, the comparison to no immunotherapy was quite similar to the KEYNOTE-522 trial, giving a much higher PCR rate using this immunotherapy with reduced dose and with longer intervals, and which makes this much more less expensive. This is certainly not a proof, but I would say it's a signal which tells us that we may also use these drugs in a modified way in patients where the healthcare system is not so well funded. So finally, I would like to focus on the positive trial, which is something which probably influences our clinical practice with young breast cancer patients. We have seen an update of the positive trial at the ESMO meeting. In the positive trial, more than 500 patients with up to 42 years of age were included. They had hormone receptor positive disease. They had a wish to become pregnant. And after 18 to 30 months of adjuvant endocrine treatment, they interrupted endocrine treatment with up to 2 years to allow for conception, delivery, and breastfeeding. After that, they were supposed to resume endocrine therapy to complete it to 5 to 10 years. Primary endpoint was breast cancer-free interval, and secondary endpoint are distant recurrence-free survival, pregnancy outcome, offspring outcome, and adherence to treatment. So what you've seen now at the ESMO meeting is a median follow-up of 71 months. And maybe when you look at the patient population which has been included in the positive trial, it's basically a low-risk population. Half of the patients had stage 1 disease, half of the patients had stage 2 disease, so very, very few patients with stage 3 disease. And the data for breast cancer-free interval were compared to a matched control population of the SOFT and TEXT trial. And you can see that the breast cancer-free interval was basically not different to this matched population. So what about pregnancy? Of the 497 patients who were evaluable, 76% reported becoming pregnant at least once. 91% had at least one live birth. Of the 589 pregnancy, 67% were full-term and 5% were preterm deliveries, with a total of 402 live births and 440 offspring. The most frequent complications of pregnancy was hypertension in 2.5% of the patients, and 8.6% of offspring had a low birth weight, and 1.8% had birth defects, but fortunately, this is similar to women who did not have a previous breast cancer diagnosis. So to sum up, in breast cancer in Warmingen, we have a worse prognosis. We have it especially in the luminal tumors, not so in the HER2 positive or triple negative tumors. Local regional treatment is in general not different to that of older patients. And systemic treatment is actually also in general not different to that of older patients. But we have to take into consideration fertility, premature menopause, and also the side effects, which could be very bothering and influence on sexual health and other factors of quality of life. And BRCA mutations are more frequently seen in young patients. This may influence our local and systemic treatment, and it's important, that we think to test those young patients so that we know they have a BRCA mutation or not, because it influences not only surgery, but it can also prolong life when we're using olaparib in these patients. With that, I'd like to finish, and thank you for your attention.
Thank you. We are a little bit behind the schedule, but I think we have time for one question in the audience, if you want. Yes, please.
So for the hormone receptor positive patient, we know that we have to finish the chemo first and then we have to start the endocrine therapy. So is there solid data to this effect, or can we do chemo and endocrine therapy together?
Well, it's a good question, and in the soft on text trial, treatment with an LHRH analog was actually started from the beginning on, together with chemotherapy, but using later on tamoxifen or an aromatase inhibitor, you shouldn't give it in addition to chemotherapy, but give it later on after chemotherapy has been stopped. So this hasn't been changing all over the last years.
Yes, last one.
I am Professor Bhattacharya from Calcutta. I just wanted to know that in young patients after chemotherapy, they remain in clinical menopause, but on testing biochemically they are premenopausal, and even after giving goserelin or leuprolide or pamorelin, biochemical monitoring always shows they are premenopausal. So does it affect the treatment? Should we go for ovarian suppression by surgery or radiation therapy in such cases, those who are clinically menopausal but biochemically non-menopausal?
Well, we know that LHRH analogs are working in most of the patients, premenopausal patients, but we also know that there are some patients we cannot achieve sufficient ovarian function suppression with LHRH analogs. And then we have to decide if it's a high-risk situation, probably you may remove the ovaries. If it's a low-risk situation, maybe you just stick to tamoxifen alone. So it depends on the situation. But usually it's not frequently seen, but there are a few patients, LHRH analogs are not working that well. So
biochemical monitoring you recommend to continue, or it should be redundant?
Sorry?
Biochemical monitoring of FSH, LH and estradiol, do you recommend for your patient regularly at least 6 months?
Usually not, actually. I mean, this is a controversial issue, and there were some data from the SOFT-S trial. They were monitoring estrogen levels, and they've seen some patients with rising E2 levels, but actually it's not recommended to do a biochemical monitoring. I think it's enough, at least enough to do a clinical monitoring, and when your patient tells you suddenly, oh, I'm feeling better, my hot flushes are going away, so maybe you should go for also biochemical screening and then look if it's really sufficient. And so in my clinical practice, usually I start, if I take an LHRH analog, I start with a 4 weeks depot, and only later on, when I'm sure that the suppression of the ovarian function is really solid, then I may change to a 3 months depot.
But very good comment. I like it, this one. I'm in favor of that too. Thank you so much. Thank you so much, Professor Uber. Thank you. I think you have to. Thank you so much. So it's my pleasure also to present Dr. Sunan Gupta. He's director of Metro Cancer Institute. He's going to talk us about an important topic, which is immunological insights into young breast cancer. Nothing better than a man that knows about bone marrow transplant to talk about that.
Thank you, sir. And it's an honor to be here with such distinguished people. So today I would like to speak something on the immunological insights into young breast cancer. We have been discussing this topic for the morning. We have understood how different it is from the breast cancer. So if we talk about breast cancer, as we discussed with the previous speakers also, it is a predominantly disease of the elderly, and less than 40, which is by definition what we call as young breast cancer, makes only 5 to 7%. But if we come to the Asian data, the data from poorer countries, LMIC countries, this percentage goes up to around 25 to 30%. So it is a real world challenge for all of us. Expression of key biomarkers, including endocrine receptors, HER2, and proliferation markers, appear to be different in younger patients, and this becomes challenging. Whether the treatment should be same for all the breast cancer, or age makes a change in our target for the breast cancer treatments. So this is another slide which shows the same thing. Azim et al. In 2012 tried to characterize it into the 4 types, which we usually do, the luminal B, HER2, and the basal. And most of these studies have found out that as the age advances, the pie changes. So from something where you have a more of luminal A, B in the elderly population, you get a more of HER2 enriched and a TNBC in the younger population. So this definitely shows that immunology of breast cancer is different in different age groups, and it is not a simple bucket of disease which is same across all the age groups. So the pathological features. So one of the studies also tried to ascertain the pathological features in early breast cancer, and they found out that in less than 40-year subgroup, the median age of diagnosis was 36 years, and majority were ductal histology with grade 3 aggressive tumors. So this comes to the biology part. The node positivity disease rates and the multifocality was observed to the tunes of 50 and 27% respectively. 1/3 of the patients were ER negative, while 1/4 were HER2 positive patients. This study further demonstrated high rates of LVI and lymphocytic infiltration in tunes of 34 to 24% in the respective subgroups. So definitely a different histology, a different molecular markers which are seen in our young breast cancer patients. So coming to the molecular profiling, which was tried in various studies, so the point mutations have been observed in TP53 and PIK3CA in around 1/4 of the patients. Germline, we all know, is one of the most common BRCA1 and 2 mutations, which we always knew is much more common in the younger population, is something in tunes of 40%. And another interesting mutation was the CHEK2, which is another germline mutation, which is again more common in the younger population. So the younger population has a different profiling, a different genetic signature, and a different clinical outcomes and signatures. So coming to the immunology and immunotherapy, the immune system plays a dual role in the breast cancer development in progression and treatment. Young breast cancer naturally induces an adaptive immune response containing TILs and express a higher PD-L1, and both TIL content and PD-L1 expression may vary from major clinical subtypes. So if we see the PD-L1 positivity only on the left side, the TNBC shows a PDL positivity of around 30% as compared to around 2 to 5% in the luminal A subtype. So which is quite different from what we see in the normal clinical scenario, especially in the elderly subgroup. So lymphocyte predominant breast cancers are breast tumors with stromal or intratumoral lymphocyte that accounts for 50 to 60% of the tumor tissue. The presence of TILs at diagnosis confirm both prognostic and predictive information regarding the subtype, and presence of stromal TILs at diagnosis is again a prognostic for TNBC in HER2, but not for luminal, as we discussed in the previous talk. 15 to 20% improvement in disease-free survival was noted for 10% progressive stromal TIL increase. So TILs are a very, very important prognostic marker as in young breast cancer. Another thing which was very interesting was the peritumoral and intratumoral FOXP3 plus Tregs in patients with breast cancer. So this again is a marker which is being studied in depth, and this showed that peritumoral Tregs were sensitive to chemotherapy and associated with higher rates of PCR, whereas intratumoral Tregs are independent prognostic predictor in patients with breast cancer. So the Tregs is something which we have been studying for last 15 to 20 years. It started with sarcomas more so. I remember from my residency days, there were a lot of work on Tregs, on FOXP3 in sarcomas, but in breast cancer, this is something which is different. And now we are trying to understand that intratumoral or peritumoral Treg expression is also leading to different outcomes. So this is something interesting. Coming to the topography of immune system, individual tumors are generally classified into 3 immune landscapes now. So we had the first pathological classification where we talked about ductal, lobular cancers, sarcomas of the breast. Then we came to the luminal subtype, luminal A, luminal B, enriched, and the TNBCs. Now we'll be talking about something which is a different thing. So they are immunologically active, immunologically quiet, and immunologically excluded. So right now it is more of an educational debate, but I think with the time how the immunotherapies and immunological agents are coming in, this will in future might be something which is new. The microenvironment, as we all know from the days of myeloma research, is again an immunological landscape and will be critical as usual in formation, progression, and maybe in the treatment of breast cancers also, especially the triple negative subgroups. So coming to just a small thing, breast cancer has definitely evolved. We used to be on TNM, we used to decide how small, big, deciding on chemo, radiation, surgery. I think now we'll be going to profiling, and this thing will again make better success rates in our treatment, as this will identify subgroups. Like we just discussed that even a luminal A can be divided into 4 subtypes. So it is not that simple that all breast cancers will be only now less than 2 centimeters to 2 to 5 centimeters as we have been trained in the past. Another thing which we have been talking on and off today morning is CTCs. So CTCs in luminal A, luminal B, we definitely knew that CTCs or ctDNA is upcoming. But with the EMTs, the epithelial mesenchymal transformations, and the data that these triple negatives, which are more common in younger age group, sheds a much better quality of CTCs. So I think in the young or the immunologically active breast cancers, CTC will be something which we'll be more looking forward to, not only for diagnosis but also as a tumor marker for the evolution of disease process. So the most important thing which has come in the last 10 years has been from immunology to immunotherapy. Now we have many robust drugs which have come up, especially in the TNBC scenario. We started with atezolizumab, pembrolizumab, and I think in future next 2 to 3 years, most of the available immunotherapies will be showing response. The most interesting part of breast cancer is that from metastatic now to early breast cancers in a neoadjuvant setting, the immunotherapy has definitely shown its presence. So I think immunology, immunotherapy, this is like something from bench to bedside, and it will continuously evolve. But younger breast cancer patients are someone who will give us a better topography, a better landscape, so that these studies will be more interesting, because we already know this is some subgroup which is going to do poorly, and we have to be all out to treat these cancers. These are some of the trials, the phase 2, phase 3 trials which are going on in metastatic, neoadjuvant and adjuvant setting. We are also talking about vaccines along with docetaxel maintenance, which is in a phase 2 study. So a lot of things which is going to come up in the next few years. And I think if we talk about the conclusions, or I like not to call it conclusions, it will be more of a future of our thing. The immunology of young breast cancer is characterized by the specific subtype, a more aggressive disease profile, and a unique immune response. The immune cell roles will be from pro-tumor, like certain immune cells such as regulatory Tregs or the MDSCs, to something of the anti-tumor activities which will help in control of these cancers. The therapeutic implications are going to be phenomenal. We have immunotherapies, are going ahead with combination therapies, and above all, we have certain very interesting biomarkers in this subgroup, because more than treatment, I think early identification and response to therapy is something which will help us. So immunology is here to stay, at least in this particular subgroup. Thank you for your patient listening.
I think we have time for one question from the audience. No question? So I have one, just one.
Sir, if I may not be the right person to answer.
No. I loved the way you presented these Treg cells in the microenvironment as an important role regarding immunosuppression.
Sir.
Do you think these Treg cells are more present in the luminal tumors compared with the triple negative or the HER2, because they do not respond so much to...
Conventionally, Tregs have always been found to be more in certain subtypes like the non-luminal subtypes.
Okay.
So those were the aggressive breast subtypes. If we go to the history also of the tumor, Tregs, we started in osteosarcoma and other tumors. So this is more of a sarcoma-like behavior, which we see more in TNBC subgroups, sir.
Okay. Thank you. So if no further questions, thank you so much.
Thank you, sir. Thank you for the honor.
Rakesh? Or myself? Is Rakesh Kumar? So, it's now we are in trouble. I'm going to present Rakesh Kumar. Okay, I would say, a very personal note, Professor Rakesh Kumar is a great friend that I met in 1992 when I was in my mentor at Penn State. And I I realized how important he was for Dr. John Mendelsohn at his time at Sloan Kettering and later on at MD Anderson. He did a huge number of discoveries. I respect him very much as a scientist and as a friend. He's a hard worker. He can put you work all night, with emails and things to work and to perform. And really he's the man that can do the things. And he's the person that really, because of one conversation during the night, because with a chat that I had with a patient, he decided to create the foundation. And if you have the foundation, it's because Rakesh Kumar is a professional capable to do it. And yes. Okay, so I think he's the right person to tell us about scientific vision of this program. Thank you.
Thank you, Luis. So we are running behind the time, but I will still like to share the message I really wanted to share with you. We learned a lot of good things this morning in terms of treatment, but I'd like to go on, what can we go beyond treatment? How can we really interfere with the process of progression, this rise in the breast cancer? So for that, I would just like to start how we started the foundation very quickly. There were two individuals in my life, they were behind the idea. One is my colleague and his patients. He had a patient, she has been asking, Luis, why me? I have no family history. I'm fine, I'm young, I'm fit, but still I got the cancer. So this was, and the second individual is sitting right there, Sunil, Dr. Sunil Saini from Dehradun. He has been telling me same thing in a different way. So these are the two individuals which really motivated me to retire formally in 2022 and create a different kind of foundation. There are hundreds of breast cancer foundations. It's a very crowded area. So what can we do different from others? So we created a US-based foundation focused on young breast cancer. This is the first such foundation in the US and globally. We have a different approach and you will see it in a minute. We are a team of pioneers in medicine and science, supported by breast cancer survivors, advocates, and their families. Our core material is in 13 different languages, and we have survival stories in 6 different languages. The Pink Ribbon has done miracles in terms of bringing awareness of breast cancer globally and has really saved millions of lives. But we as a group believe that Pink October or the Pink Ribbon is more of a commercialized vehicle right now, and Pink Ribbon does not capture the full challenges which are faced, unique challenges faced by the younger women. So there was a need to create a new logo, a new ribbon. So we created the Pink Purple Ribbon. We worked through the friends and partners in 29 different countries, and we are very proud of that. And we have initiatives which are not there in other foundation, including Susan Komen Foundation. So I'm not going to go into the details of what's really behind the story, this logo. So a story of the logo was published 2 years back in a peer-reviewed journal, and the reference is right here. Every component of this logo represents something which is unique to the young woman, as opposed to the traditional pink ribbon. So I'd like to request all of you to also start using the pink purple ribbon in addition to the pink ribbon as you talk about breast cancer. We are active in 29 different countries, and I have friends, so I'm always working on this foundation, trying to do the justice to my colleagues, to our patients, and to bring something different which others have not able to do. So now coming back to breast cancer. So this is a slide you might have seen many times, and it makes the point that globally about 10.5% of the breast cancer patients are less than 39-year-old. But in India, this number really jumps down to almost 14% right here. It's right here. And if you look at the distribution of young breast cancer, almost half of the patients are within the age group of 34 to 39, but remaining 40% are within the age group of 25 to 34. You know? And many of us believe that it is a recent phenomenon, last 3 decades, and we can trace back to 1984 when there were only 48 cases reported in India and about 1,250 cases in US. And over time, this number has really grown. Many of us believe it's a recent trend, about 1/4 of a century, and that is really not the case. If you go to the history of the young breast cancer, 3 earliest papers were reported in 1949, 51, and 56. So it is not something new. It was always there. What has happened in the last 1/4 of a century, the number of cases we are getting are just suddenly increased. So the trend is really moving into different direction. Based on the recent data, it's clear that in spite of all the discoveries, clinical trial, and advances in medicine, breast cancer will continue to grow up to 2050. For many countries, this number is different. For India, up to 2040, and for US, up to 2042 now. But for the most of the country, it will continue to grow. This projection has taken into account all the major things what are in the pipelines. In 2040, there will be turning point. It will start going down, not because of the medical advances. Rather, the percentage of the younger women between the age group of 15 to 39 is dropping down and reached to a critical point in 2040. This drop has already started 2012. We are always, so 2040 will be the critical point. Well, with time, we are likely to see this curve is shifting slowly to the left. And to my colleagues, we don't have to go into the detail, but there are protective factors and there are risk factors. By and large, almost 85% of these cases are not because of a family history or predisposed genes. So 85% of these cases are spontaneous breast cancer. And this is where we can't really change our gene, but we can definitely do something to this 85%. Well, if a younger woman has a breast cancer in mid-20s or early 30s, it was not started yesterday. This is a recent paper from my colleague, Dr. Toy, from the Kyoto University in Nature, 2 years back. And he could pick up the changes in the healthy breast tissue from 14 to 16-year-old girls, which will become tumor 10 years down the line. Using a large amount of genomic studies from different age groups, he calculated the precise age, how much it will take. So it takes about 8 to 10 years before a tumor could be clinically detected. That basically means a tumor in mid-20s or late 20s was going on for some time. And there is a good amount of data, at least 8 to 10 good publications, which are time-tested in different laboratories, indicate indeed cancer-related change could be detected in healthy breast right after the puberty. So there is a period which is really important. So the question is, why younger women are getting breast cancer? We talk about different things, and it's a polygenic disease. It's a multifactorial disease. We really cannot attribute to one single genes, except for those which are due to predisposed genes or due to the family history. There are signals which are exerted over a period of time, and especially a period from the puberty to adulthood is really important when the breast is hypersensitive to a lot of signals from outside as well as internal signals. Many times we hear in the newspaper there is a risk factor coming out every single day. If you look into PubMed, every day there is a risk factor coming out. And the number of risk factors are running in thousands. So because they are running in thousands, it creates a distrust in the society. How can we really control 1,000 risk factor every day? You know? But I want you to caution that almost 90 to 95% of these risk factors are not science supported. They are by implication, you know, and they have not been tested with time, you know. But so the majority of the risk factors, but this kind of news, this kind of information bring a distrust to the science, and people started doing their life, they are not paying attention to it. I will just show you one example. I did this Medline search last week using a simple term, breast cancer, young women, risk factor. There were almost 3,500 risk factors, publication talking about it. I just added one filter, validated, number dropped down to 187. By adding 3 more filters, this number will be less than 10. So I want all of you to know, whatever you hear in the newspaper about coming out risk factor, it only creates a fear and distrust in the society. 90% of these risk factors are by implication only, not time tested. Most of these studies are hit and run. There is no follow-up. There is nothing there behind to support it. I will only talk about 3 time-tested risk factors. We are all aware of it, birth control pills. This is the largest study, just came out about 10 days back, from 2 million women, young girls from the age of 13 to 49. 2 million over a period of time. And it reinforced the idea that the quantity and the quality of the progesterone in the birth control pills are important. No matter what kind of pills you are taking, there is an additional 24% risk. If you take the pill over a period of 5 years, the follow-up risk further increases. This study really supports the idea which came out last year from the Oxford, just reinforcing the same point. I do have a cohort of the young breast cancer survival from New York City, around 30 plus women. And what was common amongst all of them, they were all taking birth control pill right from the very early stage. Second risk factor which we are all aware of is the amount of endocrine disruptors in our personal care product, which a lot of young girls uses. There is a large amount of epidemiological data to connect these two things, but there is no cause and effect or the clinical trial ever done to support it. The first clinical trial was done 2 years back with a small number of patients, around 36, where these women were given personal care product which were deprived of all kind of endocrine disruptors. You know? And they tested all different things. They concluded, in fact, whatever we are taking in the personal care product might be a contributing factor. We all talk about that there is a shift in the early menarche. So this is one of the risk factors. But the question I am asking is, but why we have this shift at the first place? That is important. If you have a daughter who has early menarche, so it's a risk factor, one parent should be closely watching it, just like a predisposed genes or a family history. But my question as a scientist, why we are getting this at the first place? The first clue came out last year, and this is a study from NIH making a point that what is happening in the maturation of the reproductive system, reproductive hormone, LH and FSH, which we had in the earlier presentations. So something is happening in the pituitary gland, which is promoting the secretion of these hormones and creating a premature maturation of the development. So what could be the activator? Well, there is a group of molecules called nitromusk group of compounds. It's used in all kind of perfumes, personal care product. So using a model system, live model system, this group was able to show they can shift the maturation of reproductive system by these molecules. So this is the first ever reported cause and effect relationship which have been established. Obviously in a model system, this need to go into the humans. Last one, we hear every day in the newspaper, processed food and all that. This is definitely a contributing factor. There's a large amount of data which is supporting us. and simply because when you overheat the product, use certain chemicals, you create a molecules which activate inflammation system called RAGE signaling. Now, RAGE signaling means, so if you are eating the diet which is creating the molecules which activate inflammation, so you are going to have persistent inflammation in the breast and many other organs. And this is what will lead to one of the, this is from a foundation who are part of our foundation, and most of this work came from 2 different groups in the US, and it makes the point how many AGE molecules are there per 100 gram of product. So you could see it all by yourself. I don't want you to get scared, but if you look at the in the back end, it's almost 92,000 per 100 gram as opposed to 9 molecules. So persistent inflammation over a period of time will do a lot of damage. And this is one of the reasons why we might be at this point. So coming back to the point, what can we do? Well, it's now clear that breast cancer will continue to grow. There is nothing we can do at this point. What we can do, I'll be talking that. In 2040, the mean age of young women who will get breast cancer will be 33.7 in India, globally 33.6. So that means all those women who will get a breast cancer, young women, they are only 18 to 19-year-old right now. So we do have a very large window because medicine cannot fix this. These are 85% of the cases. We can't change our genes either, you know. So we do have a very large window to do something different from others. So we believe that today's 18 and 19-year-old young adult is tomorrow's woman at risk, you know. And if we could empower these young girls at a college, at an early stage, the impact it will have on her life, on her family, will be lifelong. And this is the only way we can fix the problem. And with that in mind, we created a new program where we in the foundation largely believe in empowerment in a structured way, not in a community setting, not in outreach, because every outreach event is resource intensive and there is no way to follow it through. So we decided to create outreach only at educational campuses, nursing schools, universities, and medical schools. Our goal this year was to create 25 chapters. Each one of these chapters is managed by the local mentor, faculty member, or NGO, and run by the student from different batches from the university or the classes. So it's a self-sustained model. It's owned by the school or the medical school, not by the foundation. Our role is to provide them all that they need and stay with them for 5 years minimum to make sure everything is working. This year we have created so far 27 chapters, and of course largest number of chapters I created in India because of my connectivity, and I visit this place quite often. And second largest number is in Canada, and you will hear from my colleague when he will talk about it probably. This is a typical chapter. We created the very first chapter right at the top at the Maulana Azad Medical School, and we created the latest chapter at the Miranda House 2 days back. We also convinced my colleague Dr. Sunil Saini to create the first integrated clinic in India where everything is under one roof. So this is a young breast cancer program. I'm trying to convince Dr. Ashok Vaidya to create a similar center at Medanta now. It will be the first in the NCR. We created a scientific journal for the first time dedicated to young breast cancer, coming out from a reputed publisher, and Louis and we are running it. Very recently we came out with the idea, perhaps what's happening is there is a mitochondrial dysfunctional. We are talking about breast cancer at an early stage or cancer at an early stage. So there are hallmark of cancer and aging three hallmarks are overlapping. One of the overlapping hallmark is mitochondria. So we believe perhaps in a defined cell types in the mammary gland, there is a premature aging as opposed to biological aging. And that might be one of the reasons. And this is the direction which we are giving to the field now. So going forward, we will continue to support only science-supported research. We talk about stories which are worth spreading. We have publication, we have a comic series. If the girls can read this comic series, they got 90% of awareness right away. We have chosen Uttarakhand as a model system simply because it's a small state, we can do a lot of things together, and we do have a plan to this program to take to every single block, at least in 4 different districts. So, going forward, I think we need to focus on science. We have defined and picked up very specific scientific project. I'm not going to go into details, they are all listed here, but we are science driven. And I will also cut the mitochondria. But I just wanted to show some data here that this, so using a program and using the information what we have, we were able to narrow down to 20 genes, which are under 40, or some of them are common. And these 20 genes control different functions in the mitochondria. If you can name me a risk factor, I can easily connect with the mitochondrial health in next 5 minutes. Any risk factor you want to name, So this is the direction we are moving now, and perhaps we will have more information. We will also trying to bring the best of science, and we created an annual or biannual web series. This will be the global webinar, and leaders will be participating, and we will have meeting next year in Tokyo. We do have all of these things listed in a small videos. These videos are only 5 to 12 minutes long, and everything I said is right there. So to close, Foundation is turning the question why me into a different kind of program. We are absolutely science supported, and we believe in science, we promote the science, and there is no other way we can start turning the curve from left to the right. With time, it will be always from right to the left now. And the number of, right now only 3% of the girls are less than 24-year-old, and I can tell you in 5 years, this number is going to go up, unless we start hitting it at the grassroots, at college campuses, and create a different kind of culture, and we are going to do that. I will stop it.
Let's move to the next section.
Thank you so much for the chairpersons and the speakers for session 1. Now we will start the session 2, which is on early detection and diagnostic approach. For the session, I will call chairpersons Dr. Nilakshi Mohanto ma'am, Dr. Naresh Kumar Soni sir, and Dr. Prakash Chitalkar sir. I request to chairperson to invite our speakers for this session.
Good morning, ladies and gentlemen. It's my pleasure to invite Dr. Ramesh Nimagadda, the Director, Medical Oncology, Apollo Specialty Hospital, Chennai, and a much admired person as far as I am concerned, a Senior Consultant in Medical Oncology, Director of Oncology Services, and Chairman, Medical Advisory Board at the MGM Cancer Institute, Chennai. And he'll speak on the understanding of epidemiological trends in breast cancer, young women's breast cancer. Thank you.
Thank you. I'd like to thank Ashok for inviting me for this, and as last week Hemant has done to me, Ashok has done as well, given me a good talk. I wouldn't have chosen this topic because I'm a clinician primarily, and suddenly Ashok says you talk about understanding epidemiologic trends. That is then I said it's a broad topic, so I'll take the liberty of doing whatever I can understand a little bit. So these are all charts and all. Hope you can see some of it. Essentially what it tells is this is the ICMR data from 35 registries in the country across. They have maintained population registries, and in this from top we can see the districts from northeast quite a bit with the highest incidence, and similarly next some Bangalore, Delhi, Hyderabad, Chennai, and then comes down like that. So there is variation in the country across. This is not small areas, and that is very, very important. And then male and female. Then we'll come to breast cancer, again from the ICMR, where it is increasing over the last year kind of thing, this data from 2012 to 2016. And they looked at it, and there are several areas it is increasing, except in Nagpur it did not significantly. But the numbers are on the right side. As we can see, the AAR is compared to other countries in the Asia, and especially Japan. I don't know, they have taken Hiroshima. They could have taken Japan at Tokyo. It would have been much more representative to me, but we will see. As you can see, the numbers are not very high as to the Western population comparatively. As you come down to the India, many districts we can see it is what we think are high are still much lower compared to the Western population. Now this is a monumental effort from Tamil Nadu state in this country. They have done all the districts in the country population registry. And this is Dr. Swaminathan from Adyar Cancer Institute and Dr. Shanta. And this is the data that is published for year 2016. And this is the state where I live. I live in Chennai. And you can see in the breast cancer, females, the Chennai is the top in 2016 with 52 as the crude incidence. And then subsequently, as we come down the districts, we know all these districts, and as we come down, we know the socioeconomic status and lifestyles and overall the rural to urban population ratios. So that follows a pattern. But you look at the next one, that is cervix in the same districts, and it's almost a flip over. And the bottom ones go up and the top ones come down to the second half. So that is an interesting phenomenon basically. So what it shows is that if you have a higher in reality economic status and lifestyles and a city dwelling, your risk of breast cancer is much higher. And similarly, in the opposite side, if you have a rural area and less of a health, let's say, awareness and economy, as well as the hygiene, the cervical cancer is higher. And that continues. And it used to be one area in Maharashtra where Barshi, where the rural population registry was started by ICMR in India many years ago. And that's the only one which we used to quote, saying the urban area in Barshi district compared to the rural area in Barshi district was different, in that there is a change in the urban district where the breast has increased and cervix has come down, but within the Barshi district, rural area, the breast remained less and cervix remained high. So these are all things that one need to look at. Now these slides are given to me by Dr. Swaminathan himself because I wanted to know what the changes for our time, because this is a time trend thing. Then this is, I don't have the publication of this, but he has given me the slides. And this is 2012 on the left and the 2021 the right for the breast in the first. And it has been increasing, but also to some degree that happened all across. And cervix, it is about the same. It is decreasing and also decreasing in the areas where it was high to a degree. And the transition, again, this is from Tamil Nadu Cancer Registry Program, from breast to cervix, and the breast being the number one, happened around 2012 in this particular thing he has given me. And these are the, I think it's very important when we talk about the age groups and incidents and crude incidents and all, is what is the population pyramid is doing. Are the age group is actually increasing or decreasing in the population for us to say a particular disease is decreasing or not, or increasing or not. And here Tamil Nadu, again the state, the first one is in 2012 and the second one is 2021. And you can see that slowly the bottom is narrowing and lower upper is increasing slightly, and that is where what we're talking about under 40 are there. So in fact the 20 to 40 or 18 to 40 are increasing at the moment in percentage. Oops. And he has given me this slide, and this again is the registry in Chennai City Metropolitan Registry, and this has been going on from 1982, and at various periods, 4 periods he has taken, and we can see that there is increase in the incidence rate over the time. But again, the younger than 35 also increasing, but then compared to the other one, it doesn't seem to be as much to me, but we will come to that. Now, that is the data from the country as a whole and Tamil Nadu state, as I can see. So there is a change in the country demographics and also the disease patterns. And different districts are different. So we have to look at where we are talking about, which area and which part, and what to do with any given area, and not generalize it. And I was interested in collecting the real world data in this country, and which I believe is very important, especially with the variation we have seen in the population registries, etc. Unless we collect the data, we will not know what's happening to our patients as we treat. And with that intention, I started developing some softwares and finally created a foundation, a non-profit organization. And this is the software, which can data entry is there, and also we linked R to it so that one can analyze and look at it. So these are the hospitals and institutions that are where the software is installed so far, and about 19-20 hospitals are entering some data in that. Now there are about 7 institutions that agreed to collaborate and pool their data completely, and in the last 10 years. And in this, we have registration details for about 14 lakhs, that's about 1.4 million. And primaries were identified in 5,77,000. And surgical procedures we know about 80,000. And histology is identified about 4 lakhs. And these numbers were like that because these are all retrospective. As we installed, we started looking. And 80% of these imported from structured data directly wherever it is available. In 3 institutions recently, we started actually data point extraction from electronic medical records by text analytics. And then we'll see what has come out with. And in one of these hospitals, that is this particular hospital, oops. I don't know, you can see the pointer, but that is the Saroj Gupta Cancer Center in Kolkata. There, the late Dr. Saroj Gupta started coding the site of primaries from 96 onwards. So we have a long site of primary patterns, and when we look at from 96 to 2019, you can see the crossover for them. The cervix and the breast happened in about 2003 or 4, and then the cervix kept on coming down. When I asked the institution whether they were doing any screening camps or any social awareness programs, they were doing none. And this is what I think is the important thing, to say that cervix with a little bit of hygiene, education and economy, it can come down to a large degree, but still it is there. But the breast is different because the society is changing and the breast cancer seems to be increasing. That we have seen in other registries as a population. Next, we created a breast group, and about 11 institutions are participating in it. Some data we have, and in this so far we were able to collect. I'll come to that in a minute. This is the population pyramids for the country from 2011, India, 2011 the first one, and 2023 the second one. And as we can see, the base is already narrowing down. 0 to 4 and 4 to 5 to 9, and like that it is narrowing. But in reality, the bulge is at the moment is in the area where we are talking about the patients, young breast women. That is where the bulge is at present. So with this, still when we looked at about 55,000 patients, breast cancer registered between 2011 and 2022 in that breast group database for now. The less than 40 years started off with about 21% and then is slowly coming down as a percentage as we see it from the data we could get from these institutions. Of course, this is not population, but these institutions, but I presume if we look at population, it will show the same thing. Because these institutions are spread out across the country and different socioeconomic status patients. And then the top one is the 40 to 64, and that is steady around that. And the lower one, 65 to 99, yellow graph, is slowly increasing. That is because people are living longer and are able to come to the hospitals for treatment and getting awareness. So that, I think that actually the population also increasing in that age range as we are looking at. Then now I looked at the about 40,000 of patients, we have some data, and in that about 20,000 or 25,000 in different areas of the thing we are collecting now, in fact. And this is the clinical T size, and the early breast young age, as we can see, is about the same as the middle age. Older age, it is different. That is interesting to me. I was surprising, and it should be looked at. Why? Because we are looking at the T3 and T4 more than in the older people, where it is T1 and T2. In fact, T2 is more as well as T1. And that is interesting because it may be, my thinking maybe is, it is the slow-growing tumors with hormone positive, HER2 negative, and that seems to be a possibility. Now, when we look at the pathologic tumor size, again, these are upfront surgery patients, and then we can see that the same thing between the first and the second and the third, again, there seem to be a little more the T1 and T3, relatively small number. Now, more importantly, the earlier speakers were saying that when I saw this thing, I myself was wondering what is happening suddenly, because the lower, less than 40 years, young women, there is high HER2 positivity and high triple negativity. But triple negative we have always been talking about, but the HER2 positive was a surprise, a bit to me at least, because I have not looked at the epidemiologic part of this. And then triple negative does come down, and HER2 also comes down at the late 65 plus, and that is more with hormone positivity. I think these are all important things. Now, this is a study we published, myself, Dr. Dole from Rajiv Gandhi Cancer Institute here, and Dr. Sel Radhakrishnan at Chennai. And this is about 3,400 patients, upfront surgery done between 2018 and 2014. I thought I'll just show you what we found. And we could get different sizes and different hormone receptors, and also node positivity, negativity, all these things. And we looked at if you look at the bottom of the left side, where below, triple negative, node positive and node negative, we had about 700 odd patients. And in that 294, the patients had positive nodes, and 472 patients had negative nodes. I think this is important because there seem to be something different why we get this early as far as lymph node is concerned. It is possible to me to think why it is possible is that maybe triple negative does grow faster, and so we usually feel the lump, but it may not go into the lymph node, whereas the hormone positive has time and that goes into the lymph node. That is only thing I could think of as clinically. Now, these graphs are the one published already, and the right side you can see the lymph node status and all is not important, but the hormone receptor status, you can see that is C, that the triple negative is the middle curve, and the HER2 positive is the lower curve, but that is because many of those patients didn't get the HER2 therapy. So, but triple negative as the middle curve. And when we look at this again by the age group, this I did this last week from the same data, just to look what happened with the age group breaking. And in fact, the middle one is the less than 40 years, and the last one is the older group. And that continues to drop beyond, which is the hormone positive thing we know about. And after the 5-year relapses, this is DFS. And that I think is significant. So in fact, it is age also a factor, but it seems to be that we can actually treat them or get better results with the lower age group with the treatment we already have been giving, and more I think will help to do that. So that is where I think I'll stop, and thanks to Collaborative Group and Breast Group to allowing me to do some presentation of data, and also thanks to all the IT and MRD group, which personnel in the institutions who helped us get the access the data and import the data and do a lot of work behind the scenes, much more than the physicians in the hospitals. Thank you.
Dr. Nimmagadda, Are there any quick questions? Otherwise, we've got a long session to go. Otherwise, we go to the next speaker.
Yeah. Okay. Thank you.
Thank you, Professor Nimmagadda. We now move on to the next topic, and the topic is identifying the risk factors of breast cancer in young women. How much of it is hereditary? I would like to invite Dr. Amit Verma, founder and director, Department of Clinical Biochemistry of Dr. A.V. Cancer Institute, Gurugram. We look forward to some interesting insights.
So good morning, everybody. So the topic is identifying risk factors for the breast cancer in young women and how much is hereditary in nature actually. So with that, we all know the basics of the risk factors what we see in the breast cancer, and that do apply to the young breast cancer women as well, especially the early menarche, the late age at the first childbirth, not breastfeeding, and use of oral contraceptives. All these affect the risk for breast cancer, which we all are familiar. And again, the lifestyle and the environmental factor, the alcohol consumption, smoking, physical inactivity, obesity, any past stress radiation, and night shift work. If we try to compare all these risk factors in the Indian woman versus the West woman or the Western woman, you will see there's a different style in the Indian woman status, and we see that these things are not that common in the Indian woman. We don't see much of Indian women smoking or alcohol consumption or the use of the contraceptives. So all these things, still the cancer is at a higher category in Indian women, in young, and that can be attributed to the other factor, that is the genetic or the familial factor, which are not governed by all these ongoing risk factors. So in terms of the inherited genetic mutations, we are familiar with the BRCA1 and BRCA2, but I would like to also emphasize some moderate genes which have some monitored penetrant genes which have significance in the breast cancer of young women, especially the TP53, P10, PALB2, CDH1, CHEK2 and ATM. And definitely, even if there is no genetic alteration, but a family history alone can have some increased risk for breast cancer in young women. If there is a Ashkenazi Jewish descent or certain breast conditions which are benign, like atypical hyperplasia, can increase the risk. So while we are evaluating why the patient has developed cancer, we should look into all these three major categories. So if we talk about the current guidelines as per the NCCN, the age what they talk about to do the genetic evaluation is less than 50, which definitely includes the breast cancer of a young woman, that is less than 40 for sure. But whenever you are including the age, you are also looking for other nuanced factors like the histology, that is triple negative versus the lobular, the multicentricity, and there is a family history. So all these factors boils to the possibility that the patient may have genetic as one of the factors which we have to identify, and what are the implications we'll discuss in the few slides. Especially like whenever you encounter a patient with a family history of sarcomas, then you should think of mutations like TP53. If there's a family history of breast cancer, ovarian cancer, you look for the alterations like BRCA and BRCA2. And all these things have some implications in your decision making. The standard treatment still remains the same, but the adjuvant therapy may modify if you have this information with you. So what is the prevalence of hereditary cancer in young women? That is a big question which we are going to discuss today. And in the Western literature, up to 10% of the breast cancer across are associated with BRCA1 and BRCA2. When we talk about the Indian population, we have limited data set, and there are a couple of publications coming from India with varied percentage of BRCA1 and BRCA2 alteration. And what we know that coming from Chada et al., that the prevalence can go up to 32% in BRCA1 and BRCA2, and from Singh and Selva Kumar et al., it can be between 25 to 18%. So this reflects that there is the higher prevalence in the Indian set of population. And I will go back to the initial slides. The Indian women are different as compared to the Western women in their lifestyle, the way they work actually. And what predominates in them is the genetic behavior. And that is where we have more obligations to identify who are the eligible women for some sort of adjuvant therapies, especially the PARP inhibitors, which are used for BRCA1, BRCA2 positive cancer patients. So this prevalence, there's a letter to editor written by me, which talks about the higher prevalence and also negate the possibility that there can be a hospital bias or a diagnostic bias when we do all these tests. So many authors have tried to use the NCCN as a kind of criteria to pick up these cases, and they have really found that the incidence is truly high as compared to the Western population. To add to this complexity, what we know that whenever you investigate a person, you end up having variant of unknown significance. And in the Indian population, the frequency of VUS in all the report can range from 6 to 15. And in the global, VUS is in the range of 21% max. But what is important that out of every 11 VUS reported, they are reclassified to pathogenic is in up to 3 cases. So approximately 25% time we are giving them as a positive or pathogenic alterations as a future course or as the more information is coming into the literature. So having said that, the prevalence what is reported right now is truly higher than what we are seeing, maybe 25% more. So practically speaking, if I just try to summate the Indian probability of having BRCA1 and BRCA2 alteration will range between 25 to 30%. So every 1/3 woman will have BRCA1 and BRCA2 or any other important alterations, increasing the hereditary risk. So, but this is in general. So when you try to select the patient population based on the age, then this probability will go further high. So early onset breast cancer have a higher prevalence of BRCA1, BRCA2. So which the early breast cancer, especially when you try to grade according to the age, that is less than 36, between 36 and 45, and less than 35, the percentage goes up and up actually. So what dictates them, we do not know, but it is well known to all of us that the genetic cancers present at early age, which may be supported by the other factors, including the environmental factors, and supporting the cancers to develop little early. Especially patient if have histologies like triple negative, those patients are at a higher incidence of having BRCA1 and BRCA2 alterations. So please mind, age is one of the criteria to look for, but histologies also guide you further. If you encounter a hormone positive breast cancer in a young woman, try to look for other possibilities like TP53 mutation. If there's a HER2 positivity, also look for TP53 mutation. So try to find out if the patient is having a family history related to the Li-Fraumeni syndrome. So all these things are very important. Histology and age should go hand in hand before you make those judgments. So this is a paper coming from the Indian data set from the Rosie et al., and which also talks about that the younger population, that is between 20 and 45, have more BRCA prevalence as compared to the age group of 46 and 65. So again, re-emphasizing that younger women are more prevalent, and we are obligated to investigate them thoroughly. In terms of the methods available, we all know, we are familiar with, we are using NGS as of now to not only include the BRCA1 and BRCA2, but a multi-gene panel to pick up other moderate penetrant genes, including ATM, CHEK2, PALB2, and TP53 as well. But when you try to compare BRCA1 and BRCA2, what we see is that BRCA1 dominates over BRCA2 in HBOC syndromes, but a category of alterations which are missed by the next generation sequencing is picked up by a technique called MLPA, which is able to pick up the deletions and duplications. So if you try to understand the types of mutations in BRCA1 and BRCA2 genes, it can vary from deletions, duplications, frame shifts, insertions, missense, nonsense, splice sites, stop gains, substitution synonymous. So among this, what we are missing with the NGS is the large deletions. So please bear in mind, young patients should be investigated thoroughly as compared to the elderly women. If NGS is negative in a younger woman, then please investigate by MLPA to make sure that you have not missed large deletions duplications. Try to go for multi-gene panel in a younger woman to pick up other possible alterations, because the probability of having genetic factor in a younger woman is very, very high. So why there is a need? What is the need to identify hereditary cancers? That is a big question. Even we are emphasizing too much of it, but what is the purpose of it? Biologically, they are very, very distinct. Early onset breast cancer, we all know, are very aggressive, and there is a hereditary association with them, especially the histology. You see more often triple negative. And so all these things are very important. So younger breast cancer patients, we are obligated to prevent the second breast cancer, that is the contralateral, and the other cancers, that is ovary cancer. So we are looking for secondary preventions than the primary preventions in majority of the clinical practice, but we also should look for primary prevention for the other malignancies. So if you try to compare the 5-year survival rates in female diagnosed with breast cancer over the age of around the age of 40, and as compared with the other age, we see that there is a dramatic drop in survival itself, which we are already familiar with. And if you try to compare age with age and stage with stage, what you will see that from the same stage, different age group have a different survival. And the younger the patient, poor is the survival. Whatever stage you compare, you see that the younger patients behave very badly, even if we are limiting ourselves to the basic concept of histology, the hormonal status, and the Ki67 index. So there is something beyond all these biomarkers which we are yet to discover. Even in the Oncotype DX scoring method, the intermediate score of 1625, the response is different, and what we recommend is to give chemotherapy in these scenarios also. So again, re-emphasizing the fact that the younger women are aggressive, and we are obligated to investigate more, something beyond, not like usual breast cancer of an elderly. So this is something which I wanted to emphasize. So is all hereditary cancers aggressive? That's another question. The answer is, if the patient is having BRCA1 and BRCA2 alteration or T53 alterations, they will behave badly. But if it is a BRCA2, which are usually associated with hormone positive cancers like luminal type B, they may behave in a better way. And now we have the drugs available with PARP inhibitors and platinums, what we normally use in breast cancer. The outcomes may be a little different. So hereditary cancers gives you a lot of insight and predict the overall response to therapies in the overall course of the disease. So what are the implications? We understand that once we identify who are the eligible patients for adjuvant PARP therapies, but we also are obligated to tell them that what are the risks for contralateral breast cancers in second primaries, and what are the risks for the cancers in their family members, siblings. So we are obligated once again. So young patients should be investigated in this mindset as well. So I'm just giving you the risk, population risk for other cancers, including BRCA1 and BRCA2, and which we are again need to counsel the patient accordingly. So I would like to give you an interesting case study. I'm coming from my clinic. It's a right now 44, but the patient was diagnosed with bilateral breast cancer at the age of 40 and had triple negative T3 and 2 on the right side IDC, and the left side was ER, PR positive and HER2 negative, T1 and 0. Family had a younger sister who was diagnosed again at a similar time around the age of 40, and she died little early. And the germline testing was done which came out to be BRCA positive. So a young breast cancer woman was investigated based on the family history and the bilateral presentation and turned out to be BRCA1 mutation positive. She underwent bilateral mastectomy for the treatment purpose, completed the treatment, but also underwent prophylactic the bilateral salpingo-oophorectomy and was put on adjuvant letrozole and olaparib for 1 year. So while we were doing as per the books, we were not very convinced. We did a liquid biopsy and a PET CT. PET CT was not showing anything, it was all clear. And the liquid biopsy showed the evidence of disease. We gave extended 1 year of olaparib, assuming that we are missing something and we should give the advantage of giving olaparib another year. After stopping the olaparib after 2 years, just after 3 months, a repeat scan was done, and which showed the disease coming back, and the liquid biopsy which was done at that time showed the same BRCA alteration, but this time the patient had EGFR exon 20 mutation, which is usually seen in lung cancer, and ETV6 fusion with BCL2. So this is something very rare finding which we were able to pick up. And what is the relevance of having an EGFR mutation which is usually seen in lung cancer in breast cancer patients? So these are young cancer patients, and when we went to the literature and what we saw, EGFR mutation occurred at a significant higher mutation frequency in hereditary cancers as compared to sporadic cancer, and that too lies in the tyrosine kinase domain of EGFR exon 20. Exactly what we are seeing was reported in the literature. So what we are missing is that the deep investigation gives you some answers. So we are not investigations, and that can be the explanation why the patient failed even our extra efforts given in this particular scenario. Again, the second alteration, the BCL2L14 with ETV6 fusion, which are usually seen in triple negative breast cancers, again well reported, shows aggressive tumor type. So all these things suggest that the young cancer woman behaves very differently. There are some things which we can look forward and we can resolve in a different way. Currently the patient is having chemotherapy and responding well. To conclude the whole discussion, that early breast cancer should be considered aggressive phenotype. We should investigate them at the hereditary level, not only the BRCA1, BRCA2, but other alterations including ATM, CHEK2, PALB2, T53, CDH1, STK11. So all these are common alterations which are there, which are associated with breast cancer. We should have a special attention, and extended aggressive form treatment should be offered. Whatever is the best approach should be given to the patient. And consider germline testing for all younger women, because the prevalence in India is higher as compared to the Western world, and offer risk-reducing strategies, whether it is chemoprevention, active surveillance, or prophylactic surgeries for secondary and primary prevention. So with that, I thank you all for your kind attention. And
thank you, Dr. Amit, for overview of the risk factors. Now we are moved for the next topic. I invite Dr. Hemant Malhotra sir for genomic assay in breast cancer.
So good afternoon, ladies and gentlemen. I'm going to be talking about genomic prognostic assays in breast cancer and focusing on young breast cancers. So I'm grateful to the organizers for this opportunity, particularly my very dear friend Dr. Ashok Vaid. I have some very interesting pictures of him, but I chose not to show them. Maybe one of these days I will show them. So ladies and gentlemen, the goal of having a prognostic tool and developing a prognostic tool is to give us some information regarding the prognosis of the patient and the treatment the patient should receive beyond the current method, meaning beyond the T size, beyond the N size and beyond the molecular IHC4 subtype. And they should help us in guiding adjuvant treatment decisions, and for the population for which you are applying the prognostic tool, there should be a validation of that test in that population. So the commonly used multi-gene assays world over, and including in our country, are these four. The Oncotype DX, which is a 21 gene panel, the MammaPrint, also known as the Amsterdam signature, developed in Europe, which is a 70 gene panel, the EndoPredict, which is a combination of genetic testing and clinical features, then the Prosigna. But keep in mind that the top two, Oncotype DX and MammaPrint, these are the two genetic signatures which have been prospectively tested. So in this picture, I've added, one more test which we in India, oncologists practicing in India, are familiar with this. This is the CAN-Assist test, and this is a India-specific prognostic tool, particularly for patients who are hormone receptor positive, HER2 negative, which some of us are using. And in the subsequent slides, I'll elaborate on this a little bit. So talk about each of these four tests and the fifth Indian test in the subsequent slides. So this is the Oncotype DX, 16 gene cancer-related genes and genes related to the estrogen receptor, proliferative genes, HER2, invasion and other genes, and 5 reference genes, making a total of 21 genes. And it was initially validated in the NSABP B20 trial, and it predicts the magnitude of chemotherapy benefit. In the first publication, the cutoff was at equal to or more than 31, and you have the recurrence score on the x-axis and the 10-year distant free recurrence rates on the y-axis. And you could calculate and plan for which patient is a combination of endocrine therapy and chemotherapy reducing the risk of recurrence, and for which patient only endocrine therapy is enough. It was further, this 21 gene score were further classified into, sub-stratified into different recurrence scores, and for younger women and older women. And we can see that the recommendation for adjuvant chemotherapy, particularly for younger women who have a high recurrence score, like the benefit to chemotherapy, is pretty well defined. This remains a gray area, recurrence score of between 6 and 25. You have to individualize treatment for that. You have to take the patient's choice for that. But if you have a recurrence score somewhere over here, whether young or old, or if you have a recurrence score somewhere over here, either young or old, there is unambiguity that chemotherapy should be given, and there is near unambiguity that chemotherapy should not be given. And these were the prospective studies for the Oncotype DX, the first publication of the TAILOR-X study in 2018. And again, these were the 4 stratas as per the recurrence score. Then this was the RX-Ponder study for patients with node-positive disease. 5,000 plus patients, about 1/3 of them were young women, and 2 stratas were used, 0 to 25 and more than 25. And so some data was provided in patients with node-positive patients and also in younger women. MammaPrint, the Amsterdam signature, is a 70 gene prognostic assay. It is CLIA certified, but you can do it on the paraffin embedded tissues, and it defines a good signature and a poor signature and a pretty clear-cut threshold And there is a nice division of the good signature and the poor signature in both node positive and node negative patients. And this is how the report comes like. H2, H1 low and ultra low. Again, there is a near concordance that in ultra low adjuvant chemotherapy is not required, and in H2 the adjuvant chemotherapy is required. The intermediate two remain a little bit of gray area. And this was the MINDEX study published in 2016 first, 6,600 plus patients. 1/3 of them were less than 40 years of age, both for patients who were node negative as well as node positive. And this was the classification: high clinical risk, low genomic risk, premenopausal, you consider chemotherapy, benefit is modest. For both high clinical risk and high genomic risk, unequivocal recommendation for chemotherapy, clear benefit to adjuvant chemotherapy. Both low clinical risk and low genomic risk, only endocrine therapy. And then the discordant, low clinical risk, high genomic risk, then again consider chemotherapy, but the data is limited in this cohort of patients, and the decision to give chemo or not has to be individualized as per wishes of the patient and the wishes of the doctors, and the magnitude of the clinical risk. If you have a 5 centimeter tumor with 5 nodes, then you would tilt towards, even if the genomic risk is low, you would tilt towards giving adjuvant chemotherapy to that patient, as was very clearly highlighted by Professor Michael in the earlier talks. The EndoPredict assay again is used. This is validated in the ABS-CG6 and the 8 studies. It's a RNA-based multi-gene score, and it uses both clinical as well as molecular factors, and it predicts the 5-year as well as 10-year recurrence risks as per what the genomic expression the patient has. And you get a score like this, clear-cut high risk on this end, clear-cut low risk on this end, and unfortunately a lot of patients, or a significant number of patients, are in the intermediate zone, where again the decision has to be based on a lot of factors, sometimes other than just the genetic score. Prosigna again is another test which is used sometimes by some centers, and this is the kind of report which you get: low risk, intermediate risk and high risk, less ambiguity in both ends of the scale, and some ambiguity in the intermediate risk groups. Now the two prospectively evaluated gene scores, the Oncotype DX and the MammoPrint, if you compare them head to head and try and answer some of these questions, does the assay predict benefit to chemo? Yes, for Oncotype DX. Is the assay prognostic? Both the assays are prognostic. Is the assay supported by outcome data? Answer is yes. Very large number of patients in the Oncotype DX available, been there for a longer period of time. And again, a significant number of patients, 7,000 plus patients, the validation has been done for MammoPrint also. Now, what about the homegrown test, the CanAssist? Here I'm comparing in this table CanAssist with the other tests. This is a proteomic test, looks at expression of proteins related to 5 genes, and you get a risk score. 0 to 15 is low risk, and 15 and above is high risk. So genomic tests have been in routine clinical practice across the globe, but there are certain limitations. The representation of very young premenopausal patients is relatively low and less. There is potential underestimation of chemotherapy benefit in premenopausal patients, and in the cohorts in which the two main tests, Oncotype DX and MammoPrint, where in the cohorts they have been validated, there is very significant paucity of Indian and Asian patients. So again, this is a question, and this is the topic of the day, breast cancer in young patients, premenopausal patients. Like, do the conventional prognostic assays predict for choice for chemotherapy, adjuvant chemotherapy in hormone receptor positive patients in young patients? That is a little bit of question mark. And that is the reason why this India-specific CanAssist breast was developed. This gives you a report like this. It gives you a recurrence score like this. If the patient is less than 15 in the green zone, you have low risk of recurrence, and if it is in the red zone, it is high risk of recurrence. And 5 biomarkers, as I said, done by the immunohistochemistry, and as a consequence of this, the reporting is quick. In 7 to 10 days time, you get the report. Also would like to mention that it is significantly cheaper than the Oncotype DX or the MammoPrint, about 1/3 the cost. It has been validated in about 4,000 plus patients from India, Europe, and US. Supposed to be highly accurate, and it has been patented in several countries. Now this number is 20 plus publications in national and international journals. So 22 studies, 4,000 plus patients. And how does this test compare with the other genomic tests? The concordance with of CanAssist breast with Oncotype DX is between 80 and 90%, and the concordance with MammoPrint is also between 80 to 90%, particularly in the low risk category. So this is the latest recommendation from the NCCN 2005 recommendation. For patients, the Oncotype DX is both predictive and prognostic, and level 1 evidence, and this is the preferred test as per NCCN. So maybe in the US patients, this is the preferred test. Now, what about, this is for the node negative patients over here. What about node positive patients? Patient with 1 to 3 positive nodes. It is both predictive and prognostic. For postmenopausal patients, the level of evidence is category 1. But for premenopausal patients, the category of evidence is 2A, so not as strong as for the other categories. Now, the other validated test, the MammoPrint, it is certainly prognostic, and this is also in the category 1 as per the NCCN. So, ladies and gentlemen, again, we are well aware that when we have a patient, particularly a young patient who is hormone receptor positive, HER2 negative, what are the factors which we need to take into consideration in deciding whether the patient needs adjuvant chemotherapy or not? The estrogen receptor status, the ductal histology, the grade of the tumor, the proliferative index as conveyed to us by the Ki-67, then some other markers, whether there is also HER2 positivity, and then again whether the recurrence score as per our genomic assays is high or low. And the factors which will indicate to us that possibly adjuvant chemotherapy is not needed are strong estrogen receptor positivity, lobular histology, grade 1 tumors, low Ki-67, low other markers, essentially luminal A type of patients, and a low genomic risk. So I think none of us in the audience would choose only a genetic test to decide whether chemotherapy, adjuvant chemotherapy needs to be given or not. All of us would use a combination of clinical factors as well as genetic factors to make this decision, and I think this was very eloquently emphasized by Professor Michael in the earlier talk. So these were the two main Oncotype DX studies, the TAILORx and the RxPonder, and the Amsterdam Signature MammoPrint study. TAILOR-X was in node-negative patients, and the R-exponder was Oncotype DX in node-positive patients. MINDACT included both N0 as well as N1. And here are the summary of the recommendations for you for patients who were post-menopausal. There is, as per the genetic test, there is less emphasis for giving chemotherapy. You would rather be a little conservative and try and give more and more endocrine therapy to these ladies. However, if the patient is young, less than 50 years or less than 40 years or premenopausal and clinically high risk, then if you have a low recurrence score versus a high recurrence score, there is definite benefit to chemotherapy, both in the node negative, in the node positive, and also by Oncotype DX, and also by the MINDACT data for MammaPrint, 6% benefit, 5% benefit, and 5% benefit. So in addition to the prognostic scores which I have just mentioned to you, we are quickly approaching a time where, other than these molecular assays, we might look at other markers, other molecular markers like PD-L1 expression, BRCA mutation, ESR mutations, where you would rather use a SERD rather than a SERM. Then we are looking for biomarkers for selecting patients who would benefit with CDK4/6 inhibitors, and a whole bunch of other markers are still waiting to be discovered yet. So my take-home messages, ladies and gentlemen, the multi-gene assay tests do help us in guiding, in making treatment decisions which are best for our patients, particularly for patients in which de-escalation of chemotherapy can be safely done, and we can avoid the potential short-term and long-term toxicities to our patients. In luminal A early breast cancer, the use of these tests, both in node negative as well as node positive patients, is important, and there are several assays which we've already discussed. And also there is both the aspects are there, that we don't wish to over-treat our patients, and we also do not wish to under-treat our patients and increase the chance of the disease coming back. And we have both these tests which are available as an add-on to our clinical factors. We also now have a homegrown CanAssist test which has not as much validation as the two imported tests, but it has some validation, and it is a quick turnaround time and significantly less expensive. So we do need to keep that in mind and consider that also. With that, I'd like to thank you very much for this patient hearing. Thank you.
Well, thank you, Hemant, for a wonderful lucid presentation as always. Do you have time? I think we are falling short of time, so
thank you very much. Thank you.
Thank you so much.
Thank you. Thank you so much to the speakers and to the wonderful chairpersons. Due to time constraint, we'll be skipping our tea break. I'll request you to please collect your tea and then come back to the room. And we'll be starting with our session 3. Session 3 is treatment approaches in young women, and I would like to invite our distinguished chairpersons for the session, Dr. Sunil Kumar Saini, Director and Senior Consultant for Cancer Research Institute, Dehradun, and Professor Michael, Professor of Surgery, Comprehensive Cancer Center, Medical University of Vienna, Austria.
continuing the scientific sessions. Now we have the third session, a pre-lunch session. And there's a little bit change. We have Dr. Geeta Manjunath as the first speaker for this session. And she is talking to us about early detection of breast cancer in young women using AI-enabled infrared imaging. Welcome, Dr. Geeta.
Good afternoon, everyone. It's a great pleasure to be among experts, and we are all trying to solve this sort of new emerging problem of increasing breast cancer in young women. And I'm happy to be part of this first session. So I'm CEO and founder of Niramai. I'm basically a computer scientist, with artificial intelligence as my PhD. I was a principal scientist at HP and all of that. But when I lost two of my very close family members at their ages of 38 and 42, the whole thing changed, and I started my research toward young women breast cancer. And how can we actually enable a new equipment possibly to detect breast cancer in young women? And it's been 9 years of research, and I'm here to present to you the evaluation that we have done on young women particularly, and the results so far. Of course, we all know breast cancer is the top killer, and 2,000 lives are going every day because of this. And what is interesting to note is the Asian population takes up 50% of the breast cancer deaths in the world today, which is alarming enough. And we have seen many statistics in the earlier part of today, but I just want to give in another flavor of, if you look at breast cancer as a percentage of cancer seen, right? Especially in women under 45 years of age, you can clearly see a lot of pink being first, right? So in 45 to 54, 35 to 44, it actually takes up over 30% of cancers being breast cancer and so on. And again, mortality as well, you'll see the same thing. This is data, and this is picturization created based on GloboCan data, but it clearly indicates that breast cancer is something that has to be really addressed among all the cancers in young women, right? So if you look at another simple statistics of breast cancer in young women, the number of cancer deaths as opposed to 2,000 earlier, this is now coming to 88,000 around the world. The latest data again available from WHO 2022. New cases is 429,000. It is definitely alarming. I took the 45 years as a cutoff and not 40 years, just so that we are aware. And what is more alarming, some of the Indians here is that this turns out to be India gets 10% of the breast cancer incidences of the world in young women, 44,000, and in the world it is 429. Like it's more than 10% of cancer incidences in the world are found in India. 33% of cancer deaths in Asia are from India. So definitely we Indians need to attack this problem, and Dr. Professor Saini is already here and started the Young Women Center. But the alarming thing is the only way to detect or screen for breast cancer in young women is symptomatic hand-based examination, and of course you can go for an ultrasound, but then ultrasound we know is very subjective, and if there's no symptom, not everybody can detect it. So here is where we are. Can we have a screening test for breast cancer which can work on women younger than 45, because of course mammography is first of all limited in terms of screening all population. 1.3% of women only screen, but even it's only recommended above 45. So we actually invented this new method called thermalytics, where we just measure the temperature variations on the chest and convert the temperature map to a cancer health report using artificial intelligence algorithms. So infrared imaging device, just like one of these cameras, placed 3 feet from the person, and pick up 4 lakh temperature points directly into the computer and analyze that. And with that, what has been the results, and I'll go into the clinical aspects more. With this, we've been able to detect 4 millimeter lesion. Obviously it's sub-centimeters, biopsy proven to be cancer. It does not, and it did not depend on the age. We have found a 17-year-old with breast cancer and confirmed with biopsy, and also a 92-year-old. Because there is no compression or X-rays being done, and it is non-contact, even men can actually detect their cancer with this. Absolutely no radiation. We are just measuring the temperature on the skin, which is basically infrared rays emitted from the body. It is just captured. There are no new rays which are placed, right? It is just capturing the rays which are coming out of our body, because we are a heat source. We are always at 37 degrees Celsius, irrespective of whether in Kashmir or Kanyakumari or Alaska or Texas, right? And it is very affordable. It's less than 10% equipment, and skill set needed to operate is also very simple. And even simple, gynecologists, physiologists can do the initial screening. And sometimes, if it's a health worker in a rural area, we do the triaging automatically as well. A red, yellow, green is given. And most importantly, it is extremely privacy aware. We have like 4 curtains. The lady goes in, closes all doors and curtains, removes her clothes. She sits in front of the device, which is 2 feet from her, like a passport photograph. And the technician outside gives instructions to turn left, right, etc. There are also stickers on the ground indicating where she keeps her feet, etc. So it's extremely privacy aware, and women really love this. So a quick video of that. The lady enters, goes into the door and closes curtains. She sits on the rotating stool, and she's just rotating left, right to get the lateral and oblique views. The science here is really about converting temperature maps to cancer health report. The use of thermal imaging was known, and it has gone into a little bit of a weather, because people have tried to look at a thermal image, which is an extremely complex multicolor shaded image, and trying to interpret, which is extremely subjective, and there have been false positives and false negatives in it. But what we do is different. We don't even look at the image. We directly take the temperature points, which are at high sensitive natures, 0.02 degrees Celsius, and 400,000 temperature points, and extract certain very subtle thermal abnormality patterns, which is indicative of high thermal activity, high tissue activity, high metabolism. And secondly, we also try to extract abnormal vascular activity, which is again neovascularization or dilation of vessels that is seen in the body during cancer cell activity. And this has resulted in 39 granted patents in the software itself, which converts the temperature map. And this has also resulted in new biomarkers, or radiomics, as we call it. AI-based radiology is called radiomics here, where features are extracted. About 117 thermal radiomic features or biomarkers are extracted, and about 30 vascular patterns. So if you see this lady, like this is an automatically extracted vascular picture, where you clearly see that there's something going wrong in the right side, and left is okay. So it is showing a differential blood flow analysis, something like a Doppler, but a differential Doppler. Asymmetry is what is the focus. And then we don't know exactly where the cancer is, maybe the lower quadrant in this particular case, because it's a deep tumor. But the point is, it's a screening test to identify if there is a problem, and if so, what is the probability that it is malignant, and also likely location, so that a follow-up diagnostic ultrasound can be done, and a confirmatory, obviously, biopsy can be done on that. So, so it's basically meant for both symptomatic, asymptomatic women. Oops. And 5 thermal images are uploaded after about 5 minutes of cool air being blown. So that enables contrast and removes any extraneous heat due to tight clothing. And about 20 different AI algorithms crunch this and generate a report with scores indicating the level of abnormality. So analogous to Biret score, there is a B score that is generated. 4 and 5 are shown as red, and this is just a triage, right? A kind of a solution, screening solution. Additionally, we need explainability, right? Is it because of high thermal activity, high metabolic activity, or is it because of high thermal activity near the nipple area complex, which could be indicative of IDC, DCIS, or even vascular thing, as I mentioned before. And the marking of the likely abnormality is also shown as shown here. A dark blue boundary is likely to be malignant, dark green boundary is benign. It's just indicative. So this is automatically generated. It goes to a radiologist, oncologist, or a physician who does breast care itself, and then the care management has been done. The good part is the equipment is very portable. You can do the test inside a hospital or take it out and do the rural camps, etc. And we have done, even I see Dr. Shabnam ma'am, we have done in Kashmir, and we have done in many, many other places as well. So yes, we have done several studies, 50 plus publications. And in this particular talk, I'm going to focus on dense tissue, which is of course seen in young women. And it was, many people thought it was a game changer, because some of the studies, when we did a post-hoc analysis, we saw real cases where a mammogram was showing a BIRAD 1, but it turned out to be a big blob in the thermal space, so that, it could be indicative, and then a biopsy was done under ultrasound guidance, and it was positive. So yes, maybe there is a good chance of detecting this in young women. So that's when we actually looked at 3 different prospective blinded studies that were done on thermalytics. It's of course multi-site. The first one was done across, first one was published in ASCO JCO. The study itself was multi-site between HCG and CDRF, two centers in Bangalore. And the second one was done, which was published in Frontiers in AI, and this is also in clinicaltrials.org. This was done in Max Hospital here, right in Delhi. And the third one is BMJ Open, a multi-site study done between HCG and NH, completely blinded and under all the ethical guidelines. So these 3 studies were already published. And what we did was, did a post-hoc analysis of how are the results showing for women under 45. So the study protocol was basically, we looked at all the PubMed about thermalytics, and this is what was filtered out the 3 studies I mentioned. One of them is study size of 470, another 258, another 459. Combined, 1,187 patients were there. Out of that, 463 patients were actually of age under 45. And we kind of directed them to do and compare both thermalytics and standard of care. Here, standard of care included mammography, but in cases where radiologist felt like ultrasound also has to be done, that was done. If radiologist felt only ultrasound is fine, only that was done. And of course, biopsy confirmed positivity. The interesting results were on all the full set of 1,087 patients, 88% sensitivity, 84% specificity was seen. This included a lot of symptomatic women as well. In the young women, when we did this sort of meta-analysis, we found sensitivity of 90% and specificity of 82%. This was very encouraging, and what is very interesting is 98.9% negative predictive value. Means when we say no, it's a no. So we could actually subject slightly high risk women with BRCA positivity or women with family cancer history into this stream and use this as a non-invasive test. So here is a sort of the bar chart view of the same results. Sensitivity of 90% and specificity of 82%. We need to do a little better on the PPV side, but this seems to be something that people can evaluate, and then we can figure out more studies can be done, and this could be a potential way of non-invasively, non-contact, fully privacy maintained test for detecting breast cancer. We have been partnering with YWBC for now 2 years with Dr. Rakesh sir, and we are working together to take this to different colleges along with it. I did leave some time for questions. If there is any, I'm happy to answer.
First of all, I want to thank you for this excellent and innovative methods of diagnosis.
Thank you, sir.
But issue here is the young breast cancer patient, due to the breast density, neither mammogram or to some extent ultrasound is considered very highly sensitive method.
Yes,
rather, MRI is considered best method to diagnose. So if your study is compared with the MRI diagnosis, then it may be carrying more value.
Yes, sir.
scientifically?
Yes, it makes definite sense. So we compared with the current standard of care, you're absolutely right. So Dr. Like from Vadodara, I forgot, actually conducted a study with comparing that with MRI for about 110 patients. I wouldn't say they are statistically significant because most people coming for MRI already had symptoms and so on. We don't have results for young women in that because totally it was 110. There we actually got comparable sensitivity and specificity in that study published in IRIA. Tushar Vaishnav, sir, Dr. Tushar Vaishnav from Vadodara conducted. But yes, that would be interesting, and we are trying to work with University of Illinois to look at how we can. What happens in the US is exactly as you said. If a mammogram is showing high density, they are directed for MRI, right? And so we are working with them to create a protocol where any person who is going for such an MRI is first taking thermolytics and then goes for MRI. And we are hoping we can show a non-inferiority with MRI on dense tissue, right? And if any of the clinicians here are interested, I would love to do this study in India first, but I'm meeting them in Chicago next week for the same reason. But it's a great point. Thank you, sir. Yes, sir.
So, ma'am, thank you for a very innovative presentation.
Thank you, sir.
So, like a lot of experts believe that the manipulation of the breast, and particularly a cancerous breast, which a mammography entails, can lead to initiation of dissemination of the cells. So, a no-touch technique will obviously have the advantage of not touching the breast and not touching the tumor and reducing the chance of dissemination. And secondly, we are using neoadjuvant chemotherapy in a lot of breast cancer patients. And one of our yardsticks is whether the patient has a complete pathological response or not.
Yes.
So if we are judging the biology and the vascularity of the tumor by this technique, that would be a really good thing to study. Known patient of breast cancer receiving neoadjuvant treatment, and then what was the thermolytics at diagnosis and after completion of neoadjuvant chemo. So that would be a significant add-on, or maybe you do it every cycle because it is completely non-invasive. And if you don't see a response in the vascularity of the tumor, you may think of changing the neoadjuvant treatment or moving to surgery sooner rather than later.
Yes, sir. It's an excellent point. So I would love to discuss more.
After you finish, then
yes,
maybe
sir.
we can
So
do
in order to
that.
aid this, right, we also give this scores. Like one is the vascular pattern, which can definitely change across different chemo cycles, and even the scores will actually change. So we've recently come up with a longitudinal analysis. So across two, we can see are there new vascularity or new blood vessels that have formed, or has it? So the path response, it's a proxy to the path response. Would love to we have not done a study in that. Would love to experiment what you mentioned. Definitely, sir.
Yeah, so I have some say in the Indian Society of Oncology, a 3,000 member body of oncologists. So maybe we can think of a
Thank you so much, sir.
multi-center study.
Thank you so much, sir. Thank you, thank you. Any other question?
Any other question or comments?
Okay, I give 15 seconds back. Thank you.
Would like to make any comment? Thank you.
You want to comment?
Yes, yes. We have the next lecture by Dr. Arun Kumar Goel. He's a very well-known surgeon in northern India. He's talking to us about why young women with breast cancer need a different approach. Panel is thereafter.
Very good afternoon to all of you. My sincere thanks to Dr. Ashok Vaid and the organizing team for giving me this opportunity. The topic, why young women with breast cancer need a different approach. Basically, the topic suggests that I have to raise questions and that seems to be the easy part. But we have an elite gathering of oncologists, and majority of them very experienced in the field of breast cancer management. So they would probably all be aware of these questions, but I would try to do justice to the topic. So in my talk also there will be a lot of points which have been covered by previous speakers, so there will be a lot of overlap, but it may help me. So first and foremost question which has been brought out by the previous speakers also is one, the question of age cutoff, and we have seen age cutoff of 40, 45, 35. All three are used by different organizations, by different studies, and there is no universal sort of protocol. So that causes a problem in terms of different studies based on different cutoffs. So it's very difficult to compare data from one study to another. So that is something which I feel probably should be standardized, because it can help in comparing apples with apples. Because there can be a significant difference when the cutoff is 35 versus 40 versus 45. Overall, the proportion of young breast cancers, it has also been highlighted, is different. In the West, where it is less than 10%, some studies may say for a cutoff of 40, it may be 5%, 6%. But in India and a lot of developing countries, it has been highlighted by Dr. Nimmagadda, Dr. Amit also, we have a figure of close to 20% for women below 40 or 45. There are reasons which Dr. Amit highlighted, and we'll also cover them. Overall, breast cancer in young women contributes to the cancer burden in young women, which is about 30% or so. So it is a significant health problem, and a problem where we do not have a significant amount of prospective studies. A lot of data that we use is basically on retrospective databases, and to an extent we can say, okay, it raises hypotheses and questions, but we need to work more on those hypotheses which are generated and find out real answers. So why do we need to talk of a different approach? So there can be three reasons. One, the disease, whether the disease in younger women is different compared to those in the different higher age group, whether the patient, the biology of the patient is different compared to the older age group, and what about the other factors which may be related to the thought process, the psychology, the social factors and all, which may also affect how we treat cancer in a younger patient. So coming to, is the disease in younger women different? So broadly, if we see the conventional biology, so the types are similar, but the proportion is very different. So we have a higher proportion of the aggressive subtypes. The triple negative and HER2 enriched are significantly more common all over the world, and in India, where we have a higher proportion of triple negative breast cancers overall. So in younger women, as Dr. Nimmagadda was also showing, nearly 50 to 60% of younger women would have these two aggressive subtypes. Now, the other factor is, as Dr. Amit Verma also highlighted, the higher incidence of hereditary disease. And we'll just go into a little more detail about that. But the main question is, are there other biological characters that make it different? So the question could be, say, a triple negative breast cancer in a younger woman versus a triple negative breast cancer in an older woman. Are they going to behave differently, or a HER2 positive or a hormone receptor positive? So is the young breast cancer in general more aggressive for the same biological subtype for the same stage? So it is expected that it is probably more aggressive. One, that a disease which has become clinically manifest at a younger age is generally likely to have a rapid evolution of cancer and a rapid growth, to a clinically significant tumor burden. Then there is the other factor that this disease in a younger woman is usually more advanced. So we'll just see some data from retrospective studies, but this more advanced disease, is it related to delay in diagnosis? Is it related to rapid progression, or a combination of both factors? So retrospective studies have found that overall the proportion of higher stage disease, stage 2, 3, and 4, is significantly more in the younger patient population compared to the older patient population. So the proportion of metastatic disease, proportion of stage 3, stage 2 is higher. And for all subcategories, the survival outcomes are inferior in spite of more aggressive treatment. Overall, it has been found that the mortality in younger patients is nearly 40% higher than older patients. So we have this data which is from USA National Cancer Database, 2010 to 15, so fairly recent data. Patients were in two age groups, up to 39 years and 40 to 49 years. Nearly 45,000 patients up to 40 and 1,50,000 patients above 40. So the proportion of stage 2 was nearly 45% versus 30%, and stage 3 14% versus 7%. Higher incidence of triple negative in younger women, higher incidence of HER2 positive, overall higher proportion of mastectomy and higher use of chemotherapy. The odds ratios are high. So basically younger patients were being treated more aggressively overall, but in spite of that, all studies have shown that the outcomes are inferior. So there is this study from Japan, slightly older data, 2004 to 2006, nearly 25,000 patients. And the young breast cancer, basically the proportion, they took 35 years as the age cutoff, was only 3%. But the 5-year disease-free and overall survival figures were significantly lower in younger patients, 80% versus 90% and 88% versus 92 to 95%. And these are the Kaplan-Meier survival curves for the different biological subtypes, HER2 positive, triple negative, and luminal. And in each biological subcategory, the survival curves for younger patients were the lowest curves. So basically, the study confirmed that young patients have poor prognosis independent of well-known clinicopathological prognostic factors. So trying to search for other factors which could explain the aggressive behavior. So there is this study on genomic characterization which showed that the profile of genomic changes is different. So younger women have a higher incidence of TP53 mutation, BRCA mutations, HER2 amplification, CDK12 amplification. In contrast, older women are more enriched for PIK3CA and other mutations. Now coming to the issue of hereditary breast cancer, which is definitely significantly higher in younger age group, but different series are very difficult to compare because a lot of the available data is on selected patient populations where patients were enriched, basically referred for testing based on high risk underlying features. And there are few studies which have been carried out in unselected patient population. And the testing methodology, whether it was just BRCA testing or multi-gene panel testing. So broadly, Western studies have a 5 to 10% overall incidence of hereditary breast cancer. And in younger women, the figures reach 10 to 20%. In India, the figures are higher, 15 to 20% overall, and 20 to 30% in younger women. So we have this study which was carried out at IRCH Ames, and this is a consecutive series from a single center, and recent 2019-20, 107 genes NGS testing was carried out, and pathologic or likely pathogenic mutation rate was close to 19%, which is very, very high compared to the Western data, and this is not a younger patient population. So other than this, how is the patient different? So younger patients, they are almost always premenopausal, so the endogenous hormones do play with the disease behavior, particularly when the disease is hormone receptor positive. Again, these patients are likely to be interested in fertility preservation, future pregnancy, childbearing. The thing which may be slightly favorable for us is that they are generally healthy, comorbidities are very low. Again, the competing causes of death are significantly low, so which means that the possibility of cancer recurrence in the follow-up because of the long follow-up period and the competing causes being uncommon is likely to be high. And in addition, because of the long follow-up, we have to be worried about the long-term side effects of treatment. So again, these women may be unmarried, working women, whether job, sports, or other professionals, so their functional levels are important. Body image concerns are totally significant. We see many patients having marital problems as a result of cancer diagnosis and treatment. Anxiety, depression, sleep disturbances are common. And pregnancy and breast cancer is a totally separate group, which I will not talk about. One of the issues which has been raised is a question of screening, surveillance, and early diagnosis. So one, that younger women are not candidates for screening even in the Western population. Of late, 40 to 50 age group has been recommended for screening in some areas. But another problem is whether the screening is going to be effective in this age group because of the dense parenchyma. And since the disease is aggressive, whether if we screen, then a very sort of frequent screening may be required. I will leave this study. Coming to the long-term sequelae of treatment, which are going to be very important, arm and shoulder dysfunction, lymphedema, cosmesis and symmetry are major concerns. When it comes to radiation, long-term cardiac problems, coronary artery disease as a result of radiation to the coronary arteries, second malignancies after radiation, effects of chemotherapy in terms of neuropathy, marrow suppression, effect of chemotherapy on ovarian function, and the long-term effects of hormonal deprivation when it is used as a treatment in hormone receptor positive cancers. When it comes to surgery, there has been a debate whether conservation is safer, but overall it has been found that the outcomes for conservation versus mastectomy are similar. There may be a slightly higher incidence of local recurrence, but survival data shows similar outcome. Of late, Western countries have a higher trend for use of mastectomy related to probably Angelina Jolie effect and the fear or concern of skin cancers, contralateral breast cancers, and the feeling that a bilateral mastectomy with reconstruction gives a symmetric aesthetic cosmetic outcome and takes care of the breast cancer risk. Then there are considerations for future pregnancy, lactation, so which definitely affect the choice of surgery in women. And then issues about body image, sexuality, marriage. Another concern for younger women is that the change in aesthetics or cosmetics over a long period of follow-up where there may be weight gain, there may be ptosis and other factors which affect the cosmetic outcome. So this another study from National Cancer Database, women up to the age of 40 years compared conservation, mastectomy and mastectomy plus RT. So overall it was found that the survival for all three groups was similar. So there was no negative effect of conservation. So we can say that conservation is a safe option. Again, contralateral prophylactic mastectomy has been in most studies found not to have a beneficial effect on survival. So radiation, again, as we have mentioned, that partial breast irradiation is not recommended. Radiation boost again is considered significant because of the higher risk of recurrence within the breast. The issue about regional nodal irradiation is a slightly debated issue, but often considered more often in younger women. Cardiac protection is critical. Things like deep inspiratory breath hold would be very important. Systemic therapy, effect on ovarian function, germ cell reserve, effect of hormonal deprivation, long-term bone marrow suppression, they are all going to be important factors. In India, as we mentioned, that the younger women are 20% of breast cancer burden, higher proportion of hereditary disease. but resource limited settings are applicable to a lot of Indian patients. So what is the way forward? Increase awareness in the public, medical community, identification of high-risk women, more intensive surveillance, genetic testing, whether it should be mainstreamed or universally applicable to young women, and search for serum biomarkers for earlier diagnosis. One of the major issues is disparity, which is identified in the West also, but is very, very significant in India, and we need to really work hard on avoiding disparity and getting the benefit of the modern approaches to all patients as much as possible. Then patient choices and shared decision making is going to be a very important part of this management. Definitely a lot of research is required. Focus on long-term quality of life is critical. So with that, I would like to say that the field is open with a lot of questions, a lot of extensive research is required, and events like this are going to increase the focus on the issues faced by young women with breast cancer. Thank you.
Thank you. Thank you, Arun. Is there any question for him or comments?
There's a brief comment on there are precancerous conditions like fibrocystic disease or such are common quite, and they come with the lumps and they. So what is your approach? What should be the, because they are already known precancerous. So once you disclose that you are having a precancerous, there may be subsequent effect in the quality of life globally.
So I think basically one proper pathological diagnosis in terms of having an adequate sample, assessing the high risk associated with the benign or pre-malignant pathology, and patient specific advice. So you cannot really avoid giving any anxiety, but proper communication is always, I think, the way forward for this. Other than the medical management, communication is always going to be important.
Well, we have a panel discussion.
Yeah, I
soon
think there's a
after,
panel
so
discussion
we
also.
definitely would make some comments. Okay, thank you. So with this, we move on to a panel discussion, and Dr. Arun Kumar would continue to be on dais as moderator, and he will be joined by Dr. Vaishali Chambre.
Dr. Vaishali, please. Yeah.
Dr. Vaishali is again working with him in the same hospital, and both of them are great surgeons, very well known in India, particularly in North India, and she is oncoplastic breast surgeon. And for the panelists, let me read out. Dr. Ekta Dhamija. Dr. Ekta is additional professor of oncoradiology at All India Institute of Medical Sciences, New Delhi. We have a foreign faculty, Dr. Maria. She is a breast cancer surgeon and professor of Netherlands Cancer Institute at Netherlands. Welcome.
Yeah.
Anyway. We have Dr. Ruchika Kumar Goyal. She is Associate Director, Department of Lab and Pathology, Medanta, the Medicity Gurugram. And Dr. Geeta Kadyaprath. Is Dr. Geeta here? All right. Okay.
Dr. Geeta doesn't seem to be here, and Dr. Sunil Saini is also part of the panel.
It seems the panel is very much heavily loaded with surgeons, and I hope you will try to bring a balance, asking questions to the audience also. And the discussion is about challenges in staging and diagnosis.
So basically, when we are talking of diagnosis of breast cancer, we all know triple assessment is the foundation of diagnosis, and we have a panel which basically offers us the opportunity to go through the issues related. So we have two surgeons, Dr. Saini, Dr. Peters. We have a radiologist, Dr. Dhamija, and we have a pathologist, Dr. Ruchika. Okay. So, Dr. Vaishali?
Yeah. So when we talk about young women and breast cancer, there are, like we have discussed so far, there are concerns about delay in presentation, delay in diagnosis because of either the patient, lack of awareness on the part of the patient, or systemic, delay because of having low index of suspicion. Then of course there are certain issues related to interpretation of the investigation reports. So we are going to discuss these concerns, and we are also going to discuss whether there is any difference in the approach towards staging of breast cancer in young women. So let me begin with the surgeons first. So Dr. Saini, you represent an important city in India. We know that the level of awareness varies in the different strata of our society. So in your part of the country, how is the level of awareness, and what is the stage distribution in our in your OPD or in your clinical practice?
All right. Well, I would like to answer this question not as a surgeon, but as a layperson from the society, from a social science perspective. If we look at our medical education, particularly in India, we are never taught during our undergrad and postgrad studies that breast cancer can happen in young women also.
Yes.
That means there is a deficiency in education system. We have not changed with time. So this is something which needs to be addressed very
Absolutely,
soon. Okay?
absolutely.
And then there are many more partners into enabling us to get an early diagnosis. That is all healthcare providers, including nurses, including paramedics, including healthcare systems in general.
Yes.
So there is a need to focus to bring awareness amongst all these people. And all the discussion today here has been about biomedical sciences. But biomedical sciences helps us only when a patient visits to the hospital or a clinic or a laboratory. It doesn't help the community in general.
Yes.
So we have to go back to the community and bring these changes right from the medical education, nursing education, and setting up curriculum which enables us to make all these people aware
Correct.
in the change. So
Correct.
this is what I would like to say.
So now we know that breast cancer is increasing in young women in our country, so we should educate all the clinicians to have that index of suspicion and investigate a person with breast symptoms thoroughly to prove or to disprove that the patient has cancer. Please.
If you like, if you permit me to make another comment. Well, I've been practicing in Dehradun region for last 32 years. And the change which I have seen, 32 years back, every patient visiting me had advanced breast cancer. But today, in my hospital, we get 55% breast cancer patients who are stage 1 and 2. How this has happened in India, a country which was known to be underdeveloped or developing? Well, it's not only oncologists, it's not only doctors, but largely because of socio-economic development. A lot of investigative facilities, which may include simple ultrasound or simple, more healthcare professionals, more healthcare centers, and access to healthcare, including to the simple FNA, simple biopsies, and imaging facilities, all these things have enabled this to happen. So it is not linked only with biomedical sciences, it has got a lot to do with socio-economic development of a region or a geographic region.
Correct. So that leads me to Dr. Peters. Dr. Peters, in your country, I'm sure you would be seeing a lot of patients being diagnosed in early stages of breast cancer. Is that true? Or you get advanced disease as well?
You're completely true.
Okay.
Most patients that we see are early,
Yeah.
but we do see some advanced cases as well, which are either sort of missed by the patient themselves because they didn't want to feel or didn't want to do something with it because they were simply scared.
Okay.
That is a minority of the patients that we see.
Right.
And I think awareness can become greater in every country, also in our country.
Yes.
And not only by the people, that everybody can get breast cancer, all the women and a few men as well, but especially also what you mentioned by the medical professions.
Correct.
Because also, even in the Netherlands, the general practitioners, when they see a young woman with a lump, they basically think that will be a cyst or a fibroadenoma, and that should not be.
True.
If it's a proven cyst or fibroadenoma, then it's fine.
Yes.
But don't send somebody away before it's being proven.
Correct. So, do you get referrals from the GPs, the gynecologists, for patients who are young and have breast symptoms, or they diagnose and then send the patient across to you for treatment?
Well, actually, in our clinic, we set up a new sort of diagnostic clinic.
Okay.
So there, the patients are just being seen not within the hospital, but in a separate building. So that's really, well, low key. They can just sort of come. They have to be sent by the general practitioner, though. But it's they can come any day and have the screening there whenever they are feeling something, or sometimes when they have pain, although we all, of course, know pain is not a direct symptom, but it makes the person anxious. And so then sometimes it's also needed to do additional diagnostics.
Sure. And in your practice, do breast care nurses also play an important role in the diagnosis of breast cancer in these young women?
Yeah, we have some specially trained breast nurses, and actually they are physician assistants.
Okay.
So basically they do the whole process by talking about the diagnosis, the treatment plan. They're very active in the multidisciplinary team meetings, and they also do the follow-up of the patients a lot. So in our practice, the only thing they do not do is the surgery, for example,
Yes.
or of course, like the pathologist and the radiologist, you have them.
Got it.
But yeah, they do a lot in the breast cancer treatment in the Netherlands.
Sure, thank you. Thank you for your inputs. Over to you.
Dr. Peters, in your setup, do you feel that the younger patients that you get are coming with more delay because they have not thought about a possibility of cancer, or the GPs initially ignored? So do you feel that on an average they are taking more time to be diagnosed or reach you?
Actually, I don't really think so. I think that, as I started, awareness can be increased in every country, also in our country. But on the other hand, breast cancer is a topic which is being discussed a lot. Screening, we have screening from the age of 50. Once in a while, there are the discussions to have the screening already starting at 40. So then, because of those discussions, and the media is there for everybody, so the young girls and young women, they already sort of see and hear a lot about breast cancer. And it's easy to access a general practitioner. Yeah, so not that much delay, fortunately.
Okay.
Does screening produce a problem in lag time bias? Because there was media hype and all, when more DCIS cases were being diagnosed, and a lot of chapters on DCIS had been there, but actually these diagnostic tests finally reached.
Sir, I think maybe we can have that question discussed later, because the issue of screening and its shortfalls and all is a very big issue, and it will just take time from the current discussion. Dr. Saini, just one question again. So you said that in 30 years you have seen a lot of change in the spectrum. So you think this change is happening automatically as the country is growing economically in terms of communication, media and all, or let's say you have been actively doing awareness programs in the society and
Well, it's multifactorial. Everybody has contributed towards it.
May I just add on to that
Yes,
one
yes, Dr.
last
Ekta.
comment
Yeah.
which ma'am raised, which you asked whether young females get delayed. On the contrary, what we have observed is that if a young female has a palpable abnormality, they would report faster than the older one. They are
Okay.
not that ignorant because they have that cosmesis in mind,
Yeah. Okay.
that whether it will need removal, what has happened to me, especially the unmarried ones. So
Yes.
they report quicker as compared to the elder one.
So probably the doctor who they approach to has to also be aware that this needs evaluation, because many a times these women are actually dismissed as having a fibroadenoma or any other benign breast disease and not investigated properly, and that probably leads to injustice to that
So
person.
probably awareness has
Yeah.
to come on the other side of the road as well.
Please.
so once a patient comes to the clinician, definitely, as has been highlighted, the clinician has to think of a possibility of malignancy even in a young person. But then the question is about what should be the investigation sequence or protocol. So we would start with Dr. Saini. So say a young woman in say 25 or 30 years, you feel a breast lump, slightly, not very well demarcated. How would you proceed with the diagnostic workup?
Well, since I run a cancer clinic, so most of the time patients are already worked up before they reach to me. But I would imagine as if I'm sitting in a community clinic. So first is thorough clinical examination. And no doubt, as a surgeon, I wish every surgeon would be aware of the possibilities. So that's second thing. Third thing is to again investigate with simple means, and that would be still an ultrasound, not for a young woman, right? And a good one. That's all.
So Dr. Ekta, please.
Yes, so I agree with sir completely that for young females, we do not go to mammo as the first imaging modality. It is the ultrasound. And basically why? Because again, at the back of your mind somewhere that benign entity and fibroadenosis is there, and you want to rule out whether it is just cystic changes happening. And if it is solid, then we'll take it from there. But yes, ultrasound stays as the first modality of choice.
And when in young age group would you recommend a mammogram to be done?
Whenever ultrasound is suspicious.
Okay.
So in that scenario, if I think that it is BI-RADS 4C or 5 category, when my index of suspicion is high, I also want to rule out any microcals associated,
Right.
any
So
DCIS. So I would recommend mammo.
Yeah.
Just if you allow.
Yeah.
Here I would be very sensitive. Even before I give a little hint to my patient that you may have cancer, because I have no right to scare a young woman until I'm sure and until I get a good quality ultrasound. Only then I would move on to consider doing anything, because we have to remain sensitive about giving such a message to a young individual that you may have cancer. So we have to be very careful about it.
So Dr. Ekta, when we are talking about ultrasound, so if we say you are in the premier institute and the level of training exposure is different, but we take all over the countryside. So the quality of equipment, the quality of training in breast assessment. So do you think there could be cases where ultrasound may be missing a diagnosis?
Definitely, sir, and it's not for the institute. Even our first year residents miss a lot,
Okay.
especially when it comes to fibrocystic versus DCIS, because many a times imaging
Yes.
features are overlapping. And when it comes back for review after 3 months, and if we are saying we are confident that yes, this was missed and it was kind of a DCIS, shouldn't have been labeled as fibrocystic disease. So ultrasound, that is why probably is not the you can say a screening tool, because it is highly operator dependent of who is operating and what plates they are giving. At times they do not give the representative image so that the second reader can actually identify. That is where the other cross-sectional modalities perform better.
Dr. Peters, in your setup, is the ultrasound done by the radiologist or a sonologist technician?
In our clinic, it's done by the radiologist, but you wanted to add something to the...
I just wanted to raise a point, just to continue with what Dr. Ekta was saying. Even after ultrasound, especially when it is coming from whatever center, be it peripheries, be it metros, young patients, if you have those nice circumscribed lesions, sometimes they are misdiagnosed as fibroadenomas. Yes. So the call needs to be taken there, because see, mucinous carcinomas, IDC grade 3 can look very similar. I mean, you're the radiologist who knows best, but those pushing borders and all in a young patient, and if it gets left out, if a biopsy is not done, we might be missing an early breast cancer in such patients. So just
So then the diagnostic ultrasound is being performed by the radiologist, but we as surgeons do use the ultrasounds more and more, not in diagnostic, but around surgery or response.
So I think the important point which is to be highlighted is the clinical and imaging correlation. The clinician who's ordering the investigation has to really think, in spite of a normal report, whether the clinical suspicion is strong, a repeat investigation, a review ultrasound, or any other imaging is required. So that concordance or discordance is something which the treating clinician should be particularly focused on to avoid delaying a diagnosis.
Yes, and the message which we are also sending from our specialty to our residents is, as Sir said, when it is a younger female and you see anything, just red antennas should, get, if it is not a simple cyst, just a red alert should be sent to either of the consultants around, instead of just sending her away as BI-RADS.
Correct. And the communication, to and fro communication is very critical. So, Dr. Ekta, a quick word about your, opinion about contrast enhanced mammogram and MRI to not miss a breast cancer.
So this is totally personal perspective, I would say. There is a lot of literature about it. We have not yet studied specially for the young females. We have done the off-late recent of 150 patients with dense breast, irrespective of the age. Screening, surveillance, as well as diagnostic population, all included. What we have realized is that CEM is good enough.
Okay.
Personal preference, why? Because I don't have to rush the patient for another date.
Yes.
It is then there in 8 minutes in front of me. And I am avoiding the focus enhancement, which is what raises trouble at times in MR. And this is the issue which will be discussed in the next upcoming BI-RADS, that focus term needs to be removed, because contrast mammo doesn't have that much of soft tissue resolution. So whatever enhancement it is showing has to be looked into.
Right.
It is not giving those nodular enhancements which otherwise in MR we used to keep hunting and looking for. So that way, for dense breast, whenever it is a problem solving statement, it is NPV has gone to 100% for us.
And I think ease of biopsy also would
definitely
over MRI,
because at the end you are doing second look ultrasound for either patients, and now we will get CEM biopsy also based on the requirement, and it is easier definitely than ever.
So we'll come to Dr. Ruchika now. Dr. Ruchika, just straight away, would you sort of say that there are any problems in making a pathological diagnosis in a young woman in terms of the background changes which may be present in the breast in terms of fibrocystic disease, or sometimes lactation related changes, or hormonal intake that the patient may have?
So a biopsy is definitely a better modality to see these changes, especially lactational changes, because inflammatory breast cancers, IDC grade 3s generally are seen, and on FNACs you can have even benign cells mimicking malignant cells. Also, high-grade lesions, because they have high proliferative rate, they have a lot of necrosis. Now, a biopsy would still help to define if it's a tumor necrosis, but in FNAC, what happens when you just see that necrotic background, and if the patient is lactating, one might just miss it as an abscess or a galactosele or things like that. So, definitely, young breast cancers, what we are seeing are generally more aggressive and high grade.
Yes.
So, biopsy is preferred.
Is a Ki-67, it's supposed to be somewhat subjective, not well standardized. Is it more difficult to give a Ki-67 value in a younger patient, or?
No, it's not more difficult, but I agree with you, sir. Ki-67 is subjective. There is a lot of AI coming in, but at the moment, eyeball rolling is the one, and yeah, that's.
Yeah, now we'll move on to the surgeons. Dr. Peters, your take on, do you, when it comes to a young woman with breast cancer versus an older woman with breast cancer, is there any change of protocol for axillary staging in your clinical practice?
No. Basically, we do axillary staging by ultrasounds during the same time as the ultrasound of the breast is being performed already. And not only of the axilla, but also of the periclav region and sometimes peristernal. And that's the same in young as in old.
Is the same.
Yeah.
But do you find it difficult in younger women to accurately stage the axilla versus an older person? Is that so?
I don't have data on that,
Okay.
and I never hear that back from our radiologists
Alright.
that they. No, I don't think. And of course, when there's something, when there is a pathologic note, but that's the next question, I think, how to deal with that. Yeah.
Sure.
But just looking at the notes, I think it's similar in the young compared to the older ladies.
All right.
So, Dr. Sani, in your setup also, are you using a routine preoperative ultrasound of the axilla, ultrasound guided FNAC to stage the axilla?
Yes.
Yes.
Very much. Same way as we do for
Same way,
adults.
okay. And in a younger patient, say recommendations based on Z11 and all, say a single node macrometastasis in a good biology, would you avoid the axillary dissection if the patient is young?
Well, I would say it's too far-fetched for our setting, okay? And we may find only few patients like that. Certainly, I would like to avoid that, but we have very few patients having that scenario, clinical scenario.
So, Dr. Peters, when it comes to Z11, do you triage the patient based on the age, or do you apply the same kind of, criteria for whether you would not do axillary dissection if you find low axillary burden in sentinel node biopsy, even in young women?
Yes, well, I think the Dutchies are really de-escalating axillary treatment. Yes. We barely perform axillary clearances anymore. Okay. I'll come back to that a little bit later in my talk as well. So, yeah, we're actually even sort of thinking the other way around. What woman still needs an axillary clearance? So identifying those indications.
I think since we are running late a bit, so we have to close it soon. Just one question to Dr. Sani. Say in a young woman, do you routinely do a more aggressive staging workup?
No.
No. Okay, I think then we'll close here. There are a lot of issues which could be discussed, but since we are standing between lunch and all of you, we'll just say curtains.
Thank you to all the panelists.
All the panelists. And once again, thanks to Dr. Vaid for giving us this opportunity.
Thanks everyone. I think we regret this delay, but we'll break for lunch and come back in 20-25 minutes. Thank you.
नहीं छोड़ रही हैं? Now there is onco radiology department.
Hello. Hello. So good afternoon to all of you. So we are starting the post-lunch session. It's session number 4. So please be seated so we can start the session. The session is tailored cancer therapies and toxicity management. And I would like to invite chairperson for the session, Dr. Mary Jane Rankin Peters from the Netherlands, and Dr. Professor Sanjeev Mishra sir from the Lucknow. I request to the chairperson to invite the speakers for the session.
Good afternoon. It's a pleasure to introduce our next speaker, Dr. Sudeep Gupta, who's Professor of Medical Oncology and Director of Tata Memorial Center, and he'll be giving a talk on tailored treatment options.
Good afternoon, ladies and gentlemen. I would like to thank Dr. Rakesh Kumar and Dr. Ashok Vaid for your kind invitation to participate. I bring you greetings from my institution, and the hospitals are located all over India. My remit is to talk about tailored treatment options, and I have strived to do that only in the context of young women. Those are my disclosures. So we have heard repeatedly throughout the day that young breast cancer is biologically and clinically distinct, and I will not belabor that point further except to say that there is a real biological difference in the tumors that happen in younger and older women. This is an analysis that we performed several years ago, and we showed that in a single year's cohort at our institution, the proportion of patients with triple-negative breast cancer was much higher than what was being reported from the Western countries. We also showed that among women who were younger, the proportion of TNBC was higher compared to older women, and now, of course, this has been repeatedly shown by many other groups as well. A few years ago, my colleague Dr. Jyoti Bajpai and several of us reported our outcomes and challenges in young women with breast cancers from a single tertiary institution. We analyzed the data of 2 years, 2015 and 16, and we found that of the 8,634 patients, 16.7% were formally young by the age criterion of 40 years, but a fairly high proportion was actually very young, younger than 35 years of age. As would be expected in a country like ours and a hospital like ours, which is a large public sector institution, we had women with aggressive biology, higher nodal status, tumor size, grade, and so on. And what was telling was that of the 1,228 patients that we analyzed, only 38 belonged to stage 1. So this, of course, attests to the need for early detection even among younger women, and I say that cognizant of the fact that there are no proven early detection or at least screening strategies among these women. We showed that the 5-year survival, the event-free and overall survival were close to 60 and 80%. But when we broke it down by stage, we saw that women with earlier stage disease had better outcomes compared with those with more advanced stage disease. And of course, that brings us to the question of germline testing and its therapeutic implications. We know that universal germline genetic testing is recommended for most women with breast cancer, especially those who are young. And of course, there are several implications, such as the PARP inhibitors, sensitivity to platinums, risk reducing strategies, and also the choice of neoadjuvant treatment surgery and several other implications. This is data that has been reported by the All India Institute of Medical Sciences in Delhi, and they performed germline testing in 236 patients, consecutive patients, unselected for family history or any other characteristic. And you can see that they showed 18.64% pathogenic or likely pathogenic germline mutation incidence, which is fairly high, 1 in 5 patients. Of course, 3/4 of these were BRCA1 and BRCA2, but there was a sprinkling of mutations in genes belonging to the homologous recombination repair pathway. And that then brings us to the Olympia trial, and we now also have the overall survival results as well as the disease-free survival, and both of them show not only a statistically significant but a clinically meaningful improvement with maintenance with olaparib after routine treatment among patients with TNBC and ER-positive disease, HER2-negative ER-positive disease who have high-risk features. Generic olaparib is now available in India, and so it has become accessible to a fairly reasonable proportion of patients, and there are some plans to incorporate it in the Ayushman Bharat scheme as well. What was interesting about the Olympia trial was about 57 patients who had second malignancies, and these were not only breast cancer and ovarian cancer, but a sprinkling of others. So we must be cognizant of the possibility of this situation. Let me talk a little bit about triple-negative breast cancer, and I will do only the clinical implications in TNBC because we had very nice talks in ER-positive disease earlier today. We evaluated the risk factors, the epidemiological risk factors of development of TNBC in our patients. We did it as a 2-center study, and we found that central obesity as measured by the waist-hip ratio was preferentially associated with luminal type disease, whereas lower socioeconomic status was strongly associated with the incidence or with the risk of triple-negative breast cancer. So although we lump the risk factors for breast cancer together, it is likely and it is possible, and others have also reported, that there may be differential risk factors for different subtypes of breast cancer. We also performed a multi-omic longitudinal analysis in 3 patients with triple-negative breast cancer, 2 of whom had a germline BRCA1 mutation, and we performed serial biopsies right from the time of their initial diagnosis and surgery right up to repeated relapses and death. And we subjected those samples to deep sequencing by multiple omics, and we found that these tumors have a branching pattern of evolution with a founding clone that persists throughout the life course of these tumors, and perhaps also confers some degree of resistance to repeated treatments. We also found, and the top panel for these 3 patients are the tissue samples taken at various time points, and the bottom is the ctDNA. We also found that ctDNA presents a more complete picture of the tumor compared with tissue biopsy at the same time point, and that point was made earlier today, that ctDNA is a reasonably good way to monitor disease and incorporate it into decision making, not today, but with further evidence and validation. Just a couple of weeks ago, we published our randomized control trial of platinum in the neoadjuvant setting in triple-negative breast cancer patients in JCO. And most of you have heard these results earlier. But the point that I want to make today is that there was a sharp differential of effect by age and also by menopausal status. This is PCR, substantially higher with platinum in younger women, but not in older women. And if we look at the survival, on the top is event-free survival, and at the bottom is overall survival, we see that there is a nice high degree of benefit in terms of both OS and EFS in premenopausal women, but there is no benefit in postmenopausal women, and this is the same if you break it down by age. Now the question is, why should, in a disease like triple negative breast cancer that has got nothing to do with, or at least that is not conventionally known to be associated with menopausal status, why should there be a differential effect of platinum? So this is not simply a BRCA, germline BRCA mutation enrichment effect, and investigators from the GAPAR-6 have shown that very nicely. It is possible and likely that TNBC tumors in younger or premenopausal women are enriched for a highly proliferative phenotype that is basal-like or HRD high, and also it is likely possible that the immune environment has got something to do with the impact of chemotherapy in young patients. We and several others have shown that there is a higher proportion of luminal androgen receptor-like tumors among older women who have TNBC. This is a very nice study. They perform molecular analysis of TNBC in young patients and in elderly patients, and you can see on the y-axis is the tumor infiltrating lymphocytes, and in younger patients there was a higher infiltration by TILs, and this was true primarily of tumors that were HRD high or basal-like, but not in tumors that were HRD low. So essentially the classic triple negative breast cancer that is shown to be basal-like or HRD high have a higher proportion of TILs among younger women compared to older women, and this might facilitate immunogenic cell death when you add platinum. And of course we have seen the results of the KEYNOTE-522, and pembrolizumab was beneficial. Now there are overall survival results. But I will request your attention to the fact that in the subgroup analysis, the benefit was nice and tight in younger women younger than 65 years. But if you see older than 65 years, of course, the numbers are very small. Nevertheless, there is a hint there that even immune checkpoint inhibition, its efficacy in older women is somewhat questionable. So I have summarized here the use of platinum in non-metastatic triple negative breast cancer. In neoadjuvant, we and several other trials have shown that there is a benefit, and I think we must use platinum in the neoadjuvant setting. I would say we would definitely use it in younger or premenopausal patients, but because of the KEYNOTE-522, its use is also entrenched for older patients as well. Earlier this year in ASCO, we had the presentation of the NRG trial that tested for adjuvant platinum as an addition to anthracyclines and taxanes, which means patients underwent surgery first followed by chemotherapy, and there was no benefit either in disease-free or in overall survival. But we also have the Chinese pattern study that showed that if patients for some reason cannot be given anthracyclines, we can use taxane and platinum as a reasonable substitute for them. So that's the pattern study. And of course, we have the EA1131 trial in the post-neoadjuvant residual disease setting, and there capecitabine was clearly superior to platinum, so there is no role of platinum in that setting. So I will just summarize. Neoadjuvant chemotherapy is used in most younger patients with the use of platinum and, if possible, pembrolizumab. There is compelling evidence for the use of olaparib in germline BRCA mutated situations. We don't know about HRD high or somatic BRCA. And of course, there is also a strong rationale for using capecitabine if there is no PCR. Let me change tack a little bit and talk about adjuvant decision making in young women with ER positive, HER2 negative breast cancer. And we heard an excellent talk from Dr. Malhotra earlier, tracing the entire history of this genomic testing. I will just present to you 3 results. This is from the TAILORx trial, patients less than 50 years. And you see, this is patients with intermediate recurrence scores of 16 to 20. If the clinical risk is low, there is still a benefit of chemotherapy. If the clinical risk is high, there is a benefit of chemotherapy. Between a recurrence score of 21 and 25, whether the clinical risk is low or high, there is a benefit of chemotherapy. And the way they tested for clinical risk was by a combination of the conventional grade, nodal status, and tumor size. So genomic testing alone is not useful. Even in clinically low risk, genomically somewhat lower risk, there is still an additional benefit of chemotherapy in these patients. This is the RxPonder trial in node-positive disease. Again, breaking it down by menopausal status, a benefit of chemotherapy, but no benefit of chemotherapy in postmenopausal patients. And this is the MIND-ACT trial. Again, analysis by age. There is a benefit in younger patients, benefit of chemotherapy, but no benefit in older patients. So my take on these results is the following. I think the chemotherapy benefit is strongly modified by ovarian function, not just by chronological age. And of course, as was mentioned earlier, ovarian suppression is likely the most plausible mechanism for chemotherapy benefit, but we must not discount the fact that there may be higher cytotoxic effect as well in younger patients. We know that ER-positive tumors in younger women have higher proliferation, more luminal B-like biology, and of course there are also age-driven immune and microenvironmental differences between younger and older patients. So maybe because of ovarian suppressive effect, but maybe also because of higher chemosensitivity, there is a benefit of chemotherapy even in genomically low risk younger patients. There are several other issues. They were mentioned earlier and I will not discuss them. I will just share with you another piece of data from our center. This is the pregnancy-associated breast cancer registry that was again set up by my former colleague, Dr. Jyoti Bajpai. And we had 104 patients of pregnancy-associated breast cancer, 34 of them antepartum, 70 postpartum over a 7-year period. And we found that for a number of reasons that have been well documented by others as well, pregnancy-associated breast cancer patients present in advanced stages and there is a delay in diagnosis. The outcomes were as they are in other series, and I'm not presenting to you the details because of paucity of time. Obstetric and fetal outcomes were good, and it was safe to give anthracyclines and taxanes beyond the first trimester. The last 4 slides, we recently completed the DBT-funded virtual National Cancer Institute study to decipher mechanisms of hormone therapy resistance in breast cancer. You can see that there are 5 collaborating institutions all over India. I was the overall project coordinator. We recently published the results of this collaboration. We used whole genome sequencing to look at the mechanisms of endocrine therapy resistance, and we used tumors that were resistant and sensitive. We used liquid biopsy to monitor and decipher endocrine treatment resistance. We developed PDX models from resistant and sensitive tumors in Tata Memorial Center as well as with our collaborators. And we are about to publish also the proteomic correlates using high throughput proteomics of endocrine therapy resistance. So I will like to thank all my collaborators and colleagues from Tata Memorial Center and several other institutions, and thank you very much for listening to me.
Well, that was a very impressive talk. Is there a question from the audience?
Yeah, so you did mention, thanks for a lovely talk, Sudeep, as always. You did mention about the genomic assays which we use. So if there is a clinical and a genomic assay discordance, how much weightage do you give to Ki67? And can it be a substitute for the genomic assay test?
So in general, without regard to young patients, I think in single institutions with reproducible results with the same pathologist doing it, I think Ki67 is very good. That's what I use. And I also use, it is not just only the Ki67, it is also looking at the complete tumor pathology, including the strength of expression of ER/PR, lymphovascular invasion, nodal status, tumor size, and several other features. And I have long held that I don't feel the need for genomic testing in the overwhelming majority of patients. Now in young patients, as with genomic assays, Ki67 is perhaps not the most important predictor of chemotherapy benefit. So I use Ki67 less often in younger patients than I do in older patients.
Clear. Thank you. Oh.
How do you recognize the basal phenotype? Normal tests, what we subject patients, except genomics, we do not make them out among the TNBC because Ki67.
So there are some immunohistochemical surrogates of the basal type, like the basal cytokeratin expression and others. But there isn't a good way of accurately classifying triple negative breast cancer tumors as basal-like except with gene expression profiling. There are some immunohistochemical, especially the basal cytokeratins, EGFR and others, but we don't do that in clinical practice.
Well,
recommend during endocrine therapy to continue with the ESR testing as a early point of relapse.
So your question is whether I recommend ESR testing during endocrine therapy.
Because after 6 months, most of the cases gradually those who become...
So I suppose you are referring to the metastatic relapse setting. We recently had the results of the SERENA-6 study that showed that emergence of ESR1 mutation in patients who were clinically and radiologically still not in progression, and changing treatment based on that did impact the outcome. I don't do it. I'll tell you why I don't do it. Not because it can't be done, because at least in my center I don't have the access to those modern SERDs that have actually shown that benefit. So why do a test when I cannot act on it? Those medicines are still not, those drugs are still not licensed in India. They have to be imported. They are extraordinarily expensive, so I don't do the ESR1 testing.
Thank you, Dr. Sudeep. Thank you.
Yes. Okay, so now I'm honored to introduce the next speaker, Dr. Luis Costa. He's a professor and director of the Medical Oncology Center, the Institute of Molecular Medicine in Lisbon. And he can talk basically about everything. What are you going to be talking about now?
Okay. Now I have 2 minutes left. Thank you so much, Rakesh. Thank you for the invitation. Dr. Ashok, my dear friends, thank you for being here. So this is a tough topic. So what I decide is back to the principles and share with you some thoughts, okay? First, a few years ago, I tried to put myself in the mind of a young woman that was going to search in internet things about the recent diagnosis of breast cancer. Let's go to the American Cancer Society page, for instance, okay? What she could find, first of all, that the 10 years survival rate can be 95% if detected by mammogram, is 85% if the lump is the first sign. So often the young woman detect by self-detection. So they became scared with that. Second, if it is stage 1, 99% chance of survival. If it is, but roughly you can have 62% percentage of diagnosis at early stage. Only 2/3 of the patients are diagnosed at early stage. So another thing that can scare the woman. Okay, let's going to move forward. And they're going to go to see that the percentage of survival, the odds of survival is totally different if it is stage 1, stage 2, 3, or 4. And now she starts to think, which stage am I? What happens if I'm going to migrate to stage 4? How long I'm going to survive? And they also show that the survival in stage 4 is improving, but the curve is still declining. So My last conversation with one of my patients before I came here said, I have 4 years of stage 4. How many years I'm going to live more? And she has a kid who is 6 years old. So these are important questions. And I think that the foundation is here also to help to answer these questions. Not only provide information, but also provide some science to answer some of these questions. Okay, so having said that, back to the principles. This is the natural history of breast cancer, of any cancer if you want. But with breast cancer, I think everybody agrees that about 20 to 30% of the patients, despite of neoadjuvant or adjuvant therapy, can relapse and have metastatic disease. The cancer is much more curable if it is early detected, definitely. But when we talk about young women, many of them, they will appear with metastatic de novo, because that was the first symptom they had with bone pain, and they detected was a breast cancer. And if I'm going to talk about predicting response, I have to talk a little bit about the situation of neoadjuvant, adjuvant, just a little bit, and mostly about predicting response in metastatic setting, okay? Okay, neoadjuvant and adjuvant, which is the master? I think the master is this man, Bernard Fisher, a surgeon. A surgeon that for the first time he said radical mastectomy was both too much and too little. Too much as a surgery, too little as a planning to cure the patient. Because you need what? Adjuvant therapy. You need to think about the disease as a systemic therapy in most of the cases. Either endocrine therapy or chemotherapy, we will see it, but nevertheless have a complete perspective about the disease. And I think for young women, we are changing a little bit in getting in the more elaborated this concept of adjuvant. Why? Because we are moving from the concept of surgery followed by adjuvant, at least in young women that are triple negative and HER2, definitely for the concept of neoadjuvant surgery. Why? For many reasons. It's not only because you can facilitate a better surgery, but because you can detect resistance. And by detecting resistance, you know what to do after. So I think this is an important concept in young women. If you have the chance to do neoadjuvant therapy, don't lose that, because you know what is going to happen to that woman in long term. Okay? And this is well proven by meta-analysis regarding the pathologic complete response as predictive of survival for these patients. Okay? So now let's remove what happens if unfortunately the disease migrates to other organs and becomes metastatic. And the scenario can be totally different. Depends on the organ that is affected, depends on the biology of the tumor, depends on the time. So I put that in that slide. Time, volume, and tumor biology explains you what's going to happen somehow. Time depends if the relapse is 1 year after or 10 years after. Volume depends if you have polymetastatic disease or oligometastatic disease. And of course, tumor biology, if it is a triple negative or it is a luminal A. And definitely, our decisions will depend as doctors from these three factors as well with patient's preference. And roughly, until now, for triple negative, HER2 positive, and luminal, we can speak about these numbers. Median survival of 5 years for luminal, median survival of 5 years for HER2, median survival of 2 years if it is triple negative. This is the bad kid in the block. Okay, so what we need, according to biology, we need good pathology. I was very happy listening to the previous conversations because, okay, if it's everything, previous biology, pathology is very important to tell you the biology of the tumor. But this is changing because HER2 used to be yes and no. Yes and no 3+ or 2+ with amplification. Right now, there is a range of things that can happen with interpreting HER2 that tells you that the patient can be treated with other drugs. So this is important. And we still do our classification as medical oncologists, that's what I am, from our patients, picking up the three big groups, HER2, triple negative, and ER positive, and BRCA tumors that could be both triple negative or can be anyone, as you know. And then you put the drugs over there. You put the drugs, And you think as you can use these drugs either in adjuvant, neoadjuvant, metastatic setting. And the question is, can we use with the biomarkers to predict who is going to respond to what? In some cases we do. But for instance, let's go and give you the example. You probably saw these slides in many meetings about the evolution of HER2 treatment disease. Besides HER2 expression, because this is about HER2 overexpression disease, there's no other marker here. Everything is dependent just on pathology here. So you have a range of evolution of discovery of new drugs, but the marker is still the same. And even without HER2 overexpressing, now we can use ADCs, because the ADCs came to treat almost all breast cancers, if you need a medical treatment. And indeed, this is a new concept. I just learned recently that the chemotherapy that is linked with the antibody, it's not selected by the drug companies, it's selected by the linker. The linker tells you which are the chemotherapy that you can attach to the ADC. Most of cases are topoisomerase 1 inhibitors. And these are fantastic drugs, but if you see the data over there of this CT scan, it ends today, tomorrow, 3 years from this CT scan. There was a patient that died on the day after this CT scan with an ILD due to TDX. Okay? She was a aeroplane pilot. Okay? Very young woman. And indeed, this is becoming a big problem. I was telling to Michael Gnant, just some doctors get together all over the world to discussion of the question, it's called the Hermione Project, the discussion of the question of the widespread use of TDX is going to create a big problem for ILD all over the world. And we have to train the doctors how to detect earlier, or to select any biomarker how to detect earlier. Because in many cases when the patients came with symptoms, it's already too late. What about the luminal one, luminal breast cancer? Do we have markers or not? We have more, because we have ER, just recently was discussed, we can have mutation of ER, we can have PIK3CA as alpelisib, we'll have an oral presentation next San Antonio, and nevertheless, even here, the TDX and other CDX, sacituzumab govitecan, are coming to the field. We have new kids in the block. Definitely, we will not need any biomarker to treat the luminal breast cancer in the future, because these drugs will have the role on this therapy already. And what about triple negative? To finalize, that triple negative, I think we have two markers. One is HRD classification, and the other one is PD-L1 if it is metastatic, not in neoadjuvant. So, and ADCs, as you know, can be used in triple negative, as it is here with sacituzumab govitecan, that changed a little bit the figure for triple negative. Okay, but you also can use the TDX even with HER2 low. Okay, so let's go and make these things more happier. What about Nobel Prize? We just heard the Nobel Prize today in the morning, talking about proteins. What about Nobel Prize? What Nobel Prize can bring to breast cancer? I think in triple negative they brought the immunotherapy. Why can't we do it in luminal? Why not? Since we're telling here, many people told that these patients have probably more immunogenic tumors if they are young. I think one of the big questions is that everything that we test in cancer starts with metastatic setting. By ethical reasons, you have to test first in metastatic setting. And in metastatic setting, we are talking about a big volume of disease, big heterogeneous, more than that, a big metabolic change in the host. The host is immune suppressed a lot. It's not only the tumor that is cold, it's the host that it is cold. And so that's why it's virtually incurable to treat metastatic breast cancer. But can we cure or prolong the life in metastatic cancer? If I was going to ask you, who does have a patient that has lived for 10 years with metastatic cancer? Raise your hand. Okay, at least 3 of us, 4 or 5. We do have these. And could we do that for other patients or not? Okay, so how many minutes are 6 minutes, okay, I'm okay. Let's go and imagine that in this protocol that I'll show you in a while. Unfortunately, this patient passed away last March, full of bone mets, as you can see over there. And she was doing a protocol with liquid biopsy in large sense. Not only in ctDNA, as you can see, the PIK3CA mutation here disappears at 3 months. Very good response to a protocol that when she started, there was the cyclin inhibitors at the beginning with ribociclib, letrozole, ovarian suppression plus denosumab. And you see that the CTC is going down, disappearing in the blood. I'll tell you how we captured the CTCs. And we were measuring not the tumor microenvironment, but in the blood, 64 populations of the immune system. And among them, she asked me, do you have results for me? I say, I can see that you have Treg cells decreasing. I don't know what that means. Say, why do not know? Because I need to health volunteers to see if what is the normal in healthy volunteers. She said, I'll bring my friends here. So all these spots are the friends of Joanna, okay? And definitely we saw that when you are well succeeded with the systemic therapy for metastatic breast cancer, you change the immune system in the host, even in peripheral manner. You see the decrease in Treg cells, and I hope that the recent Nobel Prize can change that. Because the newest Nobel Prize in medicine was about the immune system and Treg cells. So you have to have a different approach about the immune therapy, not only with activating lymphocytes, but probably change the coldness or the hotness of the system in the host. And again, by the CTCs, in this case, for instance, Michael Grant is not here. So he's right about CTC is not so good as ctDNA. But for instance, for HER2 breast cancer, and look at here, the breast cancer that progressed at 3 months. And you can see that there is no more HER2 positive CTCs in circulation. You cannot use ctDNA to detect HER2 positive CTCs. You can use CTCs for that. And as you see is clonal evolution. And that woman, that lady that unfortunately passed away, tell me, please control me the tumor because I want to make a trip. Here he is making the trip here. Okay? That was Sandra. Okay. So we decided also to look for these CTCs, whether they are or not on EMT process. As you can see that some of these from breast cancer, they are cytokeratin positive, others are vimentin positive and cytokeratin negative. And we can see that there is a correlation with survival, according to the number of CTCs. And I was hoping that probably the youngest, look to the left first. CTCs correlates in first line and second line with survival in these patients. Look to the right. I thought that the CTCs on EMT were more frequent on young women. It's the opposite, are more frequent in oldest women. You didn't know that about Rakesh. This is new. So why the CTCs that are in EMT process are more frequent in older women than young women, I do not know. Is a property of the tumor, or is a property of the tumor that came from that host with different age? We have to think about that. Okay, finally about the oligometastatic situation. I think this is one of situations where you can have patients living for 10 years, something like that. And I was wondering the question, do we have a patient that can live for more than 2 years without progressing from oligo to polymetastatic disease situation or not? So we did an analysis with Illumina for several tumors, comparing oligo-stable to oligo-poly, and the heat map is totally different. So these are the bad genes, these are the good genes. So there are a heat map. Now we are validating that with JCAM, with a different cohort validation. So hopefully you're going to have with the clinical and with some genes, about to 10 genes at most, have an algorithm that will say, okay, this is oligometastatic disease, but will stay oligo. Please don't worry, don't intensify so much systemic therapy, go more for surgery or SBRT, something like that, okay? And the opposite, the others can be the dangerous one. It's also true, and we published that in our journal, that young women have a different immune system, even measured by the peripheral system, usually is more active. It's also true that we would like to predict the response to CDKIs in these women, and this was the project I told you with CTCs. So a guy convinced me to do this 5 amino acids concentration by machine learning. This is a guy from Cambridge, Well, and he told me that the most common proteins in circulation, and we had here a guy of proteins in this morning, are albumin and IgGs, and said, Luis, with these 5 amino acids, I can tell you what the immune system is going to respond to the CDKIs. And we published now last June on Nature Communications this. Indeed, it's more than 90% predictive of response to CDKIs. And indeed, when you're going to see the previous papers on CDKIs, one of the mechanisms is the inhibition of Treg cells. It's not only attacking the tumor, it's also inhibition of Treg cells. And right now, we're going to use the same system to predict ILD. Why? Because these 5 amino acids concentration cluster in a different manner if it is virus, tumor, or self-immunity. So probabilities can help us to detect which are the patients in more prone to have ILD. Okay, finalize patient's preference. Okay, 2 slides. One, I just kept this one from a large trials just to tell you that these are the symptoms that patients often report. You know it. You know, vasomotor symptoms, brain, the sexual dysfunction, pain, and so on. And how many patients were in these trials? 5,000. How much completed until the 2nd year? Less than 2,000. And the same Joanna that had the bone mats one day told me, I'll do for you the questionnaire, but this is boring. Okay, why is boring? Well, we published that in Annals of Oncology, showing that the quality of life does not go up. I'm finishing. Does not go up with endocrine therapy. It's boring because they don't feel represented over there. So we are trying to develop a new concept of quality of life. And the new concept is that the patient selects the things they want to do on the next month, next year, and we're going to create a bucket list that you can put an app. And they tell you, the patient, when you have in front of you the patient, you know, these are the 5 or 7 things that you wanted to preserve with the treatment. And that will be not only for the efficacy of treatment, but also for the safety. To finalize, I think it's the impact of new therapies on survival to look at that. Liquid biopsy will need that to detect the dynamics of the tumor in metastatic setting. We have to really find the biological traits of each one of the subtypes, and particularly study new strategy for patients with oligometastatic disease in the future, and how to protect quality of life for these patients. And this was the lady who convinced me to convince Rakesh to create a foundation. Okay.
Thank you for a wonderful presentation. We can have one question, even though we are running late, if there are any.
Do you consider finally TDX2 with low, ultra low in all types of breast cancer finally will go through TDX2?
Could you repeat the question, please? I couldn't hear.
With low and ultra low concept coming in a big way, do you think all types of breast cancer, all subtypes of breast cancer will finally go through this TDX pathway, TDX treatment pathway?
I think we have to change the way we do the pathways of our treatments, and particularly you have to individualize our conversation with the patients. I think a patient will not feel represented in the quality of life questionnaires are very important for the approval of the drugs, definitely, are validated. But the patient don't feel always she stays in the spot. No? I think I wish I could have, when I'm going to decide to do first-line treatment in metastatic setting or any treatment in neoadjuvant, say, these are the odds that you preserve your 10 preference in your bucket list for the next year, the next 5 years, or so on. And I think we should achieve that in the future. But they live totally scared about the things they could do or not do in the future. Did I answer your question?
No, I asked about TDX.
Okay.
TDX, is it coming in all subtypes? Because low and ultra low.
I think so. I think so. I think so.
So thank you. I think we can have the discussion at the T10. Thank you, sir. So back to the organizers.
Thank you so much. Now we'll start our session 5 on surgical and reproductive perspectives in young breast cancer. I would like to invite chairpersons for the next session, Dr. Vijayan Devan, Dr. Manisha Singh, and Dr. Shibashish Bhattacharya.
Good afternoon, everybody. Thanks to Dr. Baid and the organizing committee for inviting me to chair this session. At the outset, I will like to call upon the first speaker, Dr. Vaishali, who is an oncoplastic breast surgeon, to deliver her talks. You have already heard her during the panel discussion. So now over the Dr. Vaishali.
Respected chairpersons, and thank you to Dr. Rakesh and Dr. Ashok Vaid sir for this opportunity. I am Dr. Vaishali, working as a breast surgeon at Andromeda Cancer Hospital, Kundli, Sonipat. We have seen that nearly 20% of women in India present with breast cancer under the age of 40. And some of the unique challenges which young women with breast cancer pose have been already highlighted by Dr. Arun Goel sir and many talks before me. So we have these women with higher incidence of aggressive tumor biology, and because of all of this aggressive biology, there is a slightly high risk of local recurrence. And these women pose some unique challenges in terms of the impact of treatment on their fertility and body image concerns. And because these women in today's times, because of the evolution of a wonderful modality of multimodality treatment, there are a lot of complex psychosocial and survivorship issues which we have to deal with as oncologists. So in addition to the basic tumor characteristics, the size, stage, which we deal with for all the women with breast cancer, when we talk about surgical decision making, young women with breast cancer have some unique challenges, especially the genetic mutation status, their desire for future pregnancy and breastfeeding, the impact of surgery and radiation on breast cosmesis and breastfeeding function, and of course body image issues, self-esteem, quality of life concerns. When we look at a young breast cancer patient, we look at her as a patient, but she is a young mother, she is a young wife, she is a daughter-in-law, a daughter, and of course a young employee of a dynamic workforce. So there are many aspirations, many expectations from the surgical treatment. In addition to these, there are careers at stake, there are hobbies to pursue, and some women are in competitive sports. And a lot of women have financial implications. So all of these are to be taken into consideration when we plan surgery for these women. I'll not go into the detail, the time and the impact of genetic counseling and all that, because that has already been discussed. So body image issues and sexuality are very, very important part of surgical planning for a woman with breast cancer in young age, because whether she undergoes mastectomy or breast conservation surgery, whenever a lady comes to the surgical table, she has only one feeling, that something is being taken away, which is an important part of her body and body function as a lady. So that is the only constant fear which she has when she undergoes surgery. And in this, we have to counsel the patient very, very thoroughly before she goes for surgery, because there can be a lot of psychological impact after the surgery if the patient goes to the surgery without appropriate counseling. And in addition to this, the body image issues, the functional issues, the post-surgery rehabilitation and recovery are most critical, because this young lady has to go back to her normal life, to tend to her young children, to tend to her career, to tend to her family, her ailing parents or parents-in-laws. So her recovery also is very critically important. She has to complete her treatment on time, and the financial burden also has to be taken care of. So the surgical options are the same as for older women. So it has to be either breast conservation surgery with or without oncoplasty, or mastectomy with or without breast reconstruction. And when it comes to the management of axilla, it is axillary clearance or sentinel node biopsy depending on the stage at presentation. But these women have something more which we have to deal with when we compare her status with a slightly older person. So when we come to the breast conservation surgery, I am sure none of the lady would actually willingly want a mastectomy, but there are certain pressing reasons when women agree to mastectomy. A large majority of the patients would definitely want to go for breast conservation surgery, but there are certain challenges because many of these women may have small breasts, and as we know that we tend to be slightly going wider to prevent the risk of local recurrence or having positive margins. So in a smaller breast, if you are resecting a larger volume of breast, then the cosmetic outcome is going to be definitely inappropriate or inferior. And because of all of this, the symmetry issues are going to be very highlighted even when we do some oncoplasty, and a large majority of them are going to require some volume replacement. So volume replacement is going to mean an additional scar somewhere else, whether it is in the close vicinity or somewhere else. When it comes to breast reconstruction, definitely whether it is an implant or an autologous flap, some associated morbidity is always there. And the impact of radiotherapy on the symmetry cannot be actually predicted beforehand. The breast, the symmetry looks wonderful, the breast contour looks wonderful, immediate post-operative period. But once the patient actually passes time after radiation, the asymmetry becomes very visible and prominent at a later date. When it comes to mastectomy, obviously it is more invasive and requires meticulous dissection to avoid complications, especially a large area is going to be dissected, so bleeding, injuries and all are going to be there. And these young women definitely would want to have some kind of reconstruction which can be technically demanding, and whether it is an implant or an autologous flap, it is going to add to the morbidity, the surgical time and the financial constraints. In addition to that, there are complications like flap necrosis, wound healing problem, infections, leading to delay in the adjuvant treatment, which can be detrimental for the overall outcome of the patient. And in addition to these problems, because the young patient is going to survive for a long time, she is going to gain weight at a later date or probably lose weight. So there can be asymmetry even when you achieve excellent symmetry with breast reconstruction today. She may have some problem of asymmetry and may need to undergo multiple surgical corrections at a later date. So these are some of the challenges associated with mastectomy. When we come to the choice of breast reconstruction, obviously the challenges which we need to choose such a reconstruction which will withstand the decades of change, and obviously the weight gain and weight loss issues. Symmetry maintenance is very important, and obviously the patient has to be explained about the complications, especially flap necrosis, implant failure, whether she has financial means to undergo recurrent surgeries, whether she is willing to go for stage procedure or whether she wants to do an immediate reconstruction. All of these aspects have to be discussed beforehand whether the patient wishes to go for breast reconstruction. And a very important thing which needs to be discussed in detail is about the impact of adjuvant radiotherapy on the reconstructed breast, especially when it comes to the implant, because we know that autologous flap based reconstruction tends to tolerate radiation much better than an implant. So when we think about breast reconstruction, these reconstructive procedures actually highlight the need for careful planning and a multidisciplinary coordination between the breast surgeon and the reconstructive breast surgery team so that the patient's expectations are well met. So when we talk about breast reconstruction, it has to be a balance of durability, aesthetics, technical skills, the duration of surgery, risk of future capsular contracture, and all that which I mentioned earlier. So after giving all the details about the choices, the patient has to take that decision based on the oncological safety, suitability for that particular patient, and of course the long-term outcomes. When it comes to axilla, obviously there are two major surgical options. If the patient is clinically node negative and becomes node negative with a low burden in the beginning after neoadjuvant chemotherapy, we can offer sentinel node biopsy. But in our part of the country, we see a lot of women presenting with high nodal burden and they have to undergo surgical axillary clearance, and leading to a high risk of lymphedema, nerve injury, shoulder dysfunction, wound complications, and of course functional morbidity. So all of this has to be tackled when we plan the axillary surgery for this patient, and it is very, very critical for every person or every clinician to stage the axilla very well by the standard protocols before the patient starts any treatment, so that no young person should unnecessarily have to undergo axillary clearance when it was not needed. Sentinel node biopsy is very well, can be conducted technically. It does not pose a much of difficulty, but sometimes young patients, in a large number of young patients undergo neoadjuvant chemotherapy, and in this setting probably identification rate in terms of sentinel node biopsy can be slightly difficult, and it is very, it is rather not very easy to accept Z11 criteria for offering no further axillary surgery when it comes to sentinel node positive cases, because young patients were underrepresented in de-escalation trials, and we do not have any patient who is young who can actually avoid any type of axillary procedure as of today. So I am going to show 2-3 clinical scenarios which are the real clinical case scenarios when it comes to the surgical decision making, and how the patient's priorities and aspirations are very different. This is what actually I'm going to show here. So she is a 28-year lady with multicentric disease and a HER2 positive disease, and between the two palpable lesions there was an area of extensive microcalcification in the upper inner quadrant. She underwent neoadjuvant systemic therapy with good response. So with her profile, she has significant ptosis. So the choice of the procedure was therapeutic mammoplasty. But she is a young IT professional and she wishes to go back to her work immediately after her treatment, and she is not married yet. So she refused any intervention on the contralateral breast because therapeutic mammoplasty meant that she has to undergo surgery on the opposite breast, whether it was at the same time of her primary surgery or as a stage procedure. So she did not want any procedure on the left side, and she had not accepted genetic testing despite counseling, and her expectations from surgery were that she wanted a minimum scar, quicker recovery, early return to work, and breastfeeding function she wanted to preserve on the opposite breast and nipple sensation on the contralateral side. But there was a challenge in offering surgery with meeting all these expectations. So we explained to her, we counseled her, and if she had to have such kind of surgery, then she has to accept some minor asymmetry which could be later dealt with by fat transfer. She agreed to that, and with informed decision she proceeded with surgery. We did a round block procedure for her. Obviously there is some asymmetry as of now compared to the contralateral breast, but I am sure it can be managed with fat transfer at a later date. She is happy with the present appearance of her breast as of now. Another lady, a 29-year-old married person, underwent surgery for chondrosarcoma of left lower jaw in 2019. She was diagnosed with CA left breast in 2022, clinically node negative, HER2 positive disease. Her genetic test after diagnosis of CA breast came out to be TP53 mutation positive. She underwent neoadjuvant systemic therapy with partial response. In view of her TP53 mutation positive status, she was counseled for mastectomy because she had a high risk of, we usually avoid radiotherapy, and she was clinically node negative also. But she did not want any mastectomy. She actually was just recuperating from her surgery from chondrosarcoma of her left jaw, and then she was mentally so devastated with the diagnosis of CA breast that it was very difficult for her to accept mastectomy. So we counseled her, we took her informed consent, and she underwent breast conservation surgery and radiotherapy also. But unfortunately, she was diagnosed with third malignancy, CA rectum, in 2025. Presently, she is undergoing treatment for that. So this is her, we gave her breast conservation surgery as per her choice. Another person, she had a very personal concern. She's a 32-year-old lady. She recently married and she was nulliparous, presented with a large tumor in her right breast, triple negative, no mutations were detected. But she was very keen on breast conservation surgery because she was afraid that if she undergoes mastectomy, then her marriage will break down and she will have to lead a life alone. So she was very keen on conservation. We counseled, of course she had triple negative breast cancer, so we gave her a chance of neoadjuvant systemic therapy, and I was very skeptical whether she responds, or sometimes we do come across women who with triple negative breast cancer also not responding to chemotherapy. So she took her chance, and fortunately with subsequent cycles her tumor shrank in a very centripetal manner, and I could offer her breast conservation surgery at the end of her chemotherapy. So this is how with the use of neoadjuvant systemic therapy the patient's aspirations could be met. This young lady was also keen on breast conservation surgery, but her tumor was located in the central quadrant. She also wanted to preserve her nipple because in her part of her culture, being a whole person was very, very important to lead a normal life. So when I told her that she probably would have to lose her nipple, she was not willing to accept. So we tried to do nipple conservation. On the table we sent nipple core, but it came out to be positive. So she had to lose her nipple. But later on, I preserved a part of her areola, and now she is actually wanting to go for nipple reconstruction, which can be done anytime now. So these are some of the challenges which we come across when we treat the patients with breast cancer in younger age group. This lady is a physiotherapist, 27-year unmarried with a very low BMI, and she was also BRCA positive, BRCA2 positive, ER positive, BRCA2 positive. We offered her, we counseled her, but because she is young and unmarried, 27 years, she preferred to have mastectomy, and later on she is going to have breast reconstruction, and once she completes her family and all that, probably she might think about doing bilateral salpingo-oophorectomy. She is not willing for bilateral mastectomy as of yet. Again, we saw that breast conservation surgery is a safe option in young women also. Obviously, the patient's locoregional extent of the disease has to be thoroughly assessed before the patients are offered breast conservation surgery in young age. We come across in India certain unique situations when the patients undergo lumpectomy because there is a low index of suspicion in younger age group, and then we come across such badly placed lumpectomy scars, and it becomes very difficult to offer conservation surgery to these women. Then modern surgical approaches, robotic and endoscopic breast surgery, I'm not going to talk about them in detail. So to conclude my talk, I would say that these young women, when it comes to surgical options, they need a personalized care. Each individual has to be in each approach has to be discussed with pros and cons, and in a multidisciplinary approach, appropriate use of neoadjuvant systemic therapy, these women can be offered the surgery of their choice to improve their body image issues as well as to preserve their sexual health. Thank you so much for patient hearing.
So thank you so much. It was so well presented. I have a very small question. So we did a small study at our center also, and majority of the patients, to our surprise, less than 35, they had come with a locally advanced disease. 3/4 of them, they had either triple negative or it was HER2 positive. So my question is, either it was a hesitancy to show up, or it was such an aggressive tumor biology that the even young educated girls, they land up in such a locally advanced disease, or it's an institutional bias. So what's your take on that?
So surely we also, the patient's profile which we see is always heterogeneous. Whether the patient is educated or not, the level of awareness is definitely very varied in our society. So we come across many young women who are very well educated, but they do not have any awareness about the disease. And of course, they might be visiting some clinicians who themselves may be missing those cancers. So we come across many young women with advanced stages of breast cancer. Wherever suitable, wherever we have a recent Tata Memorial study, so wherever suitable, even in locally advanced breast cancer, some women can be downstage with neoadjuvant systemic therapy and can be offered conservation. But of course, the patient choice of surgery has to be individualized. I per se, as a breast cancer surgeon, will not compromise on the oncological safety. That is my priority.
After the study from TMH Mumbai that even in oligometastatic disease, surgery doesn't improve the survival. Do you still practice, or some surgeons are in favor that after chemotherapy offer the local therapy that will improve the survival intuitively? And what is the practice in the West, if someone, breast surgeon, can comment on that for oligometastatic disease?
Sir, I don't think the TMH study shows the oligometastasis. They are talking of the metastatic disease.
They included everything. Any metastasis were included.
It's an overall conclusion, not specifically a subgroup of oligometastatic disease. Because today the oligometastatic disease is a different disease, should be treated aggressively, and there are reasonable incidences of long-term survival. Second thing, Dr. Manisha asked a question. I think one of the most important factor of locally advanced disease is because of the cultural reasons, 80% of our patients go to gynecologist. And somehow the other gynecologist, lot of them in the periphery, they have no idea about the breast disease. The breast is young, firm, either they say nothing or they do an FNAC which misses the diagnosis. I think that is one of the most important factor in delaying the diagnosis in young breast
metastatic disease surgery, breast surgery.
Just a quick comment, sir. Since you mentioned the study at TMH, that there was a subgroup analysis of that. The whole study that went against, the treatment of the primaries is not what was reflected in that subgroups. When we did the subgroup analysis of the oligometastatic disease, it actually behaved more like locally advanced disease. So in that subgroup, yes, you have to offer the local treatment as well, and it does improve the outcomes. And there are multiple other studies also going on. There is meta-analysis also going on. A few of them have been against it, but a lot of them are in favor. The final verdict might not be out as yet, but yes, the trend is towards treating the oligometastatic with the curative intent and giving the local treatment. Thank you. Because it is basically, the IMRNI studies say that it is not the polymetastatic disease caught early, it's an entirely different subgroup of the disease. So you have to treat curatively. Thank you.
Yes. What's the practice?
Yes, I do agree that we need to find which are the oligometastatic disease that can cure. And that's why we did that work, trying to define a molecular signature. We just did the validation cohort from JCAM, because they have 155 cases over there that we can compare with our cohort. And having that said, I think until there, we have to use our best clinical judgment. So if it is oligometastatic disease bone, it's different from oligometastatic disease that you have bone and lung. So, because the definition of oligometastatic disease is less than 5 lesions in less than 2 or 3 organs. So, but I think it's different if you have 1 bone lesion and 1 lung, different from if you have just 1 single bone lesion or 2 single bone lesions. The tumor is less heterogeneous. And until this, I have to use this clinical judgment to take these decisions. I propose to my patients with metastatic disease, oligometastatic disease, if they have bone lesions only, after a while, to do surgery of the breast. But I start with systemic therapy, and if they are okay, after 6 months, and they are stable or on response, I propose surgery. That's what I do. If it is not triple negative.
Now we'll request the start the panel discussion. I request.
Sure. The next panelist, Dr. Puneet Prakash. Oh, he's
Dr. Puneet Prakash, Associate Professor of Surgical Oncology, George Medical.
Okay, thank you.
Thank you, chairpersons, and a very good evening to all of you. It's my at the outset, I would like to thank the organizers for inviting me here for this panel discussion, and it's a very interesting talk. The topic, the clinical decision making in surgical management, and we are discussing breast cancer in young women, which is something which we are talking very less. So, and it is a topic we need to discuss more. So, hence this panel discussion has been organized. I bring greetings from Lucknow, from my parent institute, King George's Medical University. Now, I would like to invite my esteemed panelists. Am I audible? Yeah. Dr. Rajiv Agrawal from Gurugram, Dr. Sameer Gupta from Lucknow, Dr. Selvi Radhakrishnan from Chennai, Dr. Sunil Saini from Dehradun, Dr. Hiroko Bando from Japan, welcome ma'am, and Dr. Tanesha from Ahmedabad. So thank you all the panelists. So let's begin with the case 1. We have a 30-year-old lady who is unmarried. She is air hostess by profession with a history of depression on medications. Sorry. So we are discussing a case of 30-year-old lady who is unmarried. She is an air hostess by profession with a history of depression and a family history of ovarian cancer in her aunt. She presents with a 2 into 3 centimeter lump in the lower inner quadrant of left breast. There was no history of nipple discharge, no history of any lump anywhere in the body. And she also had a heated argument with the hospital attendant over a long waiting time. So, a deadly combination. On examination, she has an anxious look. Left breast has a 3 into 3.5 centimeter solitary hard lump in the lower inner quadrant, which is not fixed to the skin or underlying muscle. Podrange is not present, and a solitary lymph node is palpable in the axilla, ipsilateral axilla, 2 cross 2 centimeters. Now coming to our panelists. Thank you so much, sir. Thank you. So, is there any age criteria for women with breast cancer? I mean, is there an age criteria when we'll say that this patient is a case of breast cancer in a young woman. Any of you, Dr. Samir, if you, sir.
I don't think there is any age criteria.
Yes, sir.
In my long career, I have seen as young as 16 years.
Yes, sir.
And every year we are almost operating 20 to 30 cases between 20 and 30 years of age.
Yes,
so I don't think age has become age has remained a criteria for young breast cancer.
So my question is that whether there's a particular age before which we'll say that
So
okay,
I think,
this is a breast cancer in young women.
To classify that, I think we have had these discussions since morning. Age of around 40 years, below which we say it's a young woman
Young
with
female,
breast
right,
cancer,
right.
and very young woman is when it's below 35 years of age.
Okay, thank you, sir. And does anybody of you will say that is age an independent prognostic factor in the management of breast cancer? Ma'am, sir, anybody? Sir, Dr. Tanay.
Yeah. Younger patients, they tend to have more aggressive tumors, more of triple negative breast cancer. So age is an independent prognostic factor in today's.
Okay. Okay. And how common is the breast cancer in young women in your clinical practice? How often do you see such patients?
So we audited results from 20 to 24 amongst 1,635 patients. 10%, 162.
Yeah.
So 10.9% was under 40.
Under 40.
Under 40.
Okay. So, and what differences do you find in the management of such patients, ma'am?
Very challenging, very emotionally overwhelming for them to even understand the concepts involving the management. Now we bring in fertility related issues, genetic counseling testing, and if they are indeed positive, then it opens up a whole different ball game altogether. So it is very challenging.
It's a challenging situation, I agree.
And
yes.
There's often a sense of perception of delay when they go through this process, and which actually becomes counterproductive in our kind of practice where multiple opinions are available. When you go through this systematically, you do face the problem of people dropping out and going somewhere else where there could be a quicker
Okay. So as sir told us that women who are less than 40 years of age are considered to be patients with breast cancer who are in the young age bracket, and most of these cancers, as sir told, that they are aggressive kind of tumors. Most common is the luminal B. In some studies, TNBC is most common. Rate of metastasis is very it's high in the very young group. It's close to 31%, and they behave very aggressively. Incidence of breast cancer in young women is increasing. This is a study from South India, and they also mentioned that these patients tend to have higher grade tumors. Most of them are luminal B, TNBC, triple negative, or HER2 enriched. A study from Ahmedabad, GCRI, showed that around 23.8% of the patients were metastatic at the time of diagnosis, and close to half of the patients were grade 3. And therefore, we saw this much anticipated, this 5-year overall survival in this study was 48%. There was a study in the young women's breast cancer study, and they were studying to advance the understanding of breast cancer diagnosed in young women. They analyzed close to 1,300 patients, and most of them were grade 3. Patients were detected at later stages. Most of the time, as ma'am said, the cases were challenging and they had greater risk of psychosocial issues, non-adherence to the risk-reducing adjuvant hormonal treatment, and long-term morbidity was also an issue with these patients because of anticipated long life trajectory in survivorship. As sir said, these patients behave aggressively, but if we manage all the common areas, we look for we balance the characteristics, then they tend to have similar outcomes as compared to the older patients. Coming to the surgical decisions, who's going to decide? When a young patient comes to your outpatient department, then who decides the treatment? Is it the patient or the family? Then comes the question of lumpectomy versus mastectomy, contralateral mastectomy, breastfeeding issues, and risk of recurrence. So all these things are very different from the older age group. So ma'am, after this, Dr. Hiroko, ma'am, what would you like to do? Next step?
For this patient?
Yes, ma'am.
Of course, we have to know the subtypes of the tumor.
Yes, ma'am.
Did you say it was a luminal B or it was not?
Ma'am, that was the literature. I mean, now after we have examined this lady, so
Yes,
next is maybe radiology.
We're going to do the ultrasound and MRI as well, and
Yeah.
also we'll do the PET CT scan to see the metastasis.
No mammography? No, I think all the panel agrees that we'll go ahead, straight away with ultrasonography and MRI.
Yes, yes, we do all the things that it is listed here.
Okay.
And
So is it MRI done only for young females especially or all patients?
Yeah.
actually, we do the MRI for all the patients who are candidate for the breast conserving surgery.
Okay, okay. So which is something which we are not routinely practicing in India. Anybody? I mean, we have already discussed it.
Young
but
women particularly tend to have dense breasts.
Yes, ma'am.
And so ideally either MRI or a contrast enhanced mammogram, whichever is easily available.
Okay, okay, fine. So I think FNAC is out of question. We have discussed at large. Nobody wants to, sir.
Well, based on clinical suspicion, if there is a strong clinical suspicion, we would order ultrasound and mammogram together. Okay?
Right.
Most of the time it is done together.
Yes. So most of the time, both
Right.
these are like in
And once,
adjunct.
Well, after seeing the X-ray mammogram, if there is a need to do additional MRI, naturally for decision making,
Yeah.
I might order that.
Especially in a patient who has a history of
Yeah,
breast
this
cancer
young
in the
patient,
family.
MRI, the need of MRI should be considered.
What I mean to say, we don't order it upfront.
Upfront, right,
but
right,
we
correct.
do it on case-to-case
Case to
basis
case
based on
Yeah. Okay.
the density of the breast. Largely it is done, but still
Okay.
later on.
So we also did an ultrasonography and an MRI of this patient. Anybody who is willing to do an FNAC and start the treatment? Any of the panelists? I think this is very clear that no treatment is started on the basis of FNAC. All of us will do a core, a true-cut biopsy. We need to give the pathologist the maximum tissue which we can give so that they can run their tests. Any role of genetic test?
Here I would like to differ a little bit. For young women, where the chances of a benign disorder are far more.
Yes, sir.
It depends on where you are practicing. If it is in a clinical, in a community setting, many of the patients, they already bring an FNA report.
Yes.
Which I would agree with the referring physician. Because before ordering a biopsy, naturally they want to rule out a benign condition, which it still could be a benign pathology, infective pathology also at times. Right? Okay. So at least in a cancer clinic, I would order
a biopsy.
Biopsy, but in a community clinic, a referring physician who is not an oncologist, I still would accept it.
Okay, so you're saying that FNA will be more like a screening thing to rule a benign from a malignant lesion.
Maybe the message could be that the core biopsy should be done by a trained person. rather than having.
Yes, I agree, because the biopsy incision has to be placed properly.
Not incision, I would say a core biopsy.
Yeah, I agree. But
on the other hand, can I raise a point? Yes. To even call it a benign lesion confidently, I think core will still be a valid test. And many a times, see, false positives, nobody is going to put it under the bench. They're going to go after it. Yes. False negatives are dangerous. People are going to put it aside and not look into it. And by the time they recognize it, it could be 6 months or 1 year when the disease becomes advanced. So false positives and negatives are common with FNAC. Negatives are more dangerous. So yes, even to call it benign, a core biopsy would actually,
Okay. I mean, my understanding was also that we'll go ahead with do a core biopsy. But any difference of opinion?
Not difference of opinion.
Certainly. I'm saying, I'm talking of two different clinics.
Yeah, I got your point, sir. I got your point.
I got your
point.
Clinic. I'm not talking about your clinic. You are the best in your subject. Okay. But I'm talking how you guide the community.
Community practitioners.
See, a cancer is to be diagnosed and at the early stage by the people in the community, not by you. You are an expert sitting in a tertiary hospital. You can't take care of the whole population.
Sometimes we tend to forget that. Yes, sir.
So, many of the patients, they do come with outside done FNAC reports and which are suggestive of benign disease. But if at the tertiary care center, the radiological findings are suggestive that it's a Barrett's 4-5 lesion, then there is no way that you can get away without getting a true cut biopsy. And what our books also suggest is that when there is discordance even between a true cut biopsy and your radiological finding, the next step is to go for an excision biopsy.
Yes.
So I think tissue diagnosis by means of a solid tissue diagnosis is must.
Okay, okay. I think all of us would order a genetic test for this lady with
the ovarian cancer,
yes, with
definitely yes.
All young breast cancer. So you're saying that all young ladies who are less than 40 years, you are going to advise, irrespective of the history?
Yes.
You're going to advise a genetic testing?
Yes.
Okay. And what about the metastatic workup? Any role of PET or just a CCT, thorax, abdomen and pelvis?
She had a palpable node, so I would
Yes.
order a PET.
Okay. Sir?
Same. She has got probably T2N1 disease, a palpable 2 centimeter size node.
Yeah.
And if mammograph is also suggestive that the node is positive, then PET is must.
Okay. Okay. Agree. So as we were discussing the guidelines regarding the whether we go for ultrasonography or MRI, this is the Indian guidelines which was published in year 2022 in the Annals of National Academy of Medical Sciences. And as sir said, ultrasound is the investigation, ultrasound and mammography both, in fact, in the age bracket of 30 to 39 years, ultrasound can be initially used followed by mammography in the presence of clinical or sonographic suspicion of breast cancer. For younger ladies less than 30 years, ultrasonography is definitely the investigation of choice. But overall, all women diagnosed with breast cancer should have an ultrasonography as well as mammography, because ultrasonography, most of the time when we are doing some interventions like clipping of the lesion, the node, the marking of the exact area, or maybe a wire localization, all these interventions are done by image guidance under ultrasonography. MRI, on the other hand, has a very high sensitivity. It's going to pick up very small and all suspicious lesions, close to 92 to 98%. But it's so powerful investigation that the specificity goes down. It is offered as a screening tool to patients who have to cases who have lifetime risk of more than 25% on various risk assessment models. Patients who are BRCA1 or BRCA positive for BRCA1 or BRCA2, untested first degree relatives of patients with BRCA1 or BRCA2 mutation. There is history of radiation to the chest, the mantle radiation for Hodgkin's lymphoma, and it is also supplemental to mammography in intermediate risk females, that is 15 to 20%, and also with patients with breast implant. So our patient underwent an high resolution ultrasonography, and it showed an irregularly shaped ill-marginated lesion at 7 o'clock position in the left breast, 2 centimeters from the nipple. The size was 3 into 3 into 2.5 centimeters. And on Doppler imaging, some internal vascularity was also seen. The rest of the findings of the breast were normal. She also, as suggested by our panelist, she also underwent an MRI investigation, which showed an irregular heterogeneously enhancing lesion with spiculated margins at 7 o'clock position, approximately 2.1 centimeters from the nipple. The lesion demonstrated a rapid initial enhancement and washout kinetics. I mean, this is a very important thing when we are analyzing the MRI of breast, because all these patients undergo a contrast enhanced MRI, and it is based on the idea that all these tumors have they have good vascularity, so they'll take up the contrast very rapidly. The tumor was localized to the breast. It was not invading pectoralis muscle, or was not involving the skin. We didn't do a PET scan at that moment, because in our center at that moment we didn't have that facility. So patient underwent a bone scan, and there was no evidence of bony metastasis. Biopsy was done, which was suggestive of infiltrating ductal carcinoma, ER positive, PR negative, HER2 neu negative, and a Ki67 of 48%. So, and she also underwent, as suggested by the panelist, she also underwent a genetic testing, and she was positive for BRCA1. The risk factors include, when we are offering genetic testing to the patient, they include breast cancer before the age of 50, cancer in both the breasts, history of metastatic prostate cancer, history of ovarian cancer at any age, history of pancreatic cancer, and history of triple negative breast cancer in the family. So, next step, any of the panelists would like to take, sir?
So what was the node like?
It was
the node sampled?
Yes, ma'am. It was, the FNA was done and it was positive for, I think I have not mentioned, it was positive for malignancy, yes. So that was exactly my next question also. So we went ahead and did a clipping of the primary lesion. I think, what is your clinical practice? How do you proceed, sir?
I think clipping of the primary as well as the involved positive node, targeted axillary dissection subsequently.
If we are thinking of TAD in the future.
Yeah, same. If the lesion is small, like less than 2.5 centimeter, then we clip the lesion from the very beginning. For a larger lesion, we see the response, whether the response is centripetal or not. So after 2 cycles, if the lesion is responding uniformly from all directions, then after 2 cycles we put in the clip.
Okay, you are not clipping the lesion in the first?
For larger lesions.
For larger, like any size more than 5 centimeters?
For lesions smaller than 2.5 centimeters, we are clipping them upfront.
Okay, okay. Sir, any?
It's a luminal disease.
Yes, sir.
And node is positive. I think we have to see the node burden in the axilla in detail. Maybe a PET scan.
Okay.
If the axilla is heavy loaded,
yes,
I will definitely go for a neoadjuvant chemotherapy.
Right.
Otherwise, if the breast size is okay, the lesion is 3 centimeter, there is not much of the, because the pathological remission in luminal disease is only 15 to 20%. And if the patient is willing for conservation and breast size is okay, I can think of primary surgery with a breast conservation surgery. Because the lesion is not very big.
Okay.
It's a ER positive tumor, HER2 negative tumor.
Yes. ER positive. Ma'am, any opinion?
What was the positivity of the estrogen receptor?
Ma'am, the report was, the Aldred score was 6, I think 3 out of 8. I don't exactly remember, I have not mentioned, it was 3 out of 8.
Strong reports.
Yeah, strong.
Okay. So in that case, we would do the neoadjuvant chemotherapy, and to do this, so we would like to leave the clips in the breast.
Okay. So you are going for neoadjuvant.
So it's a low positive ER, not ER.
Yes, 3 out of 8 Aldred score.
Low positive ER is a different disease. So if it is a heavily positive 8 by 8 or 7 by 8.
So if it would have been 8 by 8,
yes,
you would have gone for upfront surgery, sir?
So in the setting of a BRCA positive young woman, I think I would go for
That's what my question is.
Followed by surgery.
With such a history, even if it was 8 by 8, would you like to go for upfront surgery, sir? In this, if it was 8 by 8? Okay. Any other opinion, ma'am?
Having said that she has a BRCA1 mutation status, breast conserving operation is not a contraindication, so it depends on her choice if she still wants to do the breast conserving operation or if she is going to do a double mastectomy at the surgery.
No, ma'am. My question is whether to go for upfront surgery versus neoadjuvant.
Neoadjuvant chemotherapy.
Okay, first. Perfectly fine, sir, ma'am.
Same here. I would like to go for neoadjuvant therapy.
Okay. Considering the young age, the luminal B positivity, history of malignancy in the family, so we are going ahead with neoadjuvant chemotherapy.
Also, fertility issues have been addressed. She's completed her family.
No, ma'am, she's an unmarried girl.
Unmarried. So that also should be discussed, and before we start chemotherapy, put her through a consult with a fertility specialist.
Absolutely. So we discussed all these things with the patient, and she was very apprehensive as she had an anxious loop. She was determined to go take the best treatment. So she received 8 cycles of neoadjuvant chemotherapy, and she had a partial response. The tumor size decreased from 3 cross 3 to close to 2 into 2 centimeter, but node was still palpable, which was approximately 1 into 1.5 centimeters in size. So now, after this chemotherapy, what are your thoughts on whether to go for BCS, mastectomy? Yes, the response is not very good, I would say.
So in ER positive situations, response doesn't drive escalation or de-escalation. They are going to be differently planned. So regarding the choice of surgery, the response is not going to determine whether it's what are we doing here. So she might need radiotherapy in any case.
Yes.
Because node is
positive. Yes.
So again, put the option of both BCS and mastectomy.
Okay.
If she did not have to have radiotherapy, say the nodes were not palpable up front, nodes were not positive up front, or the nodes have responded very well, then there's a question of offering her mastectomy with immediate reconstruction, with the option of immediate reconstruction. And then look, she's received neoadjuvant chemotherapy, so see her fitness levels, if she's up to good hemoglobin, good
She's fit, ma'am.
Yeah,
She's a-
so then
she's
talk
air
about the
hostess.
contralateral upfront or contralateral risk reduction surgery at a later date, say maybe 2 years later. So those are the things, that's how I will take the discussion with her.
Okay, but
in BRCA positive setting, when you will going to recommend bilateral mastectomy and oophorectomy,
Sir, that's what
finally you will ask for that.
Yeah.
Now you are going for BCS, is it not matching?
No, that
Sir,
is what
there
I'm
was a
saying. She
paper-
underwent a bilateral
Sir, there was
mastectomy.
a paper presented in ESCO 24,
Okay.
575 cases from Korea. There is no difference in overall survival in BRCA positive, whether mastectomy or conservation.
Many meta-analyses also have shown this fact that it is not an absolute contraindication to do a breast conservation whenever possible in BRCA mutated patients.
Okay.
Knowing that local recurrences can still be a bit higher, but it doesn't impact on overall survival for these patients.
Yeah, absolutely. But
I would only worry about the long-term consequences of radiotherapy.
It's more of the Angelina Jolie effect, as they call it, more than the disease biology. So,
okay.
I'm going to touch on this issue tomorrow in my talk.
Okay. So our patient was very anxious. She was like, she wanted to get rid of both the breasts. So she underwent a bilateral mastectomy with a DIUP flap, bilateral, and left ALND, axillary lymph node dissection. The final histopathology report was a residual tumor, one lymph node was involved, and the hormonal receptor status changed. Initially it was ER positive, now it has become ER negative, which is PR negative, and Ki67 is of 30%. So now,
So in all probability she was triple negative even to start with.
Yeah.
It's possible.
Yeah, maybe, yeah. Any role of PORT post mastectomy in this patient?
One node positive, yes. Post therapy node positive, yes.
Okay. And any adjuvant hormonal treatment? Initially she was ER positive, now she is ER negative.
I will go back and look at that ER-PR status on that
so you
core
want to review
once
the
again.
pathology? Yeah, okay. So I came across this paper, which is like prognostic value of receptor change after neoadjuvant chemotherapy in breast cancer patient, which was published in European Journal of Breast Health in 2022. And roughly 5% of the patients who are ER positive, initially they change to ER negative. PR has a higher percentage of 7% and HER2 even higher, a 17%. In subgroup analysis of such patients in this study, the patients who were turning negative for hormone receptors had a significantly shorter survival. But at present, there is no consensus whether to use adjuvant hormonal treatment. But usually in our practice, I mean, I give if one's positive.
I think the more pertinent question about adjuvant treatment is whether it should be olaparib vis-a-vis hormonal treatment.
Okay. Yes, sir. Yes. Since she is BRCA positive, I agree. Okay, and we have a medical oncologist to think. No medical oncologist is sitting in this panel. So I don't know if I have time. Okay, so I'll just rush to this. This is a second case, a triple negative, and she did not have any history of breast cancer. She's a homemaker, 38-year-old lady. She also had a mobile node, and we did a mammography and an ultrasound, a biopsy. It was triple negative. FNA from the node was positive. So she underwent clipping of the primary lesion along with the node. We added carboplatin because she was a triple negative. She had a good response. Node was not palpable. So what we did was we did a wide local excision, and this was the result. We did a matrix rotation oncoplasty for this patient. Final HPR showed a 1 into 1.5 centimeter node. One node was positive, which was not clinically detectable. She received PORT with boost to the tumor cavity, and currently she is on adjuvant capecitabine because residual tumor was present. So just a small discussion about oncoplasty. So before proceeding for oncoplasty, we should, as Vaishali ma'am already discussed earlier, so volume of the tissue excised is very important, and tumor location, breast size, breast to tumor ratio, glandular density, and various risk factors associated with patient like diabetes, obesity, and previous surgery. So this is the aesthetic triangle. When we offer patient oncoplasty, we actually maintain this. Initially this triangle is isosceles and becomes elongated as the age progresses, when the breast becomes more pendulous. And these are the standards of reconstruction when we are offering oncoplasty. So in this study, this was a study which was published in 2010, an old study. A volume of the breast excised was the single best predictive factor for breast deformity, and excision of more than 20% was associated with poor, bad outcomes. So these are the various techniques which we offer to the patient, and this is the paper which we are talking. Now I think we are too late in that, because evaluation of SLNB post neoadjuvant is doubtful, because I am discussing it because we had clipped the node initially. So in this study, ECOSOC Z1071, the false negative rate for SLNB post NACT was close to 10%, which was not acceptable. So that is why all these trials which were going for SLNB post NACT, the dual tracer technique, both using radiocolloid and blue dye, the false negative rate in all these studies was like 12-14%, not less than 10. So to negate that, as we were discussing earlier, we were clipping the biopsy positive node, and these are the various techniques which we have, currently which they are ongoing in various studies. One is marking of the axillary node with radioactive iodine, and the FNR has decreased from 7 to 5.1%. We are clipping the node, the FNR rate is 7%. Targeted axillary dissection, which is being carried out in MD Anderson Cancer Institute, the FNR rate is very low. And in TAD, what we are doing is, we are clipping the node, and we are doing a sentinel lymph node biopsy also. And regarding clinically N1 nodes converting to YPN0, whether to omit ALND, I mean, that's a question which still needs to be answered. So NACBP B51 is going on. Yeah, sir.
Thank you so much.
Thank you so much. Thank you. And before I go ahead, I'll just a small invitation. This is the ISO NatCon which you are organizing in 2026 in Lucknow. So on behalf of organizing chairperson, on behalf of organizing secretary, I would like to invite all of you to this academic extravaganza, and it is the 50th year of ISO also, so we'll be very happy to host all of you. Thank you.
I would like to call Dr. Tejinder Kataria for the, she's the moderator for the next discussion, which is the panel discussion, Clinical Decision Making in Young Women with Breast Cancer, Local Treatment.
Good evening. Thank you, Dr. Vaid, for giving me this opportunity to be the panel moderator. I'd like to call upon my esteemed panelist, Dr. Dheeraj Gautam. He is the senior pathologist at Gurgaon Medanta. Dr. Garbit Chitkara, who's a surgeon from Bombay. Dr. Anil Anand, he is the director and head at Fortis Memorial Hospital for Radiation Oncology. Dr. Shraddha Chaudhary, senior director, gynecology, surgical oncology at Medanta. Dr. Rajesh Pasricha, if he's in the audience, from Bhopal, he's at AIMS. Dr. Shabnam Bashir from Jammu Kashmir, and Dr. Nikhil Vaid from Artemis. Thank you. So as we have been listening to our lectures as well as the previous panel discussion, the key factors in decision making in breast cancer is always a shared decision making, and it should be equally efficacious for the treatment outcomes. There are patient-driven choices, and there's an importance of multidisciplinary team, which we have on my left. And we'll be addressing only a couple of issues out of this whole multidisciplinary consideration tree, which is the local therapy and some amount of, the psychosocial and the sexual health. So we have a young patient who's 35 years of age with no known comorbidities, no allergies. Her mother has had a history of gallbladder at her age 60 years, and a maternal uncle had lung cancer attributed to smoking. Her presenting complaints were a self-noticed lump in left breast since 1 month, not associated with any pain, any observable skin changes or nipple discharge. And the surgeon had given a history that examination showed in the OPD a left breast 35 mm lump in the left breast upper outer quadrant, and no axillary abnormality. Right breast and right axilla were clear. And this is her 3D mammography, which showed a heterogeneously dense nodular breast and a lobulated irregular mass lesion measuring 41 by 25 mm, seen in the upper outer quadrant on the left side. And there were no associated speculations. So she underwent, as discussed earlier, an ultrasound, which again picked up at 2 o'clock position a 2 by 2 centimeter mass showing an internal vascularity, and no other focal dominant lesion was seen. Mildly prominent lymph nodes with preserved fatty hyaline seen in the axilla. And she was labeled as BIRATS 4C. So Dr. Chitkara, I'd like to ask you what additional information or examination needs to be requested for supplementing the information we have before we proceed with the further management.
So additional information, I think what we need is having had a core biopsy done. I'm sorry, I missed that.
No, we haven't yet gone there.
So
I'm just asking you.
we've already done the imaging. We can do a core biopsy for her before or after the MR, which is a definite for her because of the heterogeneously dense breast. So
Right.
I would rather do the MR first and then the core biopsy, because that would change the vascularity a little, and that may change the presence or absence of an NME there.
Right, and Dr. Shraddha, you'd like to add something to that as a gynecologist if you're seeing
So
her?
as Dr. Rajiv Agarwal sir had pointed out that such patients often go to the gynecologist first, and the gynecologist would most probably order an ultrasound to start with. But I think it would be a good idea to do both the ultrasound and a mammogram in the gynecological setting before we proceed further.
And what's your take on doing a PET scan on her? Before the biopsy or after the biopsy, or no PET scan?
So after the biopsy, and yes, PET scan. And,
You would like to do a PET scan on her?
I know the recommendations are for less than T2 tumors. We can forego the PET scan, but more often than not, in a younger woman, the inertia of doing a PET scan is much less, and the trigger is much low.
Okay. So she did undergo a PET scan, and that was done on the 12th, that is 6 days after her ultrasound. And there was a 2.5 by 2.4 centimeters with a high SUV of 16.9 upper outer quadrant with perilesional standing. A mass was seen which was heterogeneously enhancing. And there were low-grade FDG-avid lymph nodes in the left axilla. So she underwent an ultrasound-guided FNAC, which was from the left axilla and was reported as a reactive lymph node. And Dr. Dheeraj, you would like to do the biopsy and then report other tests also to be done with that, or just go ahead with the morphological examination?
I suppose this is a core biopsy?
Yes, it's a core biopsy that will be done.
Okay, so we do the histopathology as well as the immunohistochemistry, which is routine, that ER, PR, HER2/neu and Ki67. And if other tests are required, then...
And since she has a mother who had a history of gallbladder cancer, would you like to order BRCA1, BRCA2 for her? But there is no ovarian or breast cancer history.
Can I take that?
Yes, please.
So, yes, for a young woman, whether she had a history of CA gallbladder in the family or CA breast, I think she becomes a candidate for genetic testing. I would not limit the genetic testing to just BRCA1 and BRCA2. I would probably ask for a cancer gene panel, which would encompass the other low penetrant or moderately penetrant genes as well.
Yeah, why I'm asking this question is, because at times core biopsy is ordered, but the patient is not fully aware as to where it's going to lead. So the discussion has to happen in the clinic before the biopsy is ordered. So that's why I've taken it up here, which is contradictory to when you would take the biopsy and then after the report you would discuss that. I think it's appropriate that the patient should know when she's going in for biopsy what is expected, and if A, B, C, D, if any more tests are required for her. Right? Thank you.
When we go for the genetic testing also, in addition to just discussing the histopathology, we have to also be ready with the answers, for why we are going for genetic testing and what we do have to offer. Because a lot of times they end up otherwise in the anxiety then.
Thank you. So these are the slides which Dr. Dheeraj provided me. I'd like him to just, enlighten us as to what are the different types of histologies which he'd be expecting when a core biopsy comes to him.
So in histology, predominantly we find invasive ductal carcinoma, which is on right side. It arises from the ductal cells. Then the second one is 10 to 20% are lobular carcinoma, which is a single Indian file pattern. Next slide, please. So these two entity constitute around 90 to 95% cases. Then we can have medullary carcinoma, which is a cluster of the cells. Then this is the high power, which constitute the giant cells also. We can have a mucinous carcinoma also. So these are the few types of in histopathology. And in the immunohistochemistry, would you like our audience to know a little bit more about what immunohistochemistry will show? Okay, so usually we do ER, PR and Hertinu and Ki67. So in ER and PR we give the all red score, that is intensity as well as the quantity of the positivity. It divided from score 8. If it is less than 2 or 2, then it is negative. It is more than 2, then it is positive. Then Hertinu, we go for the score is 0, 1 plus, 2 plus and 3 plus. 2 plus is indeterminate, then we have to go for the fish if it is 2 plus. 1 plus is low Hertinu positivity and 3 is positivity. We have started the dish also. So either you can go to the fish or you can go to the dish. Then Ki67, we have to see whether it is 8% or 12% or 15%. There are different criteria for the Ki67, which is a proliferation marker, which indicate how much cells out of hundreds are proliferating in that. Okay, thank you.
What is the tissue processing system you are following at present for HER2 reporting? Because I presume that processing time and it has some difference.
It is quite standard.
For reporting HER2 low.
On core biopsy, it is between 48 to 72 hours. You have to, this is the time, and then we do it routine processing.
But for HER2 low, I think the protocol is little different.
No.
That is what the Tata
As
people.
far as my knowledge is concerned, nothing.
Okay, so this is the case under discussion. She underwent a breast true-cut biopsy on the day she'd undergone an ultrasound, and it was reported to be an invasive ductal carcinoma with the ER positivity of 4/8 and a PR positivity of 5/8, and her HER2 new score was 3+. And she also has a Ki67 of 30 to 35%. So Dr. Chitkara, how would we proceed now?
Young patient T2 tumor with a HER2 3+. I think the next, which is non-metastatic, I would like to take this case to the MDT, and I think my recommendation within the MDT, and I'm sure my medical oncologist will agree with it, is to start her on neoadjuvant systemic therapy with which will include the chemo and the targeted therapy.
And you'd like to place the clip now?
So I have a practice of doing it after 2 cycles, because sometimes when it is multicentric and it is looking together because of a confluent mass, I want to see how it responds, whether it is 2 masses centrifugally responding or is it a Swiss cheese pattern. And if it is a Swiss cheese pattern, I mark the borders. If it's 2 centrifugal, I put it in 2 centers. If it's a single center, I put it in the single center.
Thank you. So she did undergo the standard chemotherapy, and I'm not going to talk to the audience here because they are beyond what I'm going to present here. So this is the standard protocol, and she underwent a neoadjuvant chemotherapy. And after neoadjuvant chemotherapy, what are the options?
Whether that patient was married, unmarried?
Oh, she's married and she has 2 young children.
33.
35. Yeah, so she's undergone neoadjuvant chemotherapy. Now, what are the surgical options for of treatment for this person? Dr. Chitkara, Dr. Shabnam?
So obviously we'll have to reassess after we have completed. The different institutions will have different protocols. Some of them tend to see the response assessment in midway between, after 3, and then send it to surgeon and then assess. If we get to see after that, then we'll have to see what has happened to the lump, whether it has, if the patient received dual blockade, it usually kind of melts away, and then we are left only with clipectomies and all. So that would depend upon the response of the tumor on radiological assessment.
So Dr. Chitkara?
So I presume we did send a genetic panel, and I would not know the result of that.
No, so her genetic panel is not available to me.
So fair enough. So
she was BRCA negative, but the rest of the gene panel was not done, so she's
Whichever
BRCA
way,
negative.
I would discuss breast conservation with her, and and obviously depending on the result, and if she is keen on conservation, she can go ahead with the conservation as far as the breast surgery is concerned. Since she was axillary node negative to begin with, we can safely do a sentinel lymph node on a post-chemo setting as well. So her axilla is going to be addressed in the way. Depending on the response, I'm going to offer her oncoplastic procedure versus not. Most likely in an HER2 positive, with a good response, oncoplastic procedures are not required. Just a type 1 closure of cavity is enough to be able to deal with it.
And in case she does need, axillary dissection,
I would differ in the axilla, because I know he comes from Mumbai and has access to very high volume pathologists, and also I have burnt my hands. I've had FNACs done on the axilla, which were negative, and while doing the axilla, I found that they don't look nice, and I did dissections to find out 13 out of 19 nodes positive. So I would take it with a pinch of salt. A lot of times we can't just go by what is the consensus around, and we have to look at our own resources and the help around available, and how much can we rely on that, the volumes that are being done in the areas. So as of now, post neoadjuvant chemotherapy, I'm probably not comfortable leaving whether it is N1 converted to N0. I would tend to clear the axilla post neoadjuvant, young patient, family history of breast cancers, and triple positive.
Okay, so is there any role of lymphovascular anastomosis to reduce the incidence of lymphedema in such persons?
If we are planning ALND, and if we are trained in that, yes, why not? Lympha is what should be given to them. Is given the fact that she is very young and we'll go a little more aggressive in the axilla. If we have the expertise, that should be offered.
Yes, Dr.
I do have a concern with that, so back to you. We still don't have evidence enough for lymphovascular anastomosis at the time of setting of axillary dissection, whether it is going to drastically improve the quality of life and have a definite reduction in lymphedema rates. I also would like to consider not just a microscopic lymphovascular anastomosis. We're doing S-lympha is a much easier procedure. It is done by breast surgeons, doesn't need a plastic surgeon, and I think that can be considered. But again, the evidence for both and the expertise for both have to be available before that is taken on.
Thank you. Dr. Shraddha, any thoughts about the bilateral oophorectomy for her, since she's young and there's been a discussion regarding the hormone ablation, and she's ERPR 4 and 5 positive?
So I think bilateral oophorectomy should not be the first line of treatment. We can give her medical hormonal suppression, and there's no need to remove her ovaries and give her a complete premature menopause at 35.
So even I think for BRCA proven patients, we're not doing oophorectomies at the age of 33, because that puts their bone health into a toss, and we do wait either for them to complete their families, or go cross 40, 42 or closer to the 45, and then is the decision made for the oophorectomy.
Right, thank you. So she did undergo left wide local excision with a sentinel lymph node biopsy on the 6th of September this year, and there was no residual invasive tumor after the chemotherapy. There was no DCIS, no LCIS, and the lymphatic and vascular invasion was not identified, and the margins were uninvolved, no lymph nodes were involved. So final pathology was YPT0, N0, N0. So now what next? So Dr. Anand, what would you like to do? In the MDT, the patient comes back, and you are here with the history, the examination, now her post-neoadjuvant therapy findings.
It's slightly controversial, because otherwise the standard of care is still to give post-op radiation to the whole breast and followed by lumpectomy boost. But there is some emerging evidence which is coming up in saying that post-neoadjuvant chemotherapy, if it is T0, N0, sometimes we can omit radiation. But in breast conservation surgery, still the standard of care is whole breast radiation. And since this patient is young, 35, so she should have boost also. And and it should be You said what are the short and long-term toxicities?
Yeah, so what are the short and the long-term toxicities expected with the adjuvant radiation? Because you mentioned that there's a thought process, there's radiation can be omitted, but she is HER2 new positive, you know that also.
So firstly, let us talk about a little bit about short and long course radiation. So now the standard is hypofractionated 3 weeks treatment compared to the 5 weeks which we have practiced for several decades, I would say. So now it is a short 15 days treatment followed by a boost of 5 days.
So Dr. Nikhil, can you tell us, are there any ways by which we can mitigate or minimize the long-term toxicity for a young person with a left-sided breast cancer
in this
who's
young
needing
patient,
this radiation?
For the long-term toxicity regarding the cardiac toxicity, we can use the DIBH technique, we can use the conformal IMRT technique, and if possible, then we can go for proton therapy also.
Yeah, so given the cost constraints, would you advocate protons for everybody? There also you would need deep inspiratory breath hold. And if we look at the recently presented paper at the ASTRO, concluded in September this year, there was no added advantage for protons, either for the local control or for the overall survival as compared to the photons. So I think that I would still wait for a long term. When you have the techniques with which you can spare the cardiac toxicity and also reduce the pulmonary toxicity, then the present day techniques probably would be still applicable to a larger population. So she underwent what Dr. Anil Anand said, moderately hypofractionated radiation with a simultaneous integrated boost rather than going in for a separate boost later. And her both the heart and the lung doses were well contained. This is where we are. So the loco-regional therapy for early stage disease after the breast conservation reduces the absolute risk of local recurrence in the younger patients as compared to the older patients, and the boost further improves the local control. Dr. Anand, would you like to say that this patient can be a candidate, if ever, for a partial breast radiation?
No, this is I would say one of the absolute contraindications so far as to evidence and all. Any younger patient less than 40 should not have a partial.
Even if she's T2 and she's YPT0N0.
No. Partial breast, no.
And in case she'd undergone a mastectomy, then what would you say? Would she need any post-operative radiation if she is node negative?
No, because her node was negative to start with, and she is T2, N0 before chemotherapy and YP0 after chemotherapy, so no.
So Dr. Nikhil, I'd like to have some thoughts on if this patient has received adriamycin and taxanes, plus she's undergoing radiation to the left side of her chest wall or breast. What is the cumulative toxicity which we expect for delayed cardiac events for her?
So in left-sided breast patients, like 15 to 20% of the patient can have long-term cardiac toxicity.
So is there any projected follow-up for these patients? How would you like them to be followed up?
So they should be subjected to regular checkup, and echo should be done, and LVF should be regularly compared with the previous one.
Dr. Anand, would you like to say anything?
Yeah, I think the additional other factors like her diabetes and other comorbidities which affect heart disease, for example, obesity, hypertension, and diabetes. So these patients have more tendency to develop cardiac toxicity later in the life.
Okay.
So I
now
think that
coming back to Dr. Shraddha again, she's 35, and if she did not have children or she's not completed her family, what advice would she need for her fertility preservation before starting her chemo, and then hand-holding for her to take her through the pregnancy?
Right. So the ESHRE guidelines, the European Reproductive Endocrine Society, says that just at the time of diagnosis, actually the guidelines say that within 24 hours of the diagnosis of a cancer, the topic of fertility preservation must be introduced with every patient, irrespective of the patient's parity, irrespective of the patient's age, and the patient should be at least sensitized about fertility preservation options. Given the condition that this patient is para 2, we should still not say that she doesn't want to have a third child, and if she does want to have a third child, this could have been discussed with this patient as well. However, if she's a nulli gravida, the most standard method of fertility preservation is an embryo cryopreservation. And if the patient doesn't have a partner, an oocyte cryopreservation is also a very good option. Given the fact that she received neoadjuvant chemotherapy, which is gonadotoxic, she requires a 2-week window, a 12 to 14-week window to be able to pick up her oocytes and then render her fit for the chemotherapy care. So this is a discussion which should be done for every married woman, where she can go for an oocyte or an embryo cryopreservation prior to the chemotherapy.
Thank you. And Dr. Shabnam, I'd like you to just mention something about what would be the psychosexual advice that can be given to this patient, if she's married, if she's not married, if she's planning to have children, not planning to have children, you know.
Firstly,
Madam, can I ask
probably the add-on to the...
Yes, sir.
So, like to our fertility expert, this is a patient who is hormone receptor positive. So you will obviously, to induce ovulation, you will have to give her high doses of hormones.
So we will use different protocols for such patients, which would be safe for breast cancer. She'll be given a letrozole protocol, which will keep her estrogen levels low, and the oncogenic outcome will not be compromised during the stimulation.
Okay.
So the only thing that I would add on to that is that if you're having a very high-risk patient and you don't want to wait for the embryo or the oocyte, then the other method is you have to take the ovarian tissue and cryopreserve, and then you can start the treatment quickly without having wasted 2 to 3 weeks.
So in such a situation, would you remove the whole ovary, or you'll do a wedge?
A part of that is removed, and then
These are not wedges actually, they are strips, and in India there are very few centers. It's still not come up so much in our country, but being practiced widely in the West, especially in other aggressive cancers, in adolescent cancers where there's really no time for any kind of stimulation, or the patient is prepubertal.
Can I ask a question? Would you regularly do an AMH before starting any of this?
Oh yes, we must do an AMH, and antral follicle count can also be done to check her ovarian reserve.
And such a discussion would happen with her partner, or with her family, or with her alone? So how would you go about? Because in India, it's a family unit that comes to you.
It's very important, because majority of the times, I think always, the women, irrespective of whether they are educated, independent, financially independent, it is the men in the family who bring them to the hospital and have that discussion. It has got a huge psychosocial role and emotional role, and it needs to be taken like that. We have to value the culture that we're living in, and it has to be a holistic discussion with the whole family. But of course, patient is the prime concern.
I think if you move to the rural setting over here, then the mother-in-law is even more important than the husband.
True,
so
sir.
Just, I think I'd have one question for all of you. What about the quality of life and survivorship in these young breast cancer patients? Because if we are giving whatever we are doing, giving them neoadjuvant chemo, doing the optimum surgery, doing the best possible radiation, holding their hand with fertility preservation and their psychosexual health, what are the overall parameters which we should be looking at besides these to improve the quality of life and their survivorship? Should it be included from the beginning when we discuss the patient when she walks into the clinic for the biopsy?
Societal support plays a huge role, and we see a huge amount of the difference in following the treatments, in kind of defaulting, and in kind of their emotional aspects when you have a family or a partner that's supporting you, and a family that is not supporting you and has kind of thrown you out of the place for those treatments. And it does impact the treatments that were given to those patients, the outcomes, and the overall thing. So it's a holistic supportive system that we have to create, and support groups also from the very beginning.
Thank you. Thank you so much to my esteemed panelists for keeping to the time and making a very interesting discussion. And thank you to the audience for being here.
Thank you, ma'am, and thank you all the panelists.
So after these wonderful panel discussions, we will proceed for the next session, which is on the innovations in AI for the breast cancer. I would like to invite the panelist, the chairperson for the same, Dr. Jeevanram Bishnoi sir from the Jodhpur, Dr. Hemant Malhotra sir from Jaipur, and Dr. Shibashish Bhattacharya from Impal. I request the chairperson to call for the next speaker.
So I think let's not delay any further. Pleasure to invite Dr. Rajiv Kumar, and I think I've been waiting to hear this talk since morning. And if you remember the lay press 2 days back, or maybe yesterday, there was a big article that the All India Institute people, All India Institute Delhi, they've already started to report their chest X-rays by AI. So we look forward to hearing some of that from our learned speaker. He's a practicing medical oncologist in England. Over to you, Dr. Rajiv.
At the outset, I'd like to have my heartfelt thanks to Ved sir for inviting me from Bangalore for this fantastic talk. It's been really very nice. I know it's like post-lunch session. Everyone's like waiting for the chai, tired, having panel discussions. Half of them are sleepy, half of them are yet drowsy. So now, ladies and gentlemen, let's get excited for the future of oncology. It's not just for breast care, but for whole of oncology. So when Ved sir asked me to talk about AI in oncology, so I went around Googling, okay, fine, let's ask Perplexity, let's ask ChatGPT. And whether you like it or not, 95% of all AI in oncology is for breast cancer. Mammogram, CT scan, then afterwards, then comes the next part of it comes as digital pathology. You look at a slide, then afterwards you're able to tell whether it is ER, PR without even putting the markers, then you're able to see whether it is immunopositive, if it's going to respond to immune therapy, it's got TILs, it looks into all of that, and then probably it levels, even tell the name of the patient. To that level of AI, people are now talking, and so many tools, and everything is in process. Then after scratching my head, like, मैं तो सारा clinician हूँ, ये सब ठीक है, it will get diagnosed and then come to me. Then after, what do I do after that? I need AI to do something for that. So then what did I do? I tried Googling for people who are offering AI solutions in Bangalore, Bangalore being the tech capital of India. So I bumped into one gentleman who's from Delhi, from Gurgaon. He's now set shop, and now he's coming tomorrow to Gurgaon as well. So and then afterwards, then his thing is called Pipe. So then I said, okay, I want to know what you all do. So he said, sir, I do this.
Namaste. Hi, Saurav, just confirming.
Can you increase the volume?
Namaste. Hi, Saurav, just confirming आप संजय सर के बेटे हो ना?
Now this is an AI generated voice. This is not a real woman.
हाय सौरभ, मैं कॉल कर रही हूँ ताकि मैं संजय सर और आपको सपोर्ट कर सकूं उनकी कीमोथेरेपी से पहले। डॉक्टर राव ने मुझे अपॉइंट किया है एज योर केयर कोऑर्डिनेटर। क्या अभी आपके पास कुछ मिनट हैं बात करने के लिए?
हाँ जी, बोलिए।
ठीक है, मैं शॉर्ट रखूंगी। हम 3 चीजें डिस्कस करेंगे। कल का प्रिपरेशन, फ्राइडे को क्या लेके आना है?
Well, I'll escape this and go on to my main presentation. This particular video I got from my AI friend when I was sitting here in the discussion. So without much ado, let me get back to my presentation. So this, ladies and gentlemen, is just the tip of the iceberg. Now you have a lady who's going to be talking. You're going to change your secretarial staff. They can talk in multiple languages depending on the person. Whoever is lifting the phone, they talk in either Tamil, Kannada, Telugu, Malayalam, Hindi, Punjabi, different dialects of Punjabi, different dialects of Hindi. That lady is going to catch it. Now this is called LLM. So I started learning about what is this large language modeling and machine learning. All of this is happening. NLP as well. So then after all of this, it takes in lots of terabytes of data, processes this, and this for just this particular only 6 slide, it is almost around 80 MB, this particular thing. But they say that they're processing huge tons of data so that just for the Indian market, this is how AI is getting inside. And this is just the tip of the iceberg, just only for the clerical service upfront. So I started, then my viewpoint was that, how do I now create an AI generated hospital where right from sourcing the patient is now seen, goes to the diagnostic center, and then afterwards it comes to my hospital. From then on, the AI generation, the AI machine is put into use. How do we go about that? So now we need to, these are the introduction objectives are end-to-end AI enabled breast cancer pathway. Now Rakesh sir is going to be very excited about this. Then I'm going to map specific tools to each workflow step. Then afterwards practical implementations. And then afterwards, are these actually valid? What are the government needs about this? And then the question that comes is, why AI in breast cancer and why is it needed now? So this huge amount of data, now right from your radiology, pathology, genomics, now we're talking so much about genomics, and in the future that's how it's all going to be driven. And then there's so much of work, there's so much of data, there's so much of guidelines. How do we amalgamate everything to ensure that your patient gets the best? Because we see in the panel discussion here, one person says neoadjuvant, one person says adjuvant, and sometimes we never reach the consensus as to what we want to do to the patient. Can we have a single workflow where it is continuously updated with the latest guidelines and it is able to tell the clinician what is best for the patient? And then afterwards, for the tumor boards, you have 2 tumor boards if a patient goes to, will have different opinions. So with all of this, we need to have, so what does AI enable? It enables personalization, fast efficiency, then afterwards, and safety for the patient as well, because the patient gets what is best and what is the latest, including the latest research that is coming out which has come out yesterday as well. And then here you can see that from the registration, right from registration to insurance, to what insurance, whether he's going to be eligible for trastuzumab. All of us know trastuzumab in some insurances after 2 lakhs they don't give it, even if they have a 10 lakh insurance. So all of this is going to be checked by the AI machine, right from screening, then diagnosis and pathology, treatment planning. This is my forte, or where my heart lies over there. Therapy delivery, and then survivorship as well. This is also very interesting. So the benefits and challenges, again, it's got very good accuracy and consistency in results, very good fast turnaround time. There's personalization, very, very precise. This is precision oncology at its best. And then the few backlogs, avoidable admissions been taken care of. Like patient has low count, he doesn't have to come to hospital. They don't have to put chutti and come to hospital. Everything is taken care of, sorted then and there with other patients' house itself. Again, there could be some challenges like how do we, the algorithmic bias which could be there for the particular local population. American population would have a different setup, and then after our local Dehati population may have a different problem. So we need to see how to integrate those as well. And then let's talk about AI in pathology and biomarkers. I'm not going to be delving too much into each of these, just going to scratch the surface for all of us and give some food for thought. Now, digital pathology. So you could have automated ERPR, HER2 K67, PD-L1 scoring just at scale. It sees, it tells immediately. So your 3-day, 4-day wait period probably shifts over to probably around a couple of hours. Biopsy is done now. As far as the blocks are fixed, slides are cut. In 1.5 hours, you have the results ready on your, and by evening, you can probably start therapy. Again, over here, this whole slide imaging, this I realize is a very, very important entity. So now this, you can see that over here, it showcases that you have a whole slide imager, then you have a slide management system, then the AI screening system which goes on over here. It's able to identify the different tenets. You probably add more information to it, it learns more, it gives you more information. Then here the biomarker quantification happens at scale. Like we mentioned, the IHC standards that we have, then your dish or fish interpretation also are very reproducible with this. There is a structured outflow to the hospital records, and then the tumor boards packets. This HL7 is again a company, and this FHIR again is another modality in this. This helps in quality control, and then you're able to do scale across multiple sites of digital pathology. You will have to do a lot of integration for high thorough throughput reporting. Again, it looks into TILs, immune microenvironment, gives you a lot of information which we normally wouldn't have or we aspire to have. Something akin to this over here. So there is a prediction analysis of tumor infiltrating lymphocytes. This again is, I've picked it up from the AI journals specifically for breast cancer. So we would not go into this. I'm again scratching the surface. Again, what are the platforms that we have? We have IBEX, Galen Breast. We had Dr. Gnat speaking from St. Gallen's. So here, again, AI-assisted cancer detection and grading on whole slide imaging. Then you have Path AI, then Lunetscope. All of these, mind you, are different programs available. They're open source. You could probably log on to the web, and as I talk to you, you can actually start looking at these particular tools which you can use. Again, there are, and all of these are well validated, and they are getting validated on a daily basis. Now, AI in treatment planning and decision support. So we had Meryem talk to us about the different post-operative radiations. Now, what kind of, suppose you have a rectal malignancy, or you have a pancreatic malignancy, or you have a breast which is close to a very close structure, close to the heart, and the heart is getting involved out of the lung. Radiation automation. This is something I found out to be very exciting. Since 2016, it's being done at MD Anderson, but it was in its very infantile stages over there, and now it's gone to a completely different level. It's gone by leaps and bounds. What do we see here? We start seeing that with time, the machines are able to identify, like, the basic planning is done with the scientist. Then afterwards, with time, they started now using the places where you don't have a nuclear physicist or a radiation physicist. It takes over his job. Does all the contouring, tells exactly when you have to just tell the age and then comorbidities of the patient. You fill up a questionnaire which is done by even a non-medical staff. And then you load the CT scans, the MRIs, everything. It does all the contouring, and the radiation oncologist can have a good time talking to the patient, not spending too much time in the TPS. So this is something I found this to be very exciting, and it is almost like 2x better. So radiation oncologists, beware. Here AI may not replace you, but it is definitely going to be a shot in your arm as well. So, and then for systemic therapy decision support. Now this where genomics integration, and then where it takes into all our guidelines, whichever are there, whatever you feed into it, it'll take into that. So it'll take care of your genomics, pathology, like something like how our IBM Watson did, but for some reason IBM Watson did not do very well. But now that was now version 2.0 is again coming up. When I searched for IBM Watson, it referred to it as it was a good tool. So it can refer to it in the past. But then afterwards, when I see there are so many more different tools coming up, which is going to help the medical oncologist make decisions as to what therapy would suit the patient best. We saw Dr. Puneet Prakash talking sometime back. He said that ER 3/8, and they had given 4-AC and 4-taxane. The question that came was like, why not carboplatin for that patient? It is acting like a triple negative breast cancer. Patient should have been on carboplatin as well. So these questions that came to my mind, AI would probably answer those with data. And then afterwards, now predicting immunotherapy response. So host response, proteomic signatures, now taking the patient's blood, looking into the genomic profile of the tumor tissue, identifying what is going to work with what. We all know that PD-L1 is a very poor marker. Is it tumor mutation burden? Is it microsatellite instability? Is it the gut microbiome? Imagine you take a sample of poop, then afterwards you take the sample of blood, take a tissue, it analyzes everything and tells you, know what, this patient has a good PD-L1 positivity, may not work with immunotherapy, may not work. You know what, you need to probably give this person Saccharomyces boulardii, improve his gut microbiome, and then give him the chemotherapy and the immunotherapy. This fellow, it'll work. Combine immunotherapy with tablet, combine immunotherapy with chemotherapy, combine so many permutation combinations. That's exactly what this is going to, we are going to see. And here this OncoHost is another thing which I've just kept looking at. It's a proteomic host response AI decision support. They got the Breakthrough Award in 2025. This is another, I'm not representing any of these companies, but nevertheless, this is just what I found out. So again, this augments our tumor boards as well. It takes it to a completely different level if you're able to utilize all of this. So this takes care of the full end-to-end hospital, AI hospital workflow. So like I told, registration, insurance, screening, risk, diagnose, staging, monitoring, therapy delivery, MDT planning. So again, this is another thing, AI-based, the OCR app, where it is able to tell quickly your waiting time for your patients in the OPD is reduced to a large extent. Now screening, large number of data, I'll spare you the headache for that. That's again the radiologist's prerogative. Again, data fusion for accurate staging, I've finished that. Now this is something very interesting, wearables and data pipeline. So now you have medical grade watches, like you have your Apple phone or your Apple ring. Now have a look at this. All of these things are there. We have a smart ring, smart glasses, smart shirt, smart watch, smart bracelets, and all of this is going to be telling you, this is his pulse, this is BP, this is his heart rate, he's getting excited with this, he's not getting excited with this, and then probably he's having a fever. So with all of this, and then saying that he's received chemotherapy today, day plus 5, his heart rate has gone up, he's going to get into sepsis. Okay, gives an alert saying that, okay, I think you should go and visit your doctor, start on Augmentin or a Ciplox. This information is fed to him on his phone. He'll start there, cut down hospital revisits. So the medical oncologist's profile starts looking glamorous. No febrile neutropenias. As and when the patient comes, identified immediately. Then he says, okay, gives you an alert. Sends, you need to have a CBC, your heart rate is going up, this is what is there. It sends a thing to the laboratory. They'll come home, take one sample. In 2 hours, they'll give you the report. And then afterwards, if you're down, go visit your hospital. And then everything goes on automated flow. So this is something very, very exciting days ahead. Again, recurrence prediction and survivorship. I will again, I'm run out of time, but otherwise this is something, this is very, 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 very interesting which I said. So it's going to tell you like every 3 months visit, it will identify whether you're high risk, low risk. Earlier we had this one particular, 2 months back we had this saying that whether it is necessary to do ultrasounds and chest x-rays on a 3-monthly basis, it may not be needed. Follow-ups may not be needed. This is going to help identify which patients need 3-monthly, which patient needs 6-monthly. Your patient says, sir, I want to go to US, my daughter is there, she's giving birth to a child, I can't come back. You can say happily go. You identify that, you tire them and then you tell them you go. So now I'll leave this. Now something which I want, AI-powered solutions for the clinician in 2026. This is the take-home. This is not just rhetorical speech. This has a large amount of hard work has gone in to find out solutions for you all. So if you have your smartphones, you can probably zoom into this and look into all these particular solutions as well. So for AI medical scribes and documentation. So if you want, documentation consumes more than 50% of your clinic time. If you want to save 2 to 3 hours a day, Heidi Health, Suki AI, these are all the different things that you have, you'll be able to save a lot of time. And then afterwards, if you want treatment planning and genomic analysis, Tempus is one which is coming now. I'm sure many of us know. Then AI pathology, there's a Page AI and Path AI. So this is for second-read accuracy and complex slides. So if you have digital slides, you can actually put it online and afterwards get an opinion on this as well. So literature and research assistance. So you have consensus, you have elicit. I use Perplexity and I'm finding it to be very, very useful. And it's free on for Airtel subscribers anyway till next year. And then for patient communication education, this is very, very vital. Like Dr. Rakesh sir was mentioning, what information to give. So just show it to the patients, don't tell. People will understand. Vaid sir was saying today, it's like if you just have videos and pictures, we will all understand rather than have text. So this is very good. This is going to be very important. This, my friends, you can take this out. Viz.ai for the patients. And then afterwards for prompts, patient reported outcome measures. Now this is huge amount of data. This huge amount of, this is an unmet need, PROMs. If we are able to capture this, how do we ensure that the patient who's undergone therapy is doing well, is well taken care of, so that he or she will come back to you, will not
Rajiv,
jump.
Can you wind up, please?
Sir.
We're late.
Done,
so
sir.
We will request Ashok to email your presentation to all of us.
Absolutely.
And we have access to all the QR codes and your hard work.
Sure, sir.
Can you conclude now, please? Thank you.
Thank you, sir.
Actually, all that glitters is not gold, like our speaker's oratory capacity and AI. With his oratory capacity, AI has become very glittering, but actually AI has killed one person in Gurugram. That guy Googled that I am having pain in the shoulder. AI answered after giving all the data that you are possibly having musculoskeletal pain. And finally, he died of myocardial infarction. So it can also happen. So be careful. Keep your clinical eye alert, and AI is no panacea to it.
So over to the hall in charges. Thank you very much for this opportunity.
due to time constraint, we will not be having a formal tea break. I would request the delegates to please go and have tea and bring it back to the conference room. Also, I would request the delegates with the poster presentation to please go and stand next to the posters, as we'll be starting the evaluation for the posters. And now I would like to invite chairpersons for the session 7, which is Breast Cancer in Young Women, Research Highlights and Continuing Gaps. I would like to invite Professor Jens Huber, who's a Breast Cancer St. Gallen Steering Committee at Switzerland, Dr. Sameer Kaul, Senior Consultant in Apollo Cancer Institute, New Delhi, Dr. Harit Chaturvedi, who's an oncologist in Max Institute of Cancer Center, and Dr. Kaushal Kalra, DA Medical Oncologist from AIIMS. Thank you.
Dr. Mary Rankin for Professor of Breast Cancer Surgery at Netherlands Cancer Institute. Is this it? What's in the program?
यहीं पे थे अभी
Okay, okay. I think I've changed the schedule. Yeah, you changed it. No, it's perfectly fine. Oh, this is good. Okay.
Okay, so thank you very much for the invitation. That's first of all, of course, to come to India from the Netherlands on behalf of young women with breast cancer care. So I'm honored to be here, actually, for sure. My task to talk about the pros and cons of de-escalation of breast cancer treatment in young women. And of course, I realize that I'm coming from a very different country that you are here in. The Netherlands, it's a tiny, tiny, small country. India is much larger. It has much more inhabitants. And also, you face way more breast cancer patients than we do. So, having said that, in our tiny little country with 18,000 new breast cancer patients per year, the incidence of breast cancer in very young patients, so under the age of 40, is about 4%. That means around 600 patients per year. And the incidence actually didn't really increase. We looked at how we treated them way back and the later years, and we saw an increase in the use of neoadjuvant systemic treatment. We saw a slight increase in breast conserving treatments, and we saw a large decrease in the amount of axillary clearances. I, of course, listened to the panels just now in the previous sections, and axillary clearances, that's a very, sort of hot topic, which is definitely changing. And as I said earlier, in the Netherlands, we are barely performing axillary clearances anymore. And later in my talk, I'll tell how we do that. I also realized that this just recently published paper from a group of very young patients, younger than 30 years of age, that you are facing, half of them only had early breast cancer and the other half was locally advanced or metastatic. So basically the overall survival rate was very low compared to the Western countries, and obviously the authors of this paper concluded that we have to aggressively treat these young women. But having said that, that's always based on the general concept that young women will have a worse prognosis, late detection, more grade 3, more lymphovascular invasion, more triple negative tumors. However, when you are looking at, and this paper already has been mentioned earlier today, when you're looking at the specific subtypes of breast cancer, it's definitely not in all the breast cancer subtypes that young women do worse. So maybe it is just one other factor, and you have to always look at the complete picture of every individual person. So basically, this paper said that the luminal A patients, young breast cancer patients, they do worse, but in the other groups, no significantly difference was be found in survival. So why is this topic, de-escalation of breast cancer treatment in young women with breast cancer, so important also for me personally? Because actually I was one of those breast cancer patients, and that was already more than 20 years ago. So basically, yes, I was very young. And back in that time, also in the Netherlands, the treatment was very aggressive. I had to have ablative surgery because actually I was even such a young woman who ignored it in the first time, so it was already a recurrence. And the first lump that was removed, actually the pathologist messed up the diagnosis. So all those things also happened in the Netherlands. So basically it was a recurrence at that time. So the guidelines said ablative surgery, axillary clearance, and absolutely treat it with chemotherapy because you are very young. But then later on in that week, and actually I came to the hospital that I'm working on now. I spoke to my colleague, my current colleague. She worked there at that time as well already. And we were not just looking at the guidelines, we were looking at the tumor specifically, and I was offered a tailored treatment back in time already back there. And that meant a lot to me because it was not ablative surgery but breast conservation. It was not an axillary clearance, but it was a sentinel lymph node biopsy. And the most important things, I didn't have to undergo chemotherapy. So that was very brave in that time because I was really young and the guidelines all said the things on the left side. But here I am more than 20 years later and they did the right thing for me. So that's of course why this topic is also, well, yeah, a personal something for me. How do you come to tailored treatment? You need a multidisciplinary team and discuss every patient to really find out what are the personal possibilities for tailored treatment, considering the biology of the tumor and the biology of the woman facing the tumor. What can systemic treatment do, and what is there still needed in surgery and radiation treatments? And where can we actually de-escalate in breast cancer treatment? You can do it in primary surgery setting, in the neo or adjuvant systemic treatment setting, or the local regional treatment after neoadjuvant systemic treatments. Actually, in the primary surgery setting, well, you can either de-escalate in DCIS, grade 1, 2, such as being investigated in the LORD, the LORIS, or the COMET trials, but they are not including patients under 40 years of age. What about de-escalation in nodal staging? So basically the best known trial is the SOUND trial, where they didn't perform a sentinel node biopsy anymore, and compared then of course to the group of patients that still did. And they didn't see a difference in 5-year disease-free survival. When you're looking at the numbers, you only see that only 1% of the patients that they included in this trial was younger than 40 years of age. So actually, I think we can't de-escalate in doing the sentinel lymph node procedure based on this trial in the young women. Then, of course, the INSEMA trial results have been published as well. Identical results, so there is definitely a group of patients where no sentinel lymph node biopsy has to be performed anymore. But here it's not clear how many patients were under the age of 40, and I expect about the same as in the sound. What about de-escalation of systemic treatment? What's out there? What are the options? Especially since we know that we are reaching very high PCR rates. So the systemic treatment is becoming way more effective than it used to be. And what can we do then in de-escalation? Now it's a little bit stuck. Is there also a pointer? No. Where I pushed before doesn't do that much anymore. I'm doing completely without this.
Somebody from
I'll do this. I'll do this. It's good as well. So, do we know if the PCR rates in patients younger than 40 are identical to the patients over 40? And what de-escalation trials are out there, and are young patients participating in these trials? Coming back to the first questions, there are actually not that much data out there, but there are a few publications on it. Small groups, but still it doesn't seem to be different in especially triple negative and HER2 positive disease, maybe lower PCR rates in the ER positive disease. It is not really working nice. Yeah. So what would be the options in the ER-positive breast cancer? Are there patients where we can do without chemotherapy? I'm going to show you some results of our TRAIN trials in the HER2-positive breast cancers and some of the immune therapy trials in the triple-negative breast cancer. So for HER2-positive, I looked up what you are doing, and I found it in this very nice comprehensive overview. And it's depicted here, but you know better than me. And of course, we also know that since the introduction of trastuzumab, the overall survival in metastatic setting has been increased. And of course, there were numerous studies to use the trastuzumab in neoadjuvant systemic treatment studies. In the Netherlands, we have our own trials, and actually the PI of this trial was Gabe Sonke, and it's already a lot of trials moving like a very quick train. So starting with the train 1, he actually, that's a single arm observation study introducing the concept of paclitaxel, trastuzumab and carboplatin with very high PCR rates. Then the train 2 trial actually compared this new regime with a regime with the anthracyclines. And actually the results were very good, less cardiotoxicity obviously, and less leukemia, and with the same results. The TRAIN 3 trial was performed in more than 400 patients, and for today, very important, about 15% of them were younger than 40 years of age. Then we have the TRAIN 3 trial. That's a real de-escalation trial based on the images in between. So we started with 3 cycles of PTCP. We added pertuzumab to the regime. And response evaluation was being performed by MRI. Already 30% of all the patients had a PCR after 3 cycles. And another 30% had a PCR after six cycles. And in total, almost 80%, a little more than 70% of the ER-negative, HER2-positive patient group reached a PCR after 9 cycles. And a little less, that was 60% in the patients with ER-positive, HER2-positive disease. So very high PCR levels. Also in this trial, about 20% of them were younger than 40 years of age. So we included everybody and also the very young patients. So also the young patients were de-escalated. And now we're about to do the TRAIN 4 trial to see if chemotherapy at all is necessary. But this is still a trial without results. What about the triple-negative breast cancer? Also here the regimes that you're giving in your current guidelines, and a lot has been said already about triple-negative breast cancer earlier today. Are there young patients where no chemotherapy is necessary? Actually, we have a group of patients younger than 40 years of age, and it's being published as well already by my colleague Sabine Lin. The patients with a T1 breast cancer, triple negative, with very high levels of TILs do extremely well without chemotherapy, because all these patients that are being shown here did not have chemotherapy. So indeed, there is a group of patients, namely the T1 and 0 patient with a triple negative breast cancer but high levels of TIL. They can do without chemotherapy with a good overall 15-year survival rate. So that made us, because this is of course a retrospective cohort, that made the basis actually of the design of this optimal trial, which is currently including T1 and 0 breast cancer patients with high TIL levels, to not give them chemotherapy anymore. And there are some checks in the schedule, as you can see here. Of course, when after surgery the pathology result is different, it's either larger than we expected, then of course there's still the escape to indeed still give chemotherapy. And then more about the TILs, of course, another colleague from our institute, Marleen Kok, she is really, well, on top of this and knows the best what's going on in this field. And she started a very nice so-called non-randomized basket study, the Bellini, in which she actually experimented with introduction of immune therapy, different immune therapies in different baskets. And the first she started with nivolumab and then surgery, and the second cohort included patients that were treated with nivolumab and ipilimumab. And actually the first cohorts are being published already, have been published already, excuse me. And also again, well, the results you can read, of course there is mixed response, but there are definitely about 20 to 30% of the patients that have a PCR based only on the immune therapy, so they are not being treated with chemotherapy anymore in this study. But most importantly, again for today, of the first included patients in different baskets, that now there are 75 patients included, and about 15% of them, again, are younger than 40 years of age. So it's also not an exclusion criteria in this trial. And in this trial is especially important because it's also being mentioned already earlier that the young breast cancer patients seem to have higher TIL levels than the older, and also seems to lead to a high response on immunotherapy. So this is definitely, probably going to be a very good answer for quite an amount of young breast cancer patients facing triple-negative breast cancer. And this was not only the T1, this is just being done in stage 1 to 3. It's also quite, because that's of course the con of de-escalation of treatment in these very young breast cancer patients. It's also sort of a study where you have to be brave, and I talk to Marleen Kok on a daily basis, and sometimes of course we're following all these patients very carefully, and sometimes I notice that we're sort of, okay, are we doing the right thing? Yes, indeed, we are doing the right thing when already a patient is longer in follow-up and things like that. So it really seems that we can use these TILs and de-escalate the chemotherapy in these patients. We also notice that the young patients especially do suffer more side effects of immune therapy than the older patients. So that's something you really have to take into account and make sure that all the patients, all the specialists in your clinic are aware of all these side effects, that you recognize them in a very early stage. Okay, and what is else to de-escalate, or actually maybe you should say just tailor, in the treatment after neoadjuvant systemic treatment? For example, this young patient, she had a clinical T2 breast cancer, was treated with 9 times PTCP, and she had a near complete response. Actually, we all know already that we can sort of well, based on the response, we can de-escalate the breast surgery. And because this sound already went, I'm going to go quickly through this part because that's not that very new. Whenever she wants, of course, she can have ablative surgery, and in the Netherlands we perform most of the times skin and nipple sparing ablative surgery and then place the prosthesis. Here it's still placed behind the pectoral muscle, but nowadays we place it in front of the pectoral muscle. But whenever she has this near complete response, she of course can also choose for a small wide local excision of her breast, and for marking we use radioactive iodine seeds. You can of course also use other markers. This person had a pathologic complete response, and the trial that's currently going on is, can we then de-escalate further? So don't give these patients radiotherapy anymore. So this is a study, clinical T1, 2, and 0 patients that reach a pathologic complete response and then no radiation treatment afterwards anymore. It's still including, so I can't show you any results, but it's including quite nicely. It's almost finished. Important again for today, a lot of patients are under the age of 40, so they're also again included. And then I want to come back to the axillary, because I sort of earlier today I said we barely do axillary clearances anymore in the Netherlands, and that is really actually the case. This patient, 38 years of age, started with this extensively involved axilla. She was treated with PTCP, she had a radiologic complete response of her breast, and why don't the lymph nodes respond as well? Of course, this is a nice operation to perform, but we should not do it when it's not necessary, because it has nasty comorbidity, especially in combination with radiation treatment. So also already being mentioned this morning, sentinel node trials were being performed using dual tracer, and I know you use here more or less one tracer, and the false negative rate was too high. Then other procedures were invented, like the TAT, which is very commonly being used, but I'm going to tell you why you do not have to do that, because we invented the MARI procedure. It's also a little bit named after my name, Marie-Jeanne, and a colleague who was called Marieke. So the two of us sort of, made this concept. So the concept is just mark one of the pathologic lymph nodes and then selectively remove it. We use an iodine seed for it, so we remove it with the probe, but any marker can be used. And now I'm going to go quickly through the results, because we have been published the 5-year follow-up already using this schedule. So pre-chemo axillary staging is being performed with a PET, and either a patient has 1, 2, 3 pathologic nodes or more than that. Whenever the MARI is negative in this first group, we do not do any axillary clearances anymore, or any axillary treatment anymore. Whenever you start with 1, 2, 3 pathologic nodes and you have a pathologic complete response in this one removed marked node, or you start with more than 3 pathologic lymph nodes and you do reach PCR, we only give them radiation treatment. And the right group is the only group of patients that still need an axillary clearance, and of course radiation treatment is being added. This way we have omitted axillary clearances in 80% of the patients, and of course that's very nice, but you need follow-up, and we do have follow-up. My PhD presented it. She was quite a little bit nervous, but did really, really great at ESCO last year. And it was being published in the JAMA Oncology this year. Here you see the disease-free and overall survival of the blue line patients that did not undergo any axillary treatment. The red line, the patients that only got radiation treatment. And the patients that had extensive nodal disease to begin with were also de-escalated. This is also being published, a 5-year follow-up. Also there you see acceptable 5 years disease-free and overall survival rate. The blue line, only radiation treatment. And the red patients that are doing the worst actually are the patients that started off with extensive nodal disease, still have residual disease, underwent an axillary clearance and radiation treatment. And I'm really telling it this way because they are still doing the worst. So we did the most and they're still doing the worst. So are we actually doing anything with an axillary clearance? I don't think so. Anyway, also here a large
summarize it now.
A large population of young breast cancer patients, 240 of them, and the results were the same. So basically, having said that, yes, indeed, we should de-escalate wherever it is possible in young women, because their quality of life can be improved. And what is most important is that we have to show data of young women, and things like this, like being invited here and talk about these topics with you, are very, very good. So I like the initiative. I'm sorry
Thank
for
you.
the time.
Thank you. No, it was brilliant.
I want to thank my
a lot
team,
of lessons
and
to be learned. Yeah, great.
And you have
Thank
a
you.
great country.
Yeah.
I'm sorry.
Thank you. Now we have Dr. Vaid, who will be talking on research in India, as far as.
Yeah, I invite Dr. Kaushal Kalra to join.
Research status in India.
So I think in the interest of time, since we are talking of the gap areas, and I have two of my best friends sitting here on the dais with 30 years plus experience in oncology, I think it can't get better. And in the interest of time, I will skip some of the initial generic slides and come to the core of the discussion, that what's happening. Can we move on? Yeah. So the disease landscape, I think we would skip these generic slides, and in the interest of time, as I said, this is a slide, pivotal slide, I would focus on and spend 5 minutes here and get your thoughts and your suggestions, because we come from different backgrounds. Dr. Kaushal, I think what this slide depicts is the year-to-year breakdown of cancer clinical trials by treatment intent. And if you look at it, the data is captured from 2008 onwards, though prior to this, the information is not very well available in public domain, though there have been trials. We participated in some of the practice-changing trials like the Tandem trial, anastrozole, trastuzumab, later lines. We participated in the Gela Prima trial, and so on and so forth. So, but if you look at the initial, years have been very, very slow, almost about 10 years, no activity. And when the activity picked up, around the year 2010 to 2012, there was activism, and then everything slowed down. Now, if you break this down to the different categories, the treatment intent is the treatment of the disease directed, and you can see the optimizing operational aspects of surgery and treating the cancer-related symptoms and mitigating the treatment-related toxicities. Now, these are the clinical trials. Dr. Kaushal, you are in a tertiary care center. So what do you see in, I think in the interest of time, we just about 5 to 7 minutes, how collaboration could sort of take these bars higher?
Definitely, actually, I think since last 15 or 20 years, there is no chemotherapy. Only chemotherapy is just like history only, and the invention of the immunotherapy, targeted therapy, ADC. This, we are staying in the era of the ADC. So because we are from the, actually, our patients are not affordable. I am from the private hospital, the public hospital. So these therapies are so costly, and it's very difficult to out of the approach to the poor patient. So because of the collaboration, clinical trials, we can make these available to our poor patients also. And whenever this patency will breach or break, then this biosimilar will be available, and it will help our poor patients.
And you guys have done it. There is the Austrian breast cancer colon group. We've been, reading the data, and then you have always had your own sort of trials, and you did it, And what is it that made the difference in your setting, in terms of putting the clinical research together, how centers came together to take it forward?
Well, probably it's, that you have a networking, that you have regular meetings, that you help in enrolling in patient in trials, and that you do trials not only in one country but in several countries, so that you do international multi-center trials, because some of the questions cannot be asked in one country alone. In particular, when we see that we only now treat fractions of breast cancer, we do not treat breast cancer patients with the same treatment, and so the portions of patients being enrolled in clinical trials are getting less and less, and so I think we need to work together on in the sense of international multi-center trials.
Thank you so much. Harit, so you have seen it,
Yeah.
right from the 90s through the last 3 decades.
I think the 3-4 elements required. One is electronic medical record. That is a very crucial. That somewhere to properly collect data, that is crucial. Second thing which is very important, that every hospital, unless you have an MDT culture, unless you have a culture of collaboration and discussion, these things will never take off. So that is crucial. And as very rightly pointed out, that discussion beyond the walls of the institution itself, that is between multiple institutions. Having said that, if you look at it, all DNB students are putting thesis work, they're doing some research work, some collaboration. But even that is not going beyond the research thesis work done at that time. It can be published, it can be taken forward, can be taken. Fortunately, last 5 years have taken a much bigger swing than what you're saying. Now I feel that the churning is happening a lot more, and the main reason probably is that more young population is coming up. So a lot of old timers were caught in the day-to-day, and especially those in private sector. I would say now that culture is coming up, more people, hands are available, people are thinking and questioning each other. So, and as you mentioned about AstraZeneca and other trials as pharma-driven, I think the time has come for PI trials, research from within the institutions, supported by institutions, by some funding, maybe some grant available for that. So these things are happening. If you notice, last 2 weeks, the government of India has released a lot of 1 lakh crore funding for cancer research has come in, and a lot of new things are happening. So scope is increasing rapidly.
That's more than about $10 billion, dollars. More than $10 billion. Samir, I have changed this slide, and I've brought up the breakdown as far as the clinical trials by the type of intervention. And if you look at the light blue, that is the drug trials. Now that is taking the most of the space. Of course, the basic research is a challenge, will continue to be. What's your thought on this?
I'll take the liberty of answering both this slide and the one before that.
I'll go back.
I want to offer a couple of my comments on the earlier one. Everything that was said before me was absolutely correct, but I think the vital point that all that is making it happen in terms of improving the infrastructure, the technical infrastructure, the electronic medical records, the funding, the placement. So increasing accessibility is fine. But I think the foremost thing that needs to happen in our country, more than, although I'm happy that the graphs that you're showing is showing an upward trend, but what really needs to happen is mind space for medical research is deficient, not only amongst the caregivers, the care providers, it's even deficient among the healthcare planners. It's even more deficient among the people who are going to get involved, the so-called fodder, which is the communities around us, because they're going to be participating in those trials very willingly and legally. So I think the overall importance of research, in healthcare, finding new drugs is part of it, and oncology is what we are talking about today. I think that needs to go up. That needs to be incentivized. So a large portion of it is awareness. Still awareness. The other things will happen as you develop, as more centers appear. Now you've got a medical college as a cancer center in the periphery. Right. So nothing stops you. You're out there in the community. Right. And when your records and your digital outlays improve, that will happen.
So Dr. Ramesh will be very happy to hear that. Could you please offer your comment? You've been talking about data collation. A very brief, quick comment, sir, and the networking of the data,
Ashok, just last 2 weeks back on Twitter, we saw that Tata Memorials published 100, they got 100 publications in 1 month. The month of August. Yeah. So a lot is happening around, and we have to celebrate that as well.
Sorry, Samir, you were interrupted. Yeah, please.
No, I wasn't interrupted. Most of what I needed to say was fine. But, we always have it's always multi-pronged. It's never one thing or the other. It needs improvement at all steps. But I've always found that the willingness to submit one's mind, heart, time, energy, resources to medical research, that bit needs to improve.
How can you, sir, your comment and your comment also, how to fire the young minds?
Well, unless we do it, they cannot. As parents, simply, our children will learn from us what we do, not what we say, right? They see it day in and day out for 365 days, at least for 10 years. And after that, maybe they have different opinions. But earlier on, that's what they learn. So I think it is important the elders have to do. But anyway, we are still there. So I think even if we do it from now, for the next 10 years or 5 years, depending on our age, and
Thank you.
The generation will learn.
Thank you so much. Thank you, gentlemen. I think we had just 10 minutes and we are almost at the stroke of the clock. Thank you so much.
Mahima, you have breast cancer and you are very lucky. मेरे डॉक्टर ने मुझे ये कहा, मुझे बहुत गुस्सा आया कि लकी और कैंसर आप एक साथ कैसे यूज कर सकते हो?
This is a message from actress Mahima Chaudhary. She'll be here tomorrow on this platform to interact with the patients' families and the patient advocates. She's been treated for breast cancer.
जल्दी पकड़ना हमारे हाथ में है। मैं महिमा चौधरी, एक एक्टर, मदर और कैंसर सर्वाइवर। Mahima, you have breast cancer and you are very lucky. मेरे डॉक्टर ने मुझे ये कहा, मुझे बहुत गुस्सा आया कि लकी और कैंसर आप एक साथ कैसे यूज कर सकते हो? लेकिन मेरी एक आदत ने मुझे लकी बनाया, मेरी रेगुलर हेल्थ चेकअप वाली आदत। कितना अच्छा होगा कि इस आदत की शुरुआत आप अपने घर से ही कर पाएं। कैंसर होना ना होना ये हमारे हाथ में नहीं है, पर उसको जल्दी डिटेक्ट करना, जल्दी पकड़ना हमारे हाथ में है। मैं महिमा चौधरी, एक एक्टर, मदर और कैंसर सर्वाइवर।
The next topic of discussion is Beyond the Tumor, Optimizing CINV Management with Akynzeo During ADC Treatment. I would like to invite Dr. Ankunanda Varshney, Senior Consultant in Medanta.
Good evening, and after a wonderful discussion which was quite thought-provoking for all of us, now we are moving to a topic which is less commonly discussed among us, optimizing the treatment of cancer patients with a special focus on chemotherapy-induced nausea and vomiting. And we have tried to focus more on ADCs because now ADCs are the drugs which are revolutionizing the treatment of breast cancer. So, we already know that ADCs are the talk of the town. They are the drugs which have been revolutionizing the cancer treatment by providing a more targeted approach to deliver chemotherapy. And everywhere there is a discussion of DB09 with a PFS benefit of over 40 months. So what's the potential side effects besides getting a good PFS and OS benefit we are detecting? A common side effect of these drugs is nausea and vomiting. And this nausea and vomiting is crucial because this can hamper the quality of life of patients, and if not handled properly can lead to improper dose reductions or discontinuation of treatment, and ultimately outcomes of patients are being compromised. So what are the risk factors? This includes important drug type. There are various drugs which NCCN have categorized in the risk of high risk, moderate risk, low risk, and then there are certain patient related factors. The patient-related factors includes younger age, female patients, prior history of any chemotherapy-induced nausea, vomiting, prior significant history of morning sickness, and this most important factor is the anxiety of the patient. We already know that antibody drug conjugates had a special toxicity, which is called as GI toxicity, and besides non-hematological toxicities, this is getting improvement in many clinical trials. But the main importance, majority of these clinical trials do not address this issue. So we have the ADC which have been approved, includes the enfortumab vedotin, where nausea was reported in the clinical trial as high as 23%. With mirvetuximab, it was reported about 29%, and with tisotumab, it was reported to be 27%. The most important, Enhertu, which is widely used these days. So in Destiny Breast 4, in cycle 1, nausea was reported in approximately 60-30% of patients, and vomiting was reported in 22% of patients. Following in the subsequent cycles, owing to a better antiemetic regime management, the rate of nausea was down from 63 to 24, and rate of vomiting was down to 22 to 10. Most of these incidents are higher in the cycle 1. So we know that both TDX and sacituzumab has an increasing emetogenic potential, and nowadays, owing to this, NCCN has reclassified them as highly emetogenic drug, and ESCO and ESMO classify them as moderately emetogenic drug, keeping them comparable to the high dose carboplatin. So what are the different features of delayed nausea and vomiting we are getting with ADCs? With the trastuzumab deruxtecan, median time to onset of nausea was found to be 3 days, while with sacituzumab, it is a slightly delayed action, and it was 8 days. Median duration of nausea was found to be 10 days, and if we look at this aspect, then in a cycle of 21 days, approximately half of the period, patient is experiencing nausea. And in sacituzumab, median duration of nausea was found to be 5.5 days, and then when we have to repeat again on 8th day, the second dose of this cycle, patient may still be having persistent nausea. So median duration of vomiting was found to be 3 days, and the most important factor is that while the patient is on treatment, half of the time patient is still having persistence of these symptoms, nausea and vomiting. If we serially analyze the Destiny Breast trial, then approximately in any breast series, any series we know, Any grade of nausea was reported in approximately 60 to 70% of patients, while grade 3-4 nausea was reported in around 5 to 8% of patient population. Coming to vomiting, it was reported in approximately 25 to 50% of patient population in any of these trials, while grade 3 or 4 vomiting was less severe, it was reported in less than 5% of patient population. So coming to the impact, what these nausea and vomiting did in this Destiny Breast trial, this led to dose reduction in approximately 5% of patient population, dose interruption in 2%, and discontinuation was found in 1 patient because of severe nausea and vomiting. And the main important issue which was highlighted, these all Destiny Breast trial doesn't include a pre-specified antiemetic prophylaxis, and majority of antiemetic prophylaxis was left to the investigator assessment. So we addressed this. Nausea and vomiting had led to a meaningful increase in the scores and led to deterioration in quality of life of these patients. And with the impact of nausea and vomiting, this was more severe in the Enhertu arm as compared to the chemotherapy arm. So this is a designated critical gap in the diagnosis and management of long delayed nausea and vomiting, and we need to identify the drugs which are effective, long acting, which ensures maximum treatment adherence, minimize the toxicity, and leads to an improvement in quality of the life of patient, which is the ultimate treatment goal. And for this, in high risk or in high emetogenic potential, as per NCCN guidelines, the combination approved is either a fosaprepitant or netopatent or rolapatant, along with a 5-HT3 agonist, which includes palonocetrone, ondansetron or granisetron, along with dexamethasone and adding olanzapine. While for the delayed phase, we may use aprepitant if it was used on day 1, and a combination of dexamethasone and olanzapine can be done. So this is a study where 62 patients having trastuzumab deruxtecan were identified. And on the basis of this, they were analyzed for having a high risk potential. 15 patients were found to have a high risk potential for nausea and vomiting, and they were offered a combination of netopatent along with dexamethasone, while rest 38 patients who were not identified to have high risk, they were offered the standard of care with dexamethasone as well as 5-HT3 antagonist. So during cycle 1, the observation was that 58% of a patient had nausea in the 5-HT3 groups, and there were more grade 2 and 3 adverse events in the 5-HT3 group as compared to the NEPA group. If we look at the incidence of vomiting, approximately 21% patients in the 5-HT3 group were having vomiting, while in the none of the patients in the NEPA group had a vomiting. And I will like to note, these patients are already pre-assessed, and on the basis of when they were found low risk, then only they will going for the 2-drug combination. So in next cycle, again the reclassification was done, and among 22 patients in the 5-HT group, 15 patients was escalated to receive NEPA in the cycle 2. And we recorded there was 100% reduction in the risk of nausea in these patients in cycle 2. And further, any grade vomiting was decreased from 47% to only 13% in cycle 2. So the addition of netopatent along with the standard of care is going good and is helpful in ameliorating the nausea and vomiting caused by these ADCs. So now this is an European study where patients from Ireland, Italy and Spain designed to receive Enhertu were evaluated, and out of them 170 patients were analyzed. So the prophylaxis for nausea and vomiting were administered in these patients, and majority of the patient, approximately 46% patients had received dual blockade, and approximately 10% of the patient received the triplet blockade. Coming to one more study from the Japan, this is a study comparing the role of double versus triplet antiemetic prophylaxis. This is a phase 2 study which compared either the combination of netopatent with 5-HT3 antagonist with DEXA or 5-HT3 antagonist with DEXA. So these patients were randomized on the basis of pre-classified assessments. 40 patients were used, and these were randomized in the ratio of 1:1. So the graphs speaks for themselves. After after a cycle 1, we see the graphs with the blue lines were those who have received the 2-drug combination, while with the red lines were those who have received the 3-drug combination. And on any day, the patients who have received the fosaprepitant were having less incidence scores of both nausea as well as vomiting. So a more advantage of the combination of this netopatant with 5-HT3 agonist is coming with the role of being DEXA sparing. Nowadays, as majority of the treatment is combined with immunotherapy, where the combination of DEXA is contraindicated. So if we are combining the immunotherapy with cisplatin, which is mainly used in the head and neck cancers, this high dose cisplatin is again having a highly emetogenic potential. And the combination of netopatant along with 5-HT3 antagonist offers a regime which could be a DEXA sparing. This is a study which showed 252 patients were randomized either to receive NEPA plus day 1 DEXA only. The second arm includes the NEPA plus 3-day DEXA, and the third arm includes the NEPA plus 4-day DEXA. So after this, we see in patients who had received NEPA with day 1 DEXA only, there was significant reduction in the nausea, and this nausea was quite comparable if the DEXA was interrupted on day 2 and day 3. The rates were comparable of nausea and vomiting. Thus, non-inferiority of each DEXA sparing regime was documented, and a single day DEXA along with netopatant can offer reduced incidence of nausea and vomiting in patients receiving highly emetogenic potentials. So on the basis of this, now as the ADC have been classified to high-risk antiemetic drugs, the NCCN guidelines recommend the combination of 5-HT3 antagonists with DEXA with NK1 along with olanzapine is a preferred choice. However, in case this treatment also is not doing well, then we can ensure further treatment with the patient counseling, encouraging them to have eating small meals, avoid food with strong smells, prefer a food which is at room temperature, and in case further if nausea and vomiting persists, a dose reduction in the treatment could be there. Thank you.
For the next talk, I would like to invite Dr. Hemant Malhotra from Jaipur to give his talk on optimizing survival outcomes in HER2-positive metastatic breast cancer.
Thank you very much. As this is a AstraZeneca-sponsored session, there will be some restrictions on the slides which I show, but I will certainly make sure that there is knowledge gain for you at the end of the talk. So we're going to talk about the advances in the management of HER2-positive metastatic breast cancer and how we can improve on the survival advantage with anti-HER2 targeted treatments. And this is what we'll cover in the next 20 minutes. Current treatment landscape, unmet needs in the first line, HER2-positive MBC, and emerging treatments. So let's first talk about the current treatment landscapes. This is the latest NCCN guidelines for patients with recurrent, unresectable, or metastatic HER2-positive, either hormone receptor positive or negative breast cancer. And the first line approved treatments are a combination of 2 anti-HER2 targeted monoclonal antibodies with either paclitaxel or docetaxel, and both are category 1 recommendations. Second line, we have TDXD, which is again category 1 recommendation. Third line, we have the oral anti-HER2 tucatinib in combination with trastuzumab and capecitabine, also TDM1. And in the fourth line, then we have several other anti-HER2 agents in combination with various chemotherapeutic agents which have not been used in the first or the second line. So the European guidelines, HER2 positive metastatic breast cancer first line, this is based on hormone receptor expression. So here you have hormone receptor positive or triple positive, if you say so, metastatic breast cancer first line treatment. Category 1A recommendation is for a taxane with dual anti-HER2 monoclonal antibody, trastuzumab or pertuzumab. And then once the chemotherapy 4 or 6 cycles are over, you continue with trastuzumab, pertuzumab until disease progression. This is category 1A recommendation. For patients who have HER2 hormone receptor negative, HER2 positive MBC, the combination is the same, and this has chemo plus 2 anti-HER2 agents followed by the 2 anti-HER2 agents till progression. If there is in the triple positive group, if there is stable disease or objective response, then you could think of adding a CDK4/6 inhibitor. And if there is progressive disease, then we'll come to what you need to do in the next slide. So this is now a second line post progression, either during neoadjuvant treatment or first line treatment. Here the critical factor is the presence or the absence of a brain metastasis. If there is active brain metastasis and a local intervention is not indicated, then the recommendation is TDXD or a combination of tucatinib with capecitabine with trastuzumab. If a local intervention is indicated, and if there is progression of the disease outside the CNS, then again the one recommendation is trastuzumab deruxtecan. If there are stable brain metastasis, then again the combination is TDXD. And what about third line treatment? The European recommendations again give importance to brain metastasis, and here a category 2A recommendation is for TDXD in both the settings. If there is progressive disease on TDXD, then you have a combination of oral anti-HER2 agents with IV anti-HER2 agents with various combinations of chemotherapy. You also have the newer anti-HER2 agents, margetuximab, in the third line setting. Now, how did we come to having the taxane plus the 2 anti-HER2 agents as first line? This was the Cleopatra trial. Our young colleagues should know this. The Cleopatra trial, we have long-term overall survival and PFS now available for the Cleopatra trial, started in 2012. And one of the classic regimes in HER2 positive metastatic breast cancer, the combination of the dual HER2 blockage produced significant overall survival benefit and significant progression-free survival benefit also. So to reiterate what I was saying, the Cleopatra demonstrated that the combination of chemotherapy, a taxane, with dual HER2 blockage improved PFS, improved overall survival as compared to trastuzumab and taxane in the first line setting. So this study is as old as 2012, and for a good 1 decade there was no change in this regime. This continued to remain as the standard of care for more than 10 years. For the triple positive patients, the addition of CDK4/6 to the anti-HER2 treatment and endocrine treatment was evaluated in the PATINA trial, and this again demonstrated improved progression-free survival with palbociclib, anti-HER2 therapy and endocrine therapy. You can see the progression-free survival here, and this PATINA group trial also demonstrated that you could safely combine a CDK4/6 inhibitor with an anti-HER2 agent and endocrine therapy. The MARINA trial compared TDM1 with or without pertuzumab versus trastuzumab plus taxane in the first line HER2-positive metastatic breast cancer patients. 3 arms in this trial, 1:1:1 randomization. One arm was TDM1 plus pertuzumab, arm 2 was TDM1 single agent, and arm 3 was trastuzumab taxane. Remember, this is first line HER2-positive MBC. Primary endpoint was PFS, secondary endpoint was OS, response rates, duration of response, quality of life. And here are the curves for you, and the author's conclusion was that TDM1 containing regime showed non-inferiority but not superiority in the PFS. So the combination of trastuzumab taxane continued to remain the standard of care. Now this is the data for all the first line summarized and collated for you. These were the trials. Some of these trials we have discussed: the Cleopatra trial, the Peruse trial, the Patina trial, Emerald trial, and Pertain trial. And for a good 10 years, there was no improvement or no change in the first line treatment. Now let's talk about the second line treatment of patients with metastatic HER2-positive breast cancer. And this was a landmark trial, I think first presented in last year's ESMO, the Destiny Breast 03 study. And this demonstrated that TDXD substantially improves progression-free survival and also overall survival in patients with HER2-positive metastatic breast cancer in the second line when compared to TDM1. So see, here is the PFS. Like with TDXD, it was almost 29 months, while with TDM1 it was 6.8 months. So more than a tripling of the progression-free survival. Similarly, statistically significant, clinically meaningful improvement in overall survival, 42 months versus 52 months. Response rates, almost doubling of the response rates, 35% in TDM1 to almost 80% with TDXD. And doubling of the response rates, complete response rates, 10% in the TDM1 and 21% in the TDXD. With longer follow-up, TDXD continued to demonstrate superior efficacy over TDM1 with a manageable safety profile in the second line setting in patients with disease recurrence. Destiny Breast 2 was a randomized phase 3 open label multicentric study, and the key inclusion criteria of the Destiny Breast 2 were HER2 positive, unresectable or metastatic breast cancer with documented progression after the most recent treatment, and they had to have received TDM1 as the first line treatment. And this was a 2:1 randomization in this study. One arm received TDXD, a single agent 5.4 milligrams per kg. You know that this is the standard dose given every 3 weekly, to this standard of care combination at that time, trastuzumab capecitabine or lapatinib capecitabine. Primary endpoint was progression-free survival. And Destiny Breast 2, you can see the really big difference in PFS when you compare TDXD to standard of care chemotherapy in the second line, and also a significant overall survival advantage. So what are the unmet needs in HER2 positive metastatic breast cancer? There are several unmet needs which can be identified in the therapeutic landscape. The first is that since the past 10-12 years, there has been no change in the first-line treatment. Patients who have recurrent disease post first-line treatment, they exhibit poor outcomes, and something better is needed for these group of patients. Patients who have visceral and brain metastasis, they are a particularly poor subset, and if we could have a molecule which addresses this poor risk group of patients, that would be a major benefit to our patients. Patients who have the PIK3CA mutation, they are a particularly bad subsets, and if you have an agent which could trump this adverse prognostic factor, that would again be a major advance. Patients who are triple positive, they have special needs, and can we do something better for this group of patients? So there was a need for a new treatment, first-line treatment for HER2 positive diseases. Since the advent of the Cleopatra trial since 2012, there was no improvement in this first-line treatment of HER2 positive MBCs. And then we had this Destiny Breast 07 study, which aimed to address these various unmet needs which I've just listed for you. The rationale for combining pertuzumab with TDXD, you know that pertuzumab basically prevents the heterodimerization of HER3 receptor to HER2 receptor, while TDXD, the antibody drug conjugate, is internalized, the linkage is broken, the toxin is released, and in addition to producing death of the cancer cell from inside, the apoptotic cell death, it also has a bystander effect. So you have the benefit of preventing this heterodimerization, direct cell apoptosis, and a bystander effect. And this was the theoretical rationale for combining pertuzumab with TDXD. And this was the study design of the Destiny Breast 09, HER2 positive advanced or metastatic breast cancers. Asymptomatic or inactive brain metastasis patients were included in this study. They had to be chemo naive with regards to their metastatic breast cancer. Stratification was according to these factors. The arm A of the study, 1:1:1 randomization, TDXD plus placebo, TDXD plus pertuzumab, and the standard of care Cleopatra regime, taxane plus trastuzumab, pertuzumab. And the Destiny 09 in this ESMO, 2025 ESMO, reported the comparison results between arm B and arm C, primary endpoints being PFS and overall survival. So here is the PFS for you, and you can see a major difference at the time of evaluation. The median PFS for the Cleopatra standard of care arm was about 27 months, and for the interventional arm, meaning TDXD plus pertuzumab, it was 40 months, a p-value of 0.56, a hazard ratio of 0.56, and a very healthy and significant p-value. And you can see the significant divergence of the curves with a delta of almost 14. This was the independent blinded committee review, and this was the investigator assessed review, both of them showing a significant improvement in PFS. Also an improvement in overall response rates and duration of response. With only 16% maturity of the overall survival results, you can still see, you're starting to see divergence of the survival curves, and we will wait for the final overall survival results of the Destiny 09 study. There was also a significant improvement in the PFS2 in the Destiny 09 study. So, ladies and gentlemen, the standard of care, which is the Cleopatra regime just now, this is likely to change to a combination of TDXD, pertuzumab, and this has started to come into the guidelines, the latest guidelines also. Brain metastasis remains a big issue in patients with metastatic HER2-positive breast cancers. Patients who have brain metastasis, their overall survival is very limited. But with the advent of the antibody drug conjugate, the TDXD, trastuzumab deruxtecan, significant improvement in overall survival in patients with brain metastasis is also being seen, and this is again a major unmet need which this group of drugs, or which this particular drug is fulfilling. Destiny Breast 12 is the largest prospective study evaluating TDXD in patients with HER2-positive MBC. I don't know what's happening. I'm not doing that. Yeah, with brain metastasis, and you take my word for it, there is a significant improvement and a huge unmet need which is being taken care of by this molecule. There are several ongoing studies in the first line, just a snapshot. Lots of new drugs are there on the horizon. They are being studied and they are being compared to the now standard of care TDXD with pertuzumab. We have several agents in the maintenance study setting which are being used, and the HER2 positive MBC field is very exciting. Immunotherapy is beginning to creep in, and lots of other targeted areas, new anti-HER2 agents and targeting the PIK3CA kinase AKT pathway is coming up in a big way. Another important class of drugs are the bispecifics. Bispecifics, you know, you attach one of the moieties of the monoclonal antibody to a target on the cancer cell, and the other attracts the killer T cells, and then you have a cell therapy kind of destruction of the cancer cell. That is also coming up a big way in the breast cancer setting. So this is the summary. About fifth of the patients are HER2 positive. We had limited progress in metastatic HER2 positive breast cancer since the advent of the Cleopatra trial. Now we have a new molecule, the TDXD, or which is making inroads into this setting. It has already moved into the first line agent of choice if you have brain metastasis, and lots of new ways and means are now being discovered with the new molecule, the TDXD. With that, I'll close. If there are, I don't think there are time for questions, but I mean we can talk during the tea time. Thank you very much.
The next scientific session is sponsored by Dr. Reddy's. I would like to invite Dr. Priya Tiwari from Mumbai for the panel discussion on treatment considerations in young women breast cancer. I'm sorry, there's a change. So I would like to invite Dr. Ankur Nandavanshne for his talk on role of dual HER2 blockade in the management of neoadjuvant or metastatic breast cancer.
So good evening, and we are running a lot of updates, but a concept of medicine says whenever we are learning new things, we should revise what we already know. And this session now belongs to a revision of trials, guidelines, which we already knew, and these are in our clinical practice, day-to-day practice, and we all have learned up these trials, mugged up these for our presentations, for our clinical case presentations, as well as for our final examinations. And all the DNB students who are sitting here, they should know at least these set of trials. They should know for their final exam going. So we proceed. We know that breast cancer, this is one of the most common cancer in India, especially the female. This is the leading cancers. Incidence is rising. Approximately 1.9 lakh cases we are getting every year, and 5-year prevalence is approximately 5 years. We knew with the various subsets of studies from a decade which have shown us that incidence of HER2/neu positive breast cancer amongst all breast cancer is approximately 1/3, and 31% accounts for amongst all breast cancer are HER2/neu positive. So there is a target, and there is targeted therapy with a sequential evolution. We have the development of first drug, which was trastuzumab in 1998. Then we have pertuzumab in 2012, the combination. Then we have TDM1, and we have neratinib, tocatinib, and then we have the added drug Enhertu, which is the talk of the town these days. And we have the further newer molecules which will be coming, such as margetuximab and pyrotinib. So what's the difference between the two most common molecules which are being used for the treatment of breast cancers, HER2/neu positive breast cancers? The very first, the pertuzumab and the trastuzumab. So while trastuzumab suppresses only HER2/neu activity, pertuzumab inhibits the formation of HER2 dimer pairs, which trastuzumab does not inhibit this HER2 heterodimerization. Pertuzumab, because of this heterodimerization, leads to a more complete HER2 blockade. And while trastuzumab uses ADCC, pertuzumab also enhances the immune system for the cell destruction. So coming to the early breast cancer first, and what ESMO guidelines told us that in any patient who is T1N0, the very first thing which has to be offered is surgery, followed by we can have, if this is PT1N0, we can have a combination of weekly paclitaxel with trastuzumab, followed by trastuzumab maintenance for 1 year. In case of T2N0, 6 to 8 cycles of chemotherapy along with trastuzumab, followed by trastuzumab maintenance is the preferred choice of treatment. But in any patients who is a lymph node positive, a combination of dual anti-HER2/neu blockade is always preferred. So 6 to 8 cycles of chemotherapy along with dual anti-HER2/neu blockade, followed by 1 year of maintenance with dual anti-HER2/neu is recommended. In the most important era for discussion is the patients with more than T2 or N1. A combination of dual anti-HER2/neu along with chemotherapy is always preferred as a neoadjuvant chemotherapy in these patients. After 6 to 8 cycles of chemotherapy along with dual anti-HER2/neu, surgery is offered, and the patients who received PET-CR, if they were N0 at diagnosis, we can offer them 1 year maintenance of trastuzumab. However, if the lymph nodes was positive, a dual anti-HER2/neu combination is offered for them for next 1 year. In the patients with residual invasive disease, despite dual anti-HER2/neu, of the adjuvant therapy includes TDM1 for the next 14 cycles. So now comes the clinical trials where these guidelines were designed. And the very first study design is the NeoSphere designs, where patients with locally advanced or inflammatory HER2/neu positive breast cancers were randomized to receive either docetaxel with trastuzumab, docetaxel with trastuzumab with pertuzumab, trastuzumab with pertuzumab, or docetaxel with pertuzumab. These were offered later on FEC 4 cycles, followed by surgery, and followed by maintenance regime as per their randomization in the trial. What achievement we got with the combination of dual anti-HER2/neu and chemotherapy, we achieved that PET-CR in this study was 45% as compared to the PET-CR which was achieved with trastuzumab along with chemotherapy. It was limited to only 29%. So we see approximately a 16% jump in PET-CR rates with combination of chemotherapy along with dual anti-HER2/neu. So this was irrespective of the ERPR receptor status, and dual anti-HER2/neu was found effective in both patients where hormone receptor was positive as well as negative. The most common thing which we address in any clinical trial is the safety analysis, and if we analyze the combination from single agent trastuzumab to the dual combination of trastuzumab with pertuzumab, we found the comparable incidence of neutropenia, febrile neutropenia, especially the side effect of interest includes the diarrhea, which was slightly more in the pertuzumab, but then it was well tolerable. So this trial concluded that with a combination of dual anti-HER2/neu along with chemotherapy, it results in a significantly higher PAT-CR rates. It exhibits a significantly higher anti-tumor activity and a favorable therapeutic ratio. The combination has excellent tolerability, and there was no meaningful increase in cardiac risk along with the addition of pertuzumab. This led to the formulation of further trials, and the combination is now as a preferred choice. Coming to another trial, which includes the TRAFENA trial, where the combination of neoadjuvant trastuzumab pertuzumab was studied in, and there were 225 patients. These were randomized to receive either FEC with docetaxel along with pertuzumab trastuzumab, or the docetaxel and pertuzumab trastuzumab along with the carboplatin regime. Post-surgery, trastuzumab was offered for 1 year's maintenance. And we found in all three regimes, with the addition of pertuzumab to trastuzumab, the PAT-CR rates were high, reported in the range of 60%. So 45% in one trial, coming to 60% in another trial. And with the dual anti-HER2/neu blockade, both the studies, either the NEOSPHERE and TRAFENA, reported increase in PAT-CR rates, and the regimes were quite tolerable. So there comes a very good subset of studies, which includes the TRAFENA, Japarsepto, Christine, where increased PAT-CR rates were documented from the range of 45% to 60% to as high as 66% in one study, with the addition of dual anti-HER2/neu to the previous existing single agent trastuzumab and chemotherapy. Now, with the addition of further drugs, the PAT-CR rates are progressively increasing. With the use of chemotherapy, they were only found to be 15 to 20%. With the addition of trastuzumab, PAT-CR rates includes to approximately 40%. In case single agent taxane with dual anti-HER2/neu, the PAT-CR rates were reported to be high as 45%, and with complete chemotherapy and dual anti-HER2/neu blockade, various studies have reported increase in PAT-CR rates to a range of 55 to 65%. Now coming to the adjuvant data comes from the Affinity trial, where patients post-surgery were randomized to receive chemotherapy plus trastuzumab pertuzumab, or in the control arm, chemotherapy plus trastuzumab. So after a follow-up of 10 years, the primary endpoint, we show an invasive disease-free survival in the pertuzumab arm, which was better. The primary endpoint study analysis shows after a median follow-up of 11.3 years, there were 452 deaths in the arm, and we notice a better survival outcomes with the use of dual anti-HER2/neu as compared to the single. This is the overall survival data, and we see at the end of 3 years, the OS benefit was 94% versus 93%, which at the end of 3 years increases to 87% versus 83%. And coming to overall survival at the end of 10 years, it includes the 91% versus 89%. This significant is more in the node positive patient population. If we see the node positive patient population at the 10 years, the OS data difference consists more than 3%. It includes 86% versus 89%. However, in the node negative patient population, this is quite comparable, 94.6 versus 94.9%. So this comes as a part of our guidelines, where any patients were having a node positive disease were offered a dual anti-HER2/neu as compared to the patients in whom nodes were negative at the initial classification. The risk assessment is based on the T size. So coming to the metastatic breast cancer. So metastatic breast cancer data comes from the Cleopatra study, where 800 patients with HER2/neu positive metastatic breast cancers were randomized either to receive trastuzumab with docetaxel or trastuzumab pertuzumab combination with docetaxel. The eligibility criteria includes HER2/neu positive disease with a measurable disease. No more than one hormonal regimens were included prior to randomization. Prior neoadjuvant chemotherapy were usually not allowed if patients were having a baseline meds, or if these patients were having a neoadjuvant treatment or adjuvant treatment, more than 12 months have passed. So final OS analysis shows that at the end of the 50 months, the median OS benefit was reported with the dual anti-HER2/neu combination blockage was 56.5 months, while with the single agent trastuzumab with chemotherapy, it was found to be 40 months. We see a significant 15.7 months overall survival benefit. And if we analyze these with the important age groups, disease subtype like visceral or non-visceral, ERPR status, we found that dual anti-HER2/neu combination is having a PFS advantage in all the subgroups, irrespective of the ERPR status, irrespective of the disease status, irrespective of the age group of the patient, and irrespective of the prior neoadjuvant chemotherapy given or not given. So this combination was found to have a complete response rate of 4% versus 5% in the dual anti-HER2/neu combination. Partial response with the dual anti-HER2/neu was found recorded in 75% of patient population as compared to 65% patient population, and progressive disease was found in pertuzumab, trastuzumab, docetaxel combination in only 3% of patient population compared to the 8% of patient population in that single agent trastuzumab cohort. So we see all the parameters, this combination had led to a significant response better advantage as well as the overall survival advantage. And the most important fact, the toxicity profile we see, neutropenia is quite comparable in both the cohorts, approximately 45%. Febrile neutropenia is slightly more in the pertuzumab arm. And the most important thing, diarrhea, which is a side effect of interest. This is slightly more in the pertuzumab cohort. It was 8% and with the use of pertuzumab, and only 5% in the trastuzumab cohort. So Cleopatra trial concluded that first-line treatment with pertuzumab, trastuzumab, and docetaxel led to significant overall survival advantage in patients with HER2/neu positive metastatic breast cancer. The most important fact, overall survival is increased by 15 months. The survival benefit is consistent across all the subgroups, and PFS benefit is maintained. There are no new safety concerns, neither the diarrhea or not the cardiac. The cardiac safety is maintained in the long-term follow-up. And this is the cardiac tolerability. We see both the results, this is quite comparable, and cardiac dysfunction is seen in less than 2% of patient population. Adverse event, mostly diarrhea. There's a slightly increase in the diarrhea in the pertuzumab cohort. Rest, all the side effects, including the neutropenia, which is predominantly caused because of the chemotherapy, rash, mucositis, are quite comparable. So this led to the formulation of guidelines for the metastatic breast cancer, where any patient with HER2 positive, hormone receptor negative, metastatic first-line treatment includes the combination of taxane with trastuzumab and pertuzumab, followed by this trastuzumab and pertuzumab maintenance till progression. However, in the patients who are having hormone receptor positive, there could be a benefit with the taxane combination of dual anti-HER2/neu, and followed by these patients can be put on the trastuzumab pertuzumab maintenance along with endocrine therapy. Nowadays we have a furthermore addition and advantage where palbociclib can be added with pertuzumab and trastuzumab. Thank you.
The scientific session is sponsored by Lilly. I would like to invite our moderator for the next panel discussion, Dr. Sachin Trivedi from Mumbai. The panel discussion is on identifying and management of high-risk HR positive and HER2 negative, node positive early breast cancer.
Thank you. How do I move the cursor? So good evening, everyone. Thank you, organizers. Thank you, Dr. Vaid, for your kind invitation, and thanks to Lilly as well. May I call upon the stage my eminent colleagues, Dr. Mohit Agrawal from Fortis Healthcare, Dr. Pankaj Goyal, Senior Consultant at RCGI, and my friend Dr. Samir from NCI in Nagpur. So about 2.5 years ago, when I was heading the Department of Oncology at Nottingham, one of the things that a common discussion and debate that we used to have in the MDT was, the tumor is too small, whether we should give any systemic therapy or not, especially the HER2 positive states, and the endocrine therapy, whether to escalate. So that was a discussion, and since I've come back to India, what I've realized that the patient population that we see here is slightly different, because what we have in the West is mostly a majority of the patients would be screen detected, but the patients that I tend to see in Bombay are generally patients who come with symptoms. Now, when they come with symptoms, the obvious expectation is that they might actually have a little more kind of an advanced disease than what you would have in patients who are screen detected. So over the next half an hour or so, we'll discuss about escalation of, so Dr. Mohit is here. So these are my disclaimers. So we'll discuss about escalation of endocrine therapy, but before we move to that, on when to use CDK4/6 inhibitors, I'd like to ask my panelist about what is the definition and what is the proportion that you see in your early breast cancer clinic. Dr. Mohit, do you want a breather or you want to have a go?
So if you talk about the hormone receptor positive cancers, I think a significant proportion of them would be fitting into that EBC criteria. So I would say into the practice, about 50% of them would be into the EBC setting.
Okay.
And if we talk specifically about the higher risk category, which would be monarchy, so that would be around, I say, 15-20%. And if I add Natalie to it as well, another 15-20% probably.
Okay. So Dr. Pankaj, you actually are coming from one of the very prominent centers in India. Now, how has your definition of defining high risk or low risk changed over the years? Because, like us medical oncologists, we always used to believe that it is not just the anatomy. We used to have a squabble with the surgeons that anatomy is not the only thing, it is also about the potency. So sometimes we used to say Ki-67 matters, the grade matters, and the cancer may be small but can be aggressive. But having that understanding and how to define it was the key to the deciding factor. What is your experience been?
So I think we were probably underestimating the chances of recurrence in hormone positive or negative patients, and we used to basically focus on how much ER positivity is there, and basically we were not giving a lot of importance to grade previously. But now I think we are seeing all the reports in total that what is the grade, we are focusing on that also, number of nodes and T size also.
Yeah.
And when we have gone through all this data, and now we believe that even these patients who are having high nodal positivity, or these patients with 1, 2, 3 lymph nodes who are higher grade, these patients are actually behaving as a TNBC in the long run, maybe another few years. So chances of recurrence are higher than what we used to actually thinking that good biology chances of recurrence are less. So I think what we used to thought, things have changed.
Yeah, excellent. And Samir, in the academic circles and the medical oncologist discussion, Ki-67 used to be considered as a very important factor in some cohort of colleagues, and some people used to just say that it is a grade is more important Ki-67. It may not be relevant in our future discussion, but what is the current thought at NCI about the Ki-67?
So we routinely do Ki, but issue with Ki is that there is a lot of interpathologist heterogeneity. So reproducibility is always an issue. Means one pathologist may say it is a high Ki, one may say low Ki. So that's why the reliability on Ki is not that high. Means we don't rely on Ki as such. We just ask them a grade and we try to see the nodal stage and the tumor size, which is more important for us.
Okay. So
sir, just to add on, we have seen patients so many times that patients grade and this key index do not go hand in hand the way they should. So the patient will be having, say, low grade key index will be somewhere around 75. So it will be sounding that if we are dealing with TNBC. So that it doesn't go very well when we see these key index. So I think he's rightly saying there's a lot of heterogeneity, I think, pathologist to pathologist, lab to lab.
Yeah, and I think that might be the reason why so many of the trials in adjuvant setting, especially even in this case, Ki-67 I think was thought to be prognostic but not a decision-making tool. Now,
but with the availability of AI, maybe later on we'll have better understanding of.
I agree.
Better reporting of Ki.
I agree.
There will be uniformity in the reporting.
I agree with you, and I think we are all medical oncologists are sticklers in when it comes to collecting data and having as many results as possible, because we know that we may not be able to use it now, but we may be able to use information in future, especially in ER positive disease, which actually the journey of the patient is literally never ending. So if a patient has a disease at 50, 60 years of age, they are at a risk of relapse after a very long time as well.
That is a different, means in HR positive we may see recurrence after 10 years, 15 years also, which is not a case with TNBC. So that's why the follow-up needed for any trial in hormone positive breast cancer would be at least 10 years, I think.
Okay. Dr. Mohit, so this is a question posed to us. Do all node positive patients that are hormone receptor positive have the same risk of recurrence? And I sorry to interrupt, do we have a surgeon colleague here? I want to ask your opinion about apical lymph node versus non-apical lymph node. What is happening in the surgical world? Is apical lymph node considered as a high risk in surgical world, or because it may be one node?
Over the period of time, our practice of clearing up level 3 nodes has changed, and we don't clear the level 3 nodes now unless it is positive, documented positive. But yes, it does make a difference in the overall survival, disease-free survival, if the nodes are positive, if the apical node is positive.
Okay, so thank you for that. So see that apical node, so anatomically if it is gone too far, even if it is one node, that may be significant. But Dr. Mohit, the question here is, what do you think of this? Do all node positive are same, or is there a difference?
So certainly any node positive cancer in a hormone receptor HER2 negative setting would be a higher risk of recurrence, but there will be some specific, the criterias where these monarchy criteria are met. They are seen that the patients who have 1, 2, 3 lymph nodes actually have a same risk of recurrence as somewhere more than 4 lymph nodes as well.
Yeah.
So I think these risk criterias and the additional criterias added onto them is the one which we are selecting for the patients, grouping them into the category of having a higher chances of recurrence.
You're right. And Dr. Pankaj, you mentioned about the prognosis of high risk patients and comparing that to TNBC. So this is actually a depiction of what is the risk of relapse even if you have stage 2 and 3 with high risk feature versus non-high risk features. So it's quite important, because you see, if you look at the SEER data, if you look at the older meta-analysis, before the anti-HER2 therapy was invented, the HER2 positive patients were the worst performing patient. Then after that, TNBC became like the worst type of breast cancer. But being able to show that even in the ER positive disease, if you have this high risk feature, they behave as badly as TNBC. It's quite significant. What do you think, Samir?
Yes, sir, means we do see ER positive patients having 9 node, even 14, 15 nodes I have seen. So this patient definitely a very high risk of relapse. And we need some special attention to this patient. So only endocrine therapy won't be enough for such patients.
So Dr. Mohit, before CDK4/6 was coming into picture, we were debating about a soft and text trial, especially in the young women, about ovarian suppression. Now let us go back to that era. There are patients who have multiple lymph node positive, and they come to see you in the clinic, say 9 lymph nodes, multiple risk factors, everything that is defined in the monarchy, and CDK4/6 was not available. What were you doing at that time?
So certainly in the adjuvant setting, the patient would be going for a chemo first, radiotherapy, and obviously a long extended protocol for hormone therapy. If premenopausal, maybe ovarian suppression with an AI or an AI. At least I would have given it for 10 years.
Okay. Dr. Pankaj, ovarian suppression for young women, is that the standard offering in your center?
So we are routinely offering that, but we are not giving that for 10 years. So we usually restrict ourselves that we give it for 5 years. And because extended that will have its own consequences. So we usually prefer we give it for 5 years to start with.
And are you doing surgical, offering surgical oophorectomies, or because some patients are actually reluctant to have?
So nowadays we do BRCA and then we decide.
Okay.
So that is a different discussion. But definitely we try to give it for 5 years after explaining pros and cons, and definitely it has its own side effects and issues. But if the patient is willing, we definitely offer for 5 years.
Okay, Samir, let's go.
If you talk about SOFTERN-TEX trial, they had done surgical oophorectomy in only 10% of the patients.
Yeah.
But I think practice remains that who is primarily treating the patient. So usually surgeons feel that they should do a surgical oophorectomy, but I think that's a overkill in most of the patients. Because if say patient is 35 years of age and you know that after 5 years you can stop this suppression and patient can have a good quality of life. So doing a oophorectomy will be, I think, a overkill unless the BRCA is positive.
Yeah. So, but I think at one point in ESMO, I don't remember what it is currently, it was an option, a valid option to offer if their women is perimenopausal and if they have completed their family. But see, we were coming to the point of pre-CDK4/6 because the debate at that point was, you give the ladies 7 to 10 years or 5 years an extended endocrine therapy. ESMO data showed that almost 30% of the patients were non-compliant. They would just come to the oncologist and say, just to make them happy that, yes doctor, we are having it, but 30% of them were non-compliant because of the toxicity and side effect. And at that point also, if you look at all these major trials that has actually opened the door for adjuvant endocrine therapy for 3 years, 5 years and extended period, the delta has been very small. In fact, we had to go back again and again. The article, the data was read on several occasions in subsequent conferences to actually say what is the latest update. Okay, so this is some of the data that actually shows that we currently, before CDK4/6, we were in a standard routine practice. We were practicing 5 years of treatment, but we actually needed meta-analysis of trials to show that adjuvant endocrine therapy can make a huge difference in the lives of patients and reduce risk of. You have a comment, sir?
Yeah. Since this is a young breast cancer conference, so I want to ask, if in young patients, suppose 35-year-old, if we need to continue hormonal treatment for 10 years, so till when ovarian function suppression is to be given?
So I would typically give it for 5 years. To my patient, and subsequent to that I would convert, if the patient is tolerating and I have to give for an extended hormone therapy, I will switch back over to tamoxifen.
Okay. So
can I have a question to the
yes.
panel and the house? Yeah. When we're extending the results of SOFTERN-TEX and we're talking about giving the aromatase inhibitors to a young population also, now on one hand we have BRCA mutated patients and we're not doing oophorectomies taking care of their bone health, and then we have a population, I mean extrapolating it to our population, a population where 90% of our women are depleted in vitamin D, and then we're trying to extrapolate that and give it to our population. I mean, do we have
so there are
that?
So in our clinic what we do, and I'm sure my colleagues do that as well, so a very close monitoring of bone health. In addition to that, what is very commonly missed is the fact that we are also offering patient IV Zometa every 6 months. So IV Zometa every 6 months, vitamin D replacement, calcium is part of the routine thing, and also a baseline DEXA scan followed by, if the DEXA scan is suggesting that the patient is osteopenic or has osteoporosis, the treatment line changes. And if you have a normal DEXA scan, you ought to do a repeat DEXA scan in 2 years' time. So that's the kind of principle.
Actually giving ZA as the OS benefit.
Yeah, Zometa is not just for bone health, it has an OS benefit also. Sir.
Thank you.
May I request you to introduce yourself? I would love to know your name because this is my first meeting in Delhi after a long time.
My name is Luis Costa. I came from Portugal.
Yeah.
I did several trials on adjuvant setting with bisphosphonates with Rob Coleman, and I just want to notice one thing. If you talk about young women that are premenopausal status, if you do bisphosphonates, you may have the detrimental effect on the disease going to extraskeletal sites. unless they are MAF negative. It is a test that is already proven is MAF negative. So either you have the patients under suppression, ovarian suppression, that you can use, bisphosphonates in adjuvant setting, or they are MAF negative.
Okay, excellent. Thank you. I mean, we need to incorporate that. So thank you so much. So now let's come back to our main topic of discussion. We've set the stage now. Let us come back to the use of CDK4/6, abemaciclib. One by one, Dr. Mohit, you can start. What is your take on the latest update on the Monarch E OS data?
So I would believe that the curves have started to separate, though in the numerical terms the delta is pretty low, it's 1.52, but we have to understand the setting as well. Here we are talking about a malignancy which actually behaves very well. We expect extended survivals. So to document a overall survival benefit, you need extended follow-ups, and it's not easy to document them as well. So any improvement and separation of graphs means that there is a benefit of the drug, and maybe in times to come, the delta is going to improve further.
Okay, Dr. Pankaj?
So I think most of our oncological practices are based on PFS, because we hardly get overall survival benefit in chronic diseases like this, where we have a long time survival, we have so many sequence of therapies one after another. So I think this delta of 2 is quite significant when we see a OS, and it gives you a confidence that the PFS what we are seeing is real. So that if even small delta in a long-standing disease should be considered as significant when we see volume of patients.
I think you made a very important point, because see, now currently when these trials were done, we had a few options at our hand. So we had knowledge of how multiple lines of treatment can be sequenced. So even if you had a relapse, the chances of you living now with the disease was slightly higher. So just coming now because of that.
That curves will separate more with further follow-up. I think 10-15 years will show definitely a big difference.
Yeah. So you're right. And now let's see about, and it is very relevant, especially in the young women, isn't it? Because they have a long life to live after the diagnosis. Now this is the curve for the IDFS and DRFS. What do you think is that this is significant? The delta is high, and do you agree with me that it is possibly that the patients may be having a relapse, but they still live with the disease, but there is a significant reduction in the risk of relapse by using abemaciclib?
So I think we have seen previous trials, like we have tried multiple options, like giving combination of hormone therapy, trying sequential hormone therapy, then giving 5 years of one hormone therapy, next 5 seconds. Multiple trials have been done, but none of the trials have shown such a good outcome, even in terms of DFS also, IDFS also. So I think this is the first trial which has shown such a good DFS benefit, and this is going to improve with time, I think. So definitely this is a standard of care.
So I think when we are taking soft and text seriously and following that day and night, this is much more impressive. So
yeah, exactly, and I'm sure the Lilly guys have been naughty and they've deliberately put it there to show that we are following the data from other adjuvant treatment trials and using a much smaller delta and using that as standard of care. So this has to be standard care, and this has become a standard of care. But see, there's one thing: 2 years of abemaciclib. There is a rationale behind it, which is the risk of relapse, especially in high-risk group, is high in the first 2 years. That's why 2 years of abemaciclib has been offered. How many patients in your practice are able to complete that? Is there any hurdle financially or clinical hurdle they cannot complete 2 years?
Lots of hurdles. The first is primarily the toxicity, the GI toxicity, and secondly obviously is the financial toxicity. But putting the finances aside, the GI toxicity is something which is really a matter of concern. But the good thing about the drug is that it has still shown that even with dose reductions, the hazards are maintained.
Yeah.
So it really doesn't make a difference. Another salient point which I want to make on this graph is that you see that the graphs are even separating further on as we keep on continuing the follow-up. So there is some carryover effect as well. So the carryover effect has been very well documented in case of abemaciclib versus the other two molecules. So here, even after 2 years, the drug has had some carryover effect in terms of the response.
So there was a kind of a, you're right on both accounts, and the toxicity side of things, we'll come to that when we discuss the doses. But there was a data, retrospective analysis of data, and what they found was if the patient is able to continue on abemaciclib for a little more than a year, they continue to have that benefit and benefit from the treatment. What is your experience been, Dr. Pankaj?
So I think it needs lot of time when you initiate one patient on abemaciclib, and if you have chosen the right patient, given her all the instructions, do's and don'ts, and you are liberal, flexible in reducing the dosage. So that good, I think 15-20 minutes of discussion, and then you start. Then usually patients stick to it. They are not startled and afraid ki, oh, I'm having so much of diarrhea.
Yeah.
So I think that is important. Then when you start, you give all the instructions clearly. They have to initiate the treatment as and when patient starts having diarrhea, hydration, and all those issues.
So Samir, just let me show this graph. This graph is actually about metastatic disease. The delta is 5.5. So one of the criticism, not a criticism, but one of the skepticism about this was that it actually combined the IDFS and distant disease-free relapse as well. But here, this delta is 5.5, especially in the metastatic setting. So the risk of metastasis is also relatively reduced. What is your thought? Even if the local recurrence is taken out, this is actually the delta for metastatic disease.
So that is what we expect, sir. So means definitely that is a drug which is giving us preventing the recurrences, and it has shown a OS benefit also. So we expect that this drug is going to reduce the disturbances also. So that is I don't think it is surprising for me. It is expected that it will reduce the recurrences.
Excellent. So this graph actually shows that there are almost 30% fewer patients who had abemaciclib. They were living with metastatic disease. What that means is there's a 30% reduction in the risk of metastatic disease. How significant is that in the lives of patient, Dr. Mohit? Because it is actually reducing that number of incurable patients with an incurable disease.
So certainly, if you do not have a metastatic disease, it has an impact on the quality of life, the psychology of the patient. The patient is much more comfortable taking the drug. If any symptom arises and the patient already has a metastatic disease, then patient obviously correlates both of them, and they're always apprehensive. So absence of metastatic disease, in terms of quality of life as well as the patient's safety, is something very prominent.
Dr. Pankaj, do you use this kind of information to talk to patient and counsel them? Because what happens many times, what I have observed is, surgery, I am completely fully on board knowing that surgery is the mainstay of treatment in early breast cancer. It has been, okay? But because of the history, surgeons have a kind of a knack of saying, now I have done the surgery, you are all clear. This adjective of all clear, when it is used, the patient comes to you saying that I have been given all clear by my consultant or surgeon. Why do you want me to have this expensive drug for so long? What is the benefit? Because when they have the disease, they see it is gone. And what we are treating is micrometastatic disease, preventing a risk of relapse. Do you use this kind of data to counsel patients?
Most of our patients will be asking that why so much when the surgeon has given the all clear. So most of the times the patient has already taken chemo when this question arises. So I ask them, then why did you take chemo? so by that logic, because the intent is same, why you are giving chemo and why you want to give this. So we are just playing around with the chances or percentages, that what are the percentage decrease that the patient will have a recurrence. So you have to explain them. Usually to start with, we told that it's a good biology disease and you will have less recurrence. So they say, okay, you initially told it's a good biology disease, and now you're giving chemotherapy, now you're giving this combination. So I always tell them we are making good to very good. So
yeah. And Samir, this question, that Pankaj was mentioning, comparing CDK4/6, managing CDK4/6 versus managing chemotherapy, what do you think you will tell patients in terms of, because I personally feel this is nowhere comparable, but it has some similarities where you have to repeat the blood test, monitor blood count. It has significant toxicities as well, but very small number of patients get that.
So once we tell patients it's an oral drug, they are very happy.
Okay.
So because always they have taken IV chemo, there are IV access issue, because always in breast cancer we cannot use one hand. So always if the patient gets to know IV is over and they need to take only tablet or pills at home, they are very happy with that. Just we need to counsel them, they have to take it for finite duration and they have to just monitor for toxicity and come in between for follow. So they are okay with that when we counsel them properly. And I always tell them this is to further reduce. So I always tell them I am not seeing you for 2, 3, 5, I am seeing you your life as a 10, 15, 10, 20 years. So I want you to be good and healthy and disease free from here for 10, 20 years. So they accept that and they start with the
So the patients are happy that they are going to be initiated on tablets till they know the cost and the toxicity.
Okay.
So once you start discussing, obviously it's difficult to take, okay, you are going to take some costly medicine and again you have to be on watch and things are not that easy. So it comes with bit of difficulty, but then you have to explain things.
Okay, and I personally think that sometimes, because this is an oral treatment, patients also get complacent and also the general practitioners get complacent because these are really significant. It has small number but significant toxicity which has to be monitored very carefully, has to be given under the supervision of a trained medical oncologist who knows how to use it. Now, let us look at the guideline. So we all agree that this is the standard of care, but the reason this slide is here is because it is sponsored by Lilly. Okay, the thing is, how do you choose where we use ribociclib and where we use abemaciclib? What is your current practice?
I think, sir, OS data is only for right now abemaciclib, so that is one advantage that abemaciclib has, and the treatment duration is 2 years as compared to 3, which is one more advantage, and this is the drug which has the longest follow-up, I think. So it is clear-cut winner right now at least. So things may change with maybe next 3-5 years follow-up, but I think right now abemaciclib is definitely winner here.
So I think with the data of Pelbis, we are not very sure whether ribociclib will behave like palbociclib or abemaciclib, whether that carryover effect will be sustained or it will be dropped. Second thing to add is this overall survival benefit. So wherever the patient is eligible for both these drugs, preferred drug is abemaciclib. If the patient is not a candidate for abemaciclib, it's a too early disease, node negative, in those patients you might offer ribociclib. So that is the practice what I follow.
Okay. Dr. Mohit, the patient comes to talk to you. Say, I have heard, I know, I have read it, and they are both the same drug. I want to have ribociclib, or he has one preference. Okay. What do you think, where does abemaciclib score over ribociclib?
So personally speaking, I feel that the NATLI would also follow the same grounds as we have had for this monarchy data, but we have to follow the guidelines as per what the data we have at present.
Yeah.
So at present, if we talk about, we are talking about a hazard ratio of 0.68 versus 0.75 when we talk about abemaciclib versus ribociclib in terms of DFS. In terms of IDFS percentage, it is 7.5 versus 4.5%. Yeah. So, but where we do not have a comparison is because the NATLI did not present it specifically the data for that monarchy criteria, where the monarchy early would have had a similar data where we could have gone for a head-to-head comparison. The another problem I find with monarchy is that they missed a point by not including the high genomic risk score, which the NATLI did. So both have their pros and cons. But if I have to fit, if my patient is fitting into the monarchy criteria as per the standard, data which I have at the present, my bias would be for abemaciclib, but nowhere I don't think that I cannot give ribociclib. I can very well give ribociclib as well.
Yeah, and see, so we've all used both, and I've been part of recruiting for both trials as well. What I think from the patient perspective, so there are two. The way the trial is designed is one is from the investigator perspective, but also from the patient perspective. So one of the simple things that a scientific mind may think is not that significant is how long you need to continue treatment, because we would want to live to have patient live forever, right? But that is not possible. The question that patient asks is, one drug I have to have for 3 years, there is another drug I have to have for 2 years. That is one thing. The other thing is the regime that is designed for abema versus ribo. 3 weeks on and 1 week off versus a continuous regime. I think that makes a huge difference in the quality of life, the communication and the understanding that the patient, has to have. So I personally find that the regime that abemaciclib has is more simplified and a shorter regime. So if you give that option to the patient would invariably and also possibly have a cost impact also, so that it makes it simple. Then again, when the strength of evidence was analyzed, and like you said, it may actually further strengthen in subsequent years, but the strength of evidence suggests that the data for MONARCH is much stronger. So currently, if there are patients who cannot tolerate, who have toxicities, who develop problems with abemaciclib, obviously we'll switch them to ribociclib. But there are certain other criteria where the MONARCH criteria may not be met, and you think that this patient may benefit from CDK4/6. Yes, so there is a place for ribociclib as well. This is been supported by our Indian guidelines as well. So our colleagues have analyzed this and thought of how does it fit into our Indian context, and it does fit into our Indian context in the same way. There is no significant difference. You mentioned about the dose reduction thing, okay? So the dose and the toxicity, this is a very important part when you have to manage the patient for 2 years on this treatment and do a bit of hand holding so that they continue on this treatment. So this is the data suggesting that the dose does not matter much. Samir, what's your take on this?
I generally start with 100 if I feel that patient may not tolerate the full dose. Start with 100, and if the patient doesn't have any toxicity, I try to increase to 150 rather than starting straight away 150. So this is my practice. The patient is fit and young and very compliant. I can sometimes start with 150 also.
I personally think you've read my notes for my students somewhere, Samir. This is what I do. What do you do?
So actually, by protocol, I think we should initiate with 150 mg twice a day.
Yeah.
Maybe keep the patient close follow-up for initial few days, and if patient is not tolerating, then step down rather than going the other way. So that is supposed to be like that.
Right. So see, this data, I am not surprised by this, because see, the way trials are designed is based on the maximum tolerable dose and minimum effective dose with considering the therapeutic index. The therapeutic index for abemaciclib and biological tend to be quite high. So now the thought for trial designers is to how to design trials such that this thing is taken into account. We have seen this time and again, even in use of immunotherapy in Indian setting, data is suggesting that somehow down the line this biologicals actually work like a trigger. So you don't need to saturate the body with the drug, and you may still have that efficacy in patients. Dr. Mohit?
So I think it makes sense, and it seems logical that when you have a toxic drug at hand, start at the lower dose. But I have talked about this at multiple places, and all the experts mention that you actually have to start, the investigators that start with the full dose. And even if you see the curves for EBC, the hazards for the full dose is about 0.89, which is favoring actually the full dose. So my practice is to start with the full dose and then subsequently.
So I think what we would do now is to try and keep the patient on full dose when we can. But if you have to de-escalate, if you have to reduce the dose, it's not the end of the world. It's not a disaster. You should do that, but keep the patient on the drug. So we've got 2 or 3 minutes left. Now we'll just switch the gears and go to the metastatic setting. So a nightmare situation for a medical oncologist is when a patient has a relapse, but the patient relapses in liver. It is my least favorite site for relapse. I don't like my patient to relapse, but if they have to relapse, if they have a bone disease, that's different to liver disease. Patient with liver disease, few metastases, ER positive, what do you do in that setting? Samir.
So sir, like in metastatic setting for CDK4/6, for me palbociclib is, because the OS data is not there, I try to use other 2 options. So we have ribociclib, which has shown OS data. For abemaciclib also there is a trend towards OS benefit. So both of the options are good for me. But for liver mets only, we have seen that data from abemaciclib has shown better outcomes. So in such special cases, very high risk cases, I try to use this drug because if the liver mets progress rapidly, we may not get the second chance.
Yeah, so so we used to debate in our metastatic breast MDT, liver mets start on paclitaxel, think of endocrine therapy later. But as the data kept coming, we became courageous and we challenged them with abemaciclib, and we actually had a good depth of response and a quite rapid response. So this is there, except for a certain situation called, visceral crisis. We'll go to that. But endocrine resistance, okay? So there's a 50-year-old lady, Dr. Mohit, comes to your clinic, progressed after 1.5 years while on AI, and had a recurrence in lung. What would you want to do? Do you want to give chemo, or what would you suggest?
So you have already put it. So I think on the basis of Monarch 2 data, you had a percentage of patients who were in a similar setting, about 1/4 of them, and they had a good response. So I would not shy away from giving an
Agree.
CDK4/6 in this situation.
And Dr. Pankaj, what is the current definition in your center for visceral crisis?
So I think this has become hazy, this visceral crisis issue, because previously visceral crisis you close your eyes and give chemotherapy. But now I think with this data of these CDK cyclin inhibitors in visceral crisis in chemo-naive patients is good, and they have been even compared with combination chemotherapies, and they are doing quite good. So so this definition has become hazy. I think it's not that you see a bilirubin of 3 and you jump and give chemotherapy. So most of the times we do want to start these combination therapies of cyclins and AIs rather than jumping for chemotherapy.
Yeah, so this is the data from Monarch 3 showing a delta of 14.3 for patients with visceral disease. Let me qualify that by saying it is not a patient with visceral crisis. Now, see, we have gone through the data for the early breast cancer setting. We have gone through the data for metastatic setting also. So we all agree that the current standard of care, high risk patient, based on the Monarchy data, abemaciclib remains the standard of care. The dosing will help us manage toxicities better, and even in metastatic setting, given the current data, except for certain patients with visceral crisis, this possibly can be our first line option. So thank you very much for an engaging discussion, and thank you colleagues for patient hearing. Thank you so much.
Thank you, sir. The next scientific session is sponsored by Dr. Reddy's. I would like to invite Dr. Priya Tiwari as moderator for panel discussion on treatment considerations in young women breast cancer.
Hello everybody. So I think may I have all my panelists? Dr. Mehdi? Dr. A.P. Dubey? Dr. Ishu Gupta? Dr. Manish? Dr. Pankaj? Dr. Praveen? And Dr. Rajit. Oh, very intelligent panel. My task is easy. So, Dr. Reddy's have made sure we are going to get the best of the lot, isn't it? So I just want to know, maybe Dr. Mehdi, I can start from you. How common do you see, so here I mean somebody who is younger than 40 years, isn't it? So how common do you see a young female in your practice of breast cancer? Around 10%, that's a big figure actually. Dr. Dubey?
Yeah, around 10 to 15%, that's it. That's
so Dr. Ishu, why do you think we are getting a 10% or maybe, so whenever you see, I think a lot of us will actually see a lot of young breast cancer patients compared to the Western figures, isn't it? So why do you think that in India we are getting young patients, young breast cancer? What could be the possible reasons?
Again, I agree with the percentages, but to point out to a specific cause, rather than probably bad genetics.
Bad genetics?
Maybe मतलब
हमारा genetics खराब है?
नहीं ये नहीं कह रहा,
ऐसा नहीं है.
genetics सबके खराब है, but we are maybe predisposed.
So maybe you think that the BRCA incidence might be higher?
Yes.
So actually there are more than one studies from especially done in the ethnic population from Canada as well as from Malaysia, that after Jewish population maybe the Indians are the one having the highest BRCA percentage. So you're not wrong there. But what else, Dr. Mehdi? I think you want to speak something.
I
yes.
don't know exact cause, but
yes.
In our study in AIMS,
yes.
in my thesis, it was the median survival was 10 years younger than the Western population.
The median age?
Median age of
10
breast
years
cancer.
younger.
That was study on locally advanced breast cancer.
Sir, actually most of the population-based cohort studies, whatever, they have actually said that yes, our is one median younger. The is 10 years younger than. So what actually what was seen in your
maybe less
cases?
pregnancies and late pregnancies
Okay.
could have definitely added to it.
I think one of the common reason is also because India is predominantly a young country. You know, our population, if you see now, more than 65 years is just around 6.5%. And our median age of the country itself is 29 years. So 75% of our population is actually less than 40 years. So when you have a young country, you're more likely to see, you know, diseases in the young. I think that is one of the reasons that is shifting our median age. So this is what it is. Dr. Jain, I think we are all very much focused and on something very right. Are young breast cancer patients treated differently, and why is it so? Do you feel that there is a difference in the disease biology?
So yes, we have seen that these patients, so they have more aggressive disease.
Okay.
In terms of grades also, in
Okay.
terms of more triple negative
Yes.
status, more HER2 positive status. And the disease is also concealed by so many factors that the dense breast is there, so you do not tend to find it on the early, and there are no screening guidelines for the
Agreed.
younger population. So I think these all factors makes that the disease will be presenting in more advanced stage, and as such also they have aggressive disease. The prognosis of these patients, they tend to be more.
And I think also because, you know, youngs have their own set of challenges, the stigma is also there, you know, so I think that also contributes to a, you know, later diagnosis. So this is where we stand. We see that yes, young patients, and also, you know, pregnancy is something that we see in young, and we know that the pregnancy associated cancers also have poorer outcomes compared to the other kinds of breast cancer. So that also contributes to some kind of affects the outcomes in young patients. So the important thing is we have to understand what is the difference also not just in the terms of outcomes, but in the terms of treatment approach. So Dr. Ishu, I want you to again take up this question. What is the difference? How do you approach a patient who has young cancer? So like somebody who is at the age of 30 years, suppose if I were to give you an example. So how are you going to approach that patient as compared to somebody who has 60 years?
So one, we should never skip the suspicion. Like
Okay.
Sometimes it happens that young lady with a lump is unlikely to have cancer. That is a myth, obviously.
Okay.
And we should always suspect that this could be cancer.
Okay.
The other aspect to always keep in mind about the imaging is that they are likely to have more denser breast.
Okay.
So a mammogram or an ultrasound might be missing it, and
Okay.
an MRI might be a modality which might pick up something
Okay.
which was not.
Okay.
And if we have a good suspicion, then just put in a needle. It should be done.
Okay.
Triple assessment, as we were doing it in everybody, in elderly, we should be doing it here also.
Okay.
And the other part is about the genetics. We should be testing everybody.
Yes, I agree. So, you know, a genetic discussion, irrespective of family history, isn't it?
Right.
Dr. Manish, so, you know, the most important part that comes to treating, besides doing a genetic, I think none of us would actually want to miss, even if the family history is negative. How do you tell your patient? So I want to know, fertility, you know, fertility and sexuality becomes very important, especially in the young. So how often do you counsel your patient for fertility, and how many of your patients actually end up doing, you know, oocyte or embryo preservation?
So these are younger patients, and many times the family would not be complete. So we need to have a detailed discussion regarding fertility preservation. But once the diagnosis is done, then the patient many times are in plenty of hurry, so they want immediate treatments. Certainly a oocyte preservation would take some time.
Okay.
So discussion would be very, very important. And seeing at the level of AMH before doing chemotherapy is also very, very important. So documentation that she has a oocyte, and then what will be the subsequent chances that she will have a successful pregnancy is also very, very important.
Okay.
Before initiating the discussion for fertility preservation. But yes, we have many different things like GnRH agonist we can use, but it has some plus or minus data, but it can be used then oocyte preservation.
So before starting chemotherapy, you usually give GnRH and
Yes.
agonist to your patients, isn't it?
We give, but it doesn't have 100% protection.
Agreed,
So,
agreed.
So oocyte preservation or ovarian tissue preservation should be discussed with the patient.
And it actually should be given at least 48 hours before the
Right,
planned chemotherapy. Sometimes we tend to miss on that.
Right.
So, Dr. Rajit, from your experience, how common is that the patients are actually able to undergo the oocyte or embryo preservation?
I think the problem is that the decision is not taken by the patient herself, it is taken by the family, and majority
Okay.
of the times I am not sure how many patients end up doing oocyte preservation. So the idea is that Dr. Saab, you start treatment ASAP, and that we'll see later on. So that happens usually most of the times.
Okay. That actually makes lot of sense. So if I were to give you a figure in our last 100 patients whom we discussed fertility preservation, just 4 of the females actually underwent that. The problem is, especially if you have a TNBC or HER2 positive disease, even you would not want to wait. And for a oocyte preservation, it actually takes around 2 weeks of time. So patients actually don't want to wait till that.
And also regarding sexuality, I
Yes.
don't think that we discuss that much with our patients, considering that we are from opposite sex. And most of the times this question is asked by the husband.
Yes.
During the course of the treatment. So it is something that is lacking, but it's very difficult to break that social stigma at the beginning that you discussed regarding sexuality also.
Yes, Dr. Mehdi,
There is
please.
a practical problem in oocyte preservation. See, in one of my patients last month, I think, what happened, the oocyte is to be collected in a specific day after menstrual cycle.
Yes.
And she was having irregular menstrual cycle. So one cycle was missed. Then when it was supposed to collect the oocyte, that was around more than 40 days gap.
Yes, yes. So this is what I'm saying. At
Yeah,
least it takes
this
2
is
weeks,
also a
2
practical
weeks,
problem.
and sometimes yes. And that's the reason that the oocyte preservation always is a difficult task and less preferred option. So this is what the panelists say, that whenever we are doing a patient, treating her for a breast cancer, we always do a genetic test, and because this is what we know, that the BRCA genetic mutations are quite common. Besides that, you also see check mutations. PALP2 is something that we are seeing increasingly, also ATM and RAD mutations. But what we also seeing that because of various unrelated reasons, for somewhat unknown reasons, young cancer patients are having more cancers. And we don't know, maybe they are shared environmental factors, but young cancers are actually is on the rise. So all of our panelists have actually said that they support this universal, and it's not just BRCA1 or 2, you should always get a hereditary comprehensive panel, more than 200 gene panel, because we know there are a lot of other genes also. In Lynch syndrome also you see breast cancer, so you should not miss on that. So it's not just BRCA1 and 2. So if there are surgeons, we see a lot of surgeons offering these kinds of tests, but they will just write BRCA1 and 2, but please make a note, it is not just BRCA1 and 2 you should offer a whole comprehensive hereditary panel, and also MLPA. So this is the very interesting part, the MLPA part, and maybe Dr. Jain, you can take. So how often have you seen that the BRCA by the common NGS being negative but MLPA being positive?
I think there is 15% approximately, I think 15 to 20%. So they will be negative by the NGS and they will be positive by the MLP.
So literature says somewhere around 2% patients. So like you have an 5 to 10% patients?
Saying, of the total BRCA
Yes.
positive.
Yes, okay, 15. So yes, I think it will come around that. So 5 to 10% patients are positive, 2% because of the MLP. So it comes to 15%.
So I think we have to look at the cost also, because
Yes.
most of the patients cannot afford that, because if I talk about my institutes, 12,000 will be for the BRCA1/2. You add on MLPA, it goes to 28,000.
Okay.
So you have to see the economics also. If patient cannot really afford that much, then you have to be happy with the 90%.
Agreed, but I think you should never miss on MLPA. Isn't it? That's very important. So when do you get a genetic test done? Dr. Pankaj, maybe, yes.
So what I do is, ideally I prefer it to do when I initiate the treatment, before I start chemotherapy. But
Okay.
yeah, but then on second thought, if patient is having some insurance,
Okay.
Then I usually tell them probably we'll get it at a later date when we have completed most of the chemotherapies.
Okay.
Because in case it turns out to be positive, then those insurance issues are
Okay.
there at times that they do not want to pay. That's just genetic or something.
So, Dr. Ajit, tell me this thing. You should have the knowledge of this BRCA testing before the patient is planned for surgery. Is it not?
Correct.
So, has it ever happened that, okay, the patient is an upfront surgical candidate, but maybe this patient is BRCA positive. So, let me give some treatment, wait for the BRCA report, and then plan surgery. See, you have an indications of NACTs, which are separate. But does that also impact your NACT decision somewhere?
So,
see, the reason I'm asking you is this, in somebody who is less than 40 years, the treatment and the guidelines, it's somewhat different than what we treat patient in the usual age group.
So BRCA testing, like diseases like triple negative, we should get it done upfront, but I don't think that our chemo decision will change to that extent because the initial part of the treatment will be either anthracycline based.
No, so that is not the question I'm asking you. I'm asking you, see somebody who is 40-year-old, and if that patient is BRCA positive, you can also offer that patient either bilateral, surgeries, as well as ovarian surgeries,
Correct.
isn't it?
So we need the report before surgery, not for planning chemotherapy.
Exactly. So suppose the report will come in 3 weeks' time. So what are you going to, and that patient is an upfront surgical candidate because the lump is quite small. There
See,
is no
in that
negative.
case, I have no say. वो तो surgeon कर ही चुका होगा.
So
it has
happened that I had a patient
Yes.
of TNBC and patient had a strong family history.
Okay.
So in that case, when I know the patient is most likely to be a BRCA positive,
Okay.
so I discuss these issues that if it turns out to be BRCA positive, you will undergo a second surgery.
Okay.
So if you are okay with that, fine. Otherwise, I give some chemotherapy first and
Yes.
then wait for maybe after 2 cycles or 1 cycle you operate. But then you wait rather than going for 2 surgeries. So patient has to take a call whether the patient is happy.
Yes, that actually makes a lot of sense that you have to counsel them if the patient is undergoing an upfront surgery that may be later on because of the BRCA status or the genetic panel report, maybe the patient will benefit from a second surgery. So I think that discussion becomes very important.
So
Yes, Dr. Gupta, please.
there is a structured study also from
Yes.
the West. If the decisions are taken for the surgery and beforehand we have the BRCA mutation test report, then almost for 50% patient they will opt for bilateral mastectomy rather than from
Agreed.
BCS or MRM. So I think the discussion is very, very important. Secondly, those patients who have BRCA mutations, the PCR rates with platinum are to the tune of 30%. And,
Yes.
and BRCA negative patient, they are 17%.
Okay.
So somewhere it can influence the decision of adding platinum as well. So before and I think we should have the report with us.
Okay. So this is what we were just discussing that yes, younger patients will actually have an inferior prognosis. There's a lot of data to confirm this from the SEER database, 2004 to 2008 studies, 2010 to 2015 studies. The risk of locoregional as well as distant recurrences are higher compared to all other ages, and irrespective of whether it was HR positive disease or TNBC or HER2 positive disease. So this becomes very important. Genomic sequencing of HR positive disease, if done, reveals that yes, these patients have got aggressive biological subtype factors. So compared to patients more than 40 years and compared to less than 40 years. So you see a lot of like FGFR mutations. So these are pathways which tell you that yes, this is going to be a chemo-resistant disease also. Lot of such mutations are seen in young patients which are not seen in older age groups. So yes, lot of poor prognostic factors which are associated with worse prognosis, higher risk of having a PIK3CA mutations also, copy number amplification which gives you a treatment resistance too. HRD deficiencies are seen more commonly in young. There's a lot of discussion about ctDNA and this becomes very important, when a young patient comes to your OPD and, they are saying, okay, is there a way to avoid chemotherapy, isn't it? Because most commonly the fertility part is very important. So with a lot of talk of the ctDNA coming in your practice that you can actually use this to de-escalate treatment. So any of the panelists can take, maybe Dr. Dubey, you can take. Do you actually offer this to your patient? A lot of Indian labs have started doing ctDNA.
No, I actually do not offer ctDNA because though there are studies which have shown that ctDNA negative, then there the chances of recurrence are still there, although there are lower rates of recurrence. But still their chances, incidence of recurrences are there even in ctDNA negative. We don't have any phase 3 data. So I will not offer.
So I think as of now you're not going to offer that. No. Even if the patient comes and asks about that upfront.
No, I will not.
Because of the chat GPT you get all kinds of questions now. Okay, I think none of us will actually try to do that. Now the question is, how are you going to treat these patients? So I think all of us would definitely want to start them on, the first thing is GnRH agonist, and then you take your chemotherapy decisions, especially if you have planned the patient for an NACT setting. So how is your NACT setting going to be different? Dr. Mehdi, based on the age, chemotherapy decisions based on the age.
Based on the age, there is no significant difference in the chemotherapy protocol, but try to incorporate anthracycline in the chemotherapy protocol.
Okay, but if it is HR2 positive disease then? HER2 positive disease then?
Then this is the standard.
You would not want to do
TCHP.
that? Okay, so my question is, so you have a TNBC, ER disease, and you have HER2 positive disease. Okay, and you have decided this patient will benefit from NACT given the latest guidelines. So based on young age, in which particular group of patient you see that the chemotherapy regimen might be different? So in HER2 positive, I don't think so it is going to be different.
Yeah.
All of you would want to do a HER2 blockade, and now you have data that you can just do a single taxane, need not add carboplatinum. Isn't it? You have that amount, and I don't think so it has to do anything with the age now in HER2 positive disease. But what about ER positive disease and TNBC?
For TNBC, the standard anthracycline, cyclophosphamide plus immunotherapy followed by taxane, carboplatin and
so even in TNBC setting, it's not going to be different for you. But you would definitely want to use a dose-dense regimen in young patients, isn't it?
That is that.
So I think the most important thing is we are not going to change the chemotherapy drugs, but the dose-dense treatment. Yes, Dr. Goyal,
So
please.
I think we will be more confident using PD-L1 inhibitors in younger patients where we know the patient will tolerate the drug better. So rather than just going
But
for
PD-L1 inhibitors, the tolerance does not depend on the age.
does not depend on age, but the tolerance will be good. So maybe in a 60-65-year-old, I'll not be that pushy for a PD-L1 inhibitor. In a younger patient where I know the patient will tolerate it better, so they will be more confident using it.
Dr. Rachit, do you agree with that statement?
I would, this statement, I would rather say dose-dense protocol. I would prefer if the patient cannot take Pembro in the neoadjuvant setting. Otherwise, I don't think that Pembro will make a difference regardless of the age. Dose-dense protocol, yes, if the patient is not.
So you would not want to omit immunotherapy based on age? I don't think so anybody would want to do that, isn't it? It's just that the matter of dose-dense regimen we would all want to use because we know that yes, wherever the patient can tolerate, dose-dense regimen is actually better. And why not in younger patient, isn't it? Where the benefit and the tolerance is actually not an issue. Yes, Dr. Ishu, please.
The only difference which I can think of that age would make to chemotherapy regimen apart from the dose-dense thing is if a patient was operated upfront as TNBC.
Yes.
And say BRCA is negative, even then I might be tempted to add platinum in the adjuvant with the taxane.
So now you have data from mostly Asian countries, especially from Korea, that even adjuvant platinum helps the patient.
Yes.
So suppose if you have not given NACT to the patient, the platinums you have not been able to give, you can still give the patients in the adjuvant setting. The data is now there.
So that's where the premenopausal data is much more stronger versus the postmenopausal data.
Agreed.
And that's where I would be definitely looking to add.
Okay. I think the biggest controversy and the difference comes when you are deciding the hormonal treatment, isn't it? So when the patient, so you have done, so the other important thing is risk stratification, okay, about your oncotype DX score, okay. So Dr. Mehdi, if I were to ask you this question, in which group of patients, okay, in premenopausal females less than 40 years, would you want to do, in which group of patients would you want to do a oncotype DX?
Oncotype DX, I personally, I do not have lot of confidence on on the basis of oncotype DX to take decision in younger patients.
Okay, I agree. Yes, so you have a valid point there. It depends upon the how much was the patient's percentage representation, the younger population, and you also have CAN assist. You also have Mama Print, Prosigna, a lot of other tests. Any other experience with any other?
I have done CAN assist also.
Okay.
And, other one.
Prosigna.
Yeah, but the more experience is with oncotype DX only.
Most experience with the oncotype DX. What about other panelists? Dr. Dubey, yes. So suppose if the patient comes to you and she says, okay, it is just a T2 lesion, N0, she's premenopausal. The key is around 15%. Ki-67 is around 15%, ERPR is strong positive.
Okay.
Okay, so what would you do for this patient? Would you give her chemotherapy or what would you do?
So initially for patients who are younger than 50 years of age,
Okay.
I'll omit Oncotype DX.
Okay.
But yes, if patient insists.
So you will omit Oncotype DX and give chemotherapy?
Yeah, younger age.
Okay.
Anyhow, I have to give. And secondly, if patient insists on Oncotype DX, then mid-range, that is 16 to 25, I'll give chemotherapy.
Okay.
And thirdly, if patient insists that she doesn't want chemotherapy and patient is young,
Okay.
then only those low clinical risk subset, those patients who are less than 3 centimeter and low grade,
Okay.
they are the patients where you can omit chemotherapy.
So have you ever done that in your practice?
No, I have not. I am
Okay.
saying, you're saying that if patient is
So
sick,
if any young
in
patient,
I'll give chemotherapy.
Okay, all the panelists, same opinion? So this was just the data set, the Taylor X analysis, the premenopausal females. Now if they have you have an RS score of 16 to 25, still they will benefit from chemoendocrine adjuvant treatment. So yes, the data is there, but less than 16, maybe you can omit, especially though the data set is small, but that data set is still there, but not in 16 to 25, okay? So even in that group, the score shows, say that yes, the data says that yes, the chemotherapy is beneficial. Now, but yes, the representation remains very, very small, 4, 5%, 6%, 7%. The problem is most of these studies were not done in India, where, you know, we are a larger representation, especially like 10 years. Now we come to the hormonal treatment, and this is the biggest, the biggest part of the problem. So I'll just give you an example, Dr. Goyal, I want you to take this question. So somebody who's 41-year-old, you know, she says that she has normal periods. She has completed chemotherapy, underwent surgery. How are you going to plan her adjuvant treatment? NSCT done, NSCT done, surgery done, radiation plus minus.
So if a patient has taken chemotherapy, I consider that she is high risk enough to follow this softened text, and we should give this ovarian suppression.
You should give ovarian suppression. Okay, so won't you ask, is she still menopausal or postmenopausal or premenopausal after chemotherapy?
So in less than 45 years of age, even if it is chemotherapy induced amenorrhea, I do not consider it as menopausal.
Okay.
Ultimately, the patient will have that vapas estrogen will recover. So I give that suppression to these patients, not considering that they are permanently menopausal. That confusion arises when the patient is between 45 to 50.
Okay, so suppose your patient is 41-year-old, and you will give her what you want to give her, some kind of GnRH agonist?
Any suppression, yeah.
Any suppression, or you'll prefer surgery?
No, I do not prefer surgery.
Ovarian
I prefer
removals.
not to do surgery.
Why?
So if I am giving, say, 5 years of ovarian suppression, after that the patient can have her good quality of life, because ovarian suppression is required for 5 years, that is more than enough. If you do that surgical thing, then the patient goes for a toss for menopausal forever. So I consider that even if the patient will become maybe premenopausal for 4 or 5 years in the end, that is worth it.
Dr. Rajit, your thoughts on this? So this is the area of a big controversy here. How are you going to offer the patient best, you know, hormonal treatment in this age group?
So I think my thought process is similar with Dr. Pankaj. So it basically depends on the disease status and the.
So I would ask you a more direct question. In softened text trial, if you go through the softened text trial, they took patients who were still premenopausal after chemotherapy was done. So how do they define premenopausal? So I want to know that first.
In the softened text?
Yes.
So in this study, I think
so they said that the patients who are still having menses, that is very clear. But somebody who does not have menses, what we should do about that? We should measure the estradiol and the FSH level. Okay, estradiol should.
Correct. So the problem is that we don't know that immediately doing the levels of E2 after chemotherapy would actually give us the correct value.
Okay.
So as Dr. Pankaj said, that the patient can resume the normal estrogen level after some time. So there is no data to support that if a young patient has stopped periods, so we'll consider that patient as in menopausal range. So I would, in the 40 to 45, I would also follow the same practice as what Dr. Pankaj said.
Dr. Dev Dubey, you want to say something? Yes, please.
I think menopause is defined by either age more than 50 years or post chemotherapy 12 months the levels should be in post-menopausal range. That should be
Yes, I agree. But you know, we are talking about what we are when we are sitting in the over OPD. So somebody who is 41-year-old, okay. So and that is where the the soft and textile actually comes into role, where you want to give OFS and where you should not give OFS. So in that particular trial, the patients who were still having active menstrual cycle, they were taken. The other group of patient was after chemotherapy, you do estradiol level and FSH level. They should not be in the postmenopausal range. Okay. But suppose, so if the patients have so my question is, are you routinely doing these levels? Dr. Mehdi?
I do the levels, but...
do you offer surgery to them? Just oophorectomy. In which patients you will offer oophorectomy?
Oh, this
That
is
is the
very
first
important
question.
question.
Yes.
Actually. In one hand, we are discussing the fertility preservation.
Okay.
In other hand, we are discussing the
Yes.
ovarian function suppression.
Okay.
So, if the patient is not completed the family,
Okay.
if wants to have children in future, then only medical ovarian suppression.
Okay.
And if it is completed and more than 40 years old, then I think we can go ahead with the surgical suppression. But at the same time, if BRCA positive, then we may go for
excellent.
ovarian
So if somebody is 36
removal.
year old and she is stopped having periods, okay, after chemotherapy, how are you going to do? Proceed? Are you going to give her this GnRH agonist? She has already stopped having periods.
For how long? It
36.
Is it more than 2 years?
No. So this is where I am coming to you. So
Yeah,
she has
if
done
it
her
is
surgery.
amenorrhea more than 2
5
years,
years of ovarian
and the hormonal
suppression.
levels are same.
5 years of ovarian suppression
what I'm
is
trying to
adequate.
So most of the patients will be having amenorrhea after chemotherapy.
Yes. Agreed.
So this is a transient amenorrhea. That's what
And
I'm
this is
telling.
not
And
the
even if you
post-
go by the test, the E2 and LH, you will never find those LH in the menopausal range. E2 will be suppressed, but LH will always be confusing. You check it on
No, so
two
you do
instances.
FSH and estradiol levels. FSH and estradiol.
So
okay.
I have stopped recently because what I have seen is ultimately I end up giving the suppression. So so I start with tamoxifen, I give suppression, then I check it after 3 months. So at baseline, again 3 months. If E2 is in the menopausal range, maybe after 3 months or 6 months, then I change to AI. Otherwise, that's what I do.
Valid point. Dr. Praveen, yes, please.
I'm asking, are we supposed to monitor the levels? So because the recent trials of adjuvant hormone therapy, so they do not recommend it to be monitored routinely.
Okay.
So I have Cambria trial, which is an adjuvant oral SERD versus AI, and they do not recommend. So most of our patients, even after giving the GnRH analogs in the premenopausal patients, so they are coming in the like premenopausal range only. So,
So somebody who is less than 40 years, if she stopped having menses after chemotherapy, you are going to give her GnRH agonist along with some kind of hormonal therapy.
Yes.
Isn't it? All of us agree on that?
Yes.
And along with 5 years.
Yes.
So sir, in my practice, I usually do hormonal estimations regularly for a simple reason that up to 30% of the patient, sir, these GnRH agonists, they require cold chain maintenance. And sometimes the cold chain is not maintained. So it actually tells me how efficacious the treatment that she is receiving. So I tend to do it in my practice.
No, then which is the hormone you are looking at?
I'm looking
AMH,
at estradiol
FSH
and
or
FSH.
E2?
Estradiol and FSH. Estradiol and FSH. That is what I do. So I think we can end it up here. 20 minutes gone. So there is not much after this. Tamoxifen, panel discussions. Adjuvant CDK inhibitors. All of us would agree there was a wonderful panel discussion before this. And yes, premenopausal females less than 40 years, we'll all want to add. Based on BRCA, olaparib addition has also become very important. So that's all. And HER2 treatment is actually not dependent on the age. So that's all. Thank you.
Thank you for a wonderful discussion. For the next session, I would like to invite Dr. Jagmohan Singh from Jammu and Dr. Manisha Singh from Patna as the chairperson.
So a very good evening to all of you. To begin with, the first topic that we are dealing is with a real-world treatment pattern and clinical outcome with tucatinib-based therapy in patients with HER2-positive metastatic breast cancer. And to do the honor, I would invite Dr. Aditya Sareen to start the session, please.
So thank you, chairpersons, and thank you, organizers, for having me here. And HER2-neu positive breast cancer, I think it can give you sleepless night, and it can give you a very, night with a baby-like kind of a sleep. Reason for that is it's such a heterogeneous disease, and there is no one set of rule that is going to be followed. You can have a patient who is going to have a refractory HER2-neu disease, or you can have a patient who is a responder, maybe 4, 5, 6 years, going well on the first line setting itself. So I have one patient who has achieved, CR. It's been 4.5 years, and she is still coming and taking injection, trastuzumab and pertuzumab. So HER2 positive disease, I think if it is in the favor, it can definitely change the outlook of a single patient. But then again, you do have the other spectra of this disease where you are bound to have those brain mets, and let's dive into the discussion. So breast cancer, it obviously, it remains the most prevalent among women globally, and obviously in India as well. The latest data set is somewhere around 2 lakh Indian patients. So again, this was Globocon 22, which was, now 4 years back. We will soon be entering into 2026. And the number is steadily rising. If they have written 2 lakh, I think the number should be around 4 lakhs or something like that. And in India, breast cancer accounts for 28% of the female cancer, again topping it up. And HER2-neu prevalence is as to our standard of care, which is to the tunes of 18 to 20%. And it's rising both in the urban and the younger cohorts. So the problem with HER2-neu MBC, it's the therapy resistance. The disease progression post trastuzumab, pertuzumab and TDM1 is frequent, and especially in the later lines. And resistance is driven by the HER2 receptor positive PI3K, the parallel pathways AKT, mTOR pathway, and the intratumoral heterogeneity, leading to ultimately diminished response durability. And this is what we have been experiencing day in and day out to all of our patients who are progressing beyond the first line. Again, the CNS met burden, up to 50% are bound to land up with brain mets, and often early in HER2 positive phenotypes and hormone negative. And once they are there, you have to explain the family in terms of poor prognosis, and you have to alert them regarding the neurocognitive decline. And another problem which was there few years back, the lack of penetration of blood-brain barrier. And obviously the trials, mostly trials, just exclude these subgroup, and you technically never know. So limited agent, most HER2 targeted therapy exhibit minimal CNS bioavailability, and here comes tucatinib, which is HER2 selective oral TKI and demonstrated significant CNS PFS and OS benefit in HER2 climb with the favorable tolerability and outpatient suitability. So if I were to go into the molecular subtyping of the tumor, and if I were to choose my treatment plan as per the subtypes, in hormone positive breast cancer and HER2-neu, you have plethora of molecules with plethora of targeted therapies and molecular alterations. Let's focus on to the monoclonal antibody component, where you have these trastuzumab, pertuzumab, patritumumab, again responsible in the HER2 positive advanced breast cancer. So approved agents in HER2 positive MBC, you have margetuximab, you have TKIs like lapatinib, neratinib and tucatinib, you have pertuzumab, and obviously very recently the cost of the drug is not a major issue now, where our acceptance rate to this molecule in the upfront setting was somewhere around 15%. Now I can comfortably say that 90% and above patients are able to afford this molecule. And now you are entering into the era of ADC, which is antibody drug conjugate, Catherine trial, where TDM1 or this drug Kadcyla was the kickstarter, and Cleopatra, Catherine, so they were in sync with the TDM1 molecule efficacy. And then the Destiny breast trials. Destiny breast trials completely changed the outlook how we deal with the HER2 positive breast cancer. Again, TDXD, the only issue in Indian scenario is the cost, and if cost is not an issue, I think 99% of us are going to land upon the data set of the DB03, where you had a phenomenal PFS benefit. So as HER2 targeted options continue to expand, physicians will weigh many factors while sequencing for the first line, and 80% of the patients will receive a second line, and then 65% will receive a third line. And the sequencing depends upon the previously administered therapy, your progression-free intervals, the site of progression, tumor burden, patient preference, and quality of life. So where does this precision comes? So it's tucatinib, which is acting as a small molecule, highly selective for the HER2, and it binds selectively to the intracellular domain of the HER2, ultimately leading to the MAPK and the PI3K pathway inhibition, and it inhibits the HER2 activated signaling pathway, which ultimately tantamounts to increase in the tumor cell cytotoxicity and inhibits the cell proliferation, survival, and metastasis. So HER2 CLIMB, well, this was a randomized, double-blind, placebo-controlled phase 2 trial where HER2 positive metastatic breast cancer, prior exposure to either TDM1 or trastuzumab, pertuzumab was there, and brain mets were allowed. So see, if we were to go into the depths, how many patients of this versus if I were to compare with the DB03, I think this had a pretty well notion that you can have active brain mets and you can still get incorporated into this trial. And this was further randomized with tucatinib 300 mg BD along with trastuzumab and capecitabine versus placebo, trastuzumab and capecitabine. With the median, so just a second. So with the primary endpoint of PFS and secondary endpoint being the OS and PFS in patients with brain mets. So the primary analysis, it met all its primary endpoints and alpha control secondary endpoints. If we were to see the PFS, the benefit was 46% risk of reduction or death by 46% if we were to use the experimental arm. And again, with the hazards of hazard ratio of 0.66, with tantamounts to 34% risk of death and was reduced by this combination. And PFS by the blinded committee in patients with brain met, it was reduced by 52%. It's a massive number, 52% reduction with the hazards of 0.48. It's definitely one of the most phenomenal ones. And if we were to go into the depths of it, you can see the graph. Even though your PFS number in terms of month, you can see it is hardly 2 months or 3 months. But then again, look at the hazards. The graphs are separating well on after 3 months and they keep on separating till 30 months. And the same if we were to see in the hormone receptor negative subgroup, it started way back within 1 or 2 months and you are having a hazard of 0.54 and with the PFS month benefit of 4 months. So PFS benefit was observed in patients with tucatinib arm of the primary endpoint population regardless of the hormone receptor status. So whether you are having a hormone receptor positive or a hormone receptor negative, this combination is going to do its work. What about OS? Then again, if we were to see the OS in the hormone receptor group had a improvement of approximately 4 months. In the hormone receptor negative, you can see from 14 to 31 months. So this drug works and you have your subgroup identification where this drug is going to do phenomenally better as compared to little bit less better. What about the safety? Obviously, if you are using capecitabine and trastuzumab, so obviously one needs to be on high alert regarding the trastuzumab related toxicity and then on capecitabine related toxicity. But what it adds to the toxicity is the diarrhea. On one side you are handling diarrhea because of the capecitabine and the other end you will be handling the diarrhea associated with the drug. For that you just need to be very calm. You have to stop the drug, you have to re-escalate the drug in a very standard step ladder fashion uptake, and rather than starting the full dose upfront, I generally recommend to start at least a level 1 dose below and then take the things forward to the full dose. And you can have a patient with nausea, fatigue, vomiting, stomatitis. So these are run-of-the-mill side effects, nothing major other than this management of diarrhea, which you can see there is a frequency benefit of approximately 81%. So if we were to see all the TKIs in one slide, you have lapatinib, neratinib, pyrotinib and tucatinib, and we have been using lapatinib for quite some time now, and the molecule right now in question is tucatinib, so let us just focus here. You have your patients with having significant PFS benefit, OS benefit and a BICR independent committee review benefit of this molecule, especially in the hormone receptor negative subgroup. So again, in the side effect profile, all are well balanced. I think the frequency is still the same. So when a patient comes to us, or one of our patient lands up in trouble where you are failing with the first line, best line of defense, then obviously you switch to the second line of defense. And the problem with Enhertu right now is the cost, and you know that most of our Indian patients might have trouble even buying this drug. So rather than having a dose modified or a low dose antibody drug conjugate, I think one should consider this molecule tucatinib with trastuzumab and capecitabine. The cost of this is still way less than the Enhertu. So what about the real world treatment pattern and the clinical outcome with tucatinib in patients with HER2 positive MBC? So in this, from 2017 to 2022, lot of patients were incorporated, somewhere around 143 from one market scan, and then Komodo's databases incorporated 436. Again, the primary endpoint was real world time to discontinuation, and secondary was treatment persistence at 6, 12 and 18, 24 months. And these were the selection criteria. And you can see from the market scan that 73% had brain mets, and Komodo had 70% of brain mets, and tucatinib was most frequently initiated in the second or the third line settings with the high prevalence of brain mets, more than 70% across databases. So if our patients are not been able to afford the antibody drug conjugate like Enhertu in the second line, I think HER2 climb is definitely a way forward. With the treatment to discontinuation is 4.7 months and 9 months approximately. Again, the side effect profile, the resistance, persistence still remains the same. So this was the another Mountaineer trial where tucatinib plus trastuzumab in HER2 positive breast, in HER2 positive metastatic colorectal cancer was used, and this was a phase 2 HER2 positive RAS wild type CRC where again this combination was used more than 2 prior standard lines. And you can see the DCR is to the tunes of 71% and DOR to the tunes of 12 months. So just to consolidate all the findings and the discussion here, HER2 positive MBC tantamounts to 20% of the global cases. Indian prevalence again is 20% with rising incidence in the younger women, and CNS mets affect up to 50% of HER2 MBC. So as a routine, either if you are having a patient in the early stage or in the later stages metastatic, please get MRI brain with contrast at baselines as well, because then you will not be questioned whether this disease was earlier in the brain or not. So for HER2 positive or MBC or triple negative breast cancer patient, do get MRI brain with contrast at baseline. And tucatinib, this selective oral TKI did demonstrate a real world time to treatment discontinuation of 7.4 months and 9 months, consistent with the HER2 climb trial. And persistence at 12 months remained clinically meaningful in both the subgroup. Post TDXD showed reduced TTD because of the obvious reasons, because then you are giving this drug to that bad biology disease like refractory disease biology, and obviously there are going to be some sequencing challenges. And majority of patients did receive tucatinib, trastuzumab and capecitabine guidelines with the FDA. And with this, I thank you.
So very well presented. I have a very small question. So in Indian scenario, how many patients can tolerate the exact dose that has been prescribed by the HER-CLIMB trial? And what is the percentage of the patient where we have to cut down the doses or we have to de-escalate the dose, and with what result?
So,
do we have Indian data?
So with the problem with TKIs is, and the problem with the trials that I have just quoted, that very few subset of Indian patient or Asian population was there. So for me as a practicing physician, I start with a step down lower dose. So I generally don't find any of the major issues with these TKI. Other than that, if you are already starting with a less dose.
So what you start with 300 OD?
Yeah. And max to max, I can give 300 one day and 300 BD on alternate day dosing schedule, and 90% of my patients are doing well as per this schedule. At the end of the day, these TKIs will definitely land patient into trouble, and diarrhea is huge. So when I was not having any experience of using it, I was just writing, the full doses of tucatinib. But then again, horrible. It's very horrible. Both lapatinib and tucatinib. Might as well start with a low dose.
Nice presentation. Thank you. Any question from the audience? Thank you.
Thank you, sir.
So our next talk, I think, is quite interesting. The topic is lessons from global models, breast testing using radio frequency signals. I would like to invite Dr. Gianluigi Tibri from Italia. It may be joined online, yes. Sorry, I would like to invite Dr. Kunjari Mehdi from New Delhi, and the topic is transform the journey of your HER2 positive early breast cancer patients.
Good evening all. So next 20 minutes or so I will be discussing about the pertuzumab and trastuzumab combination, which is in subcutaneous form. There is no difference in response, no difference in protocol, only difference is the convenient use of subcutaneous route, which is less time consuming, which is very convenient. The slides are provided by Roche. Perjeta, that is pertuzumab, and Herceptin is trastuzumab. The pertuzumab trastuzumab has transformed the treatment landscape and is the standard of care for patients with HER2 positive breast cancer. These are three pivotal studies of pertuzumab trastuzumab combination in neoadjuvant setting. It is the NeoSphere trial. In adjuvant setting, it is in early breast cancer, it is Affinity trial. And in metastatic setting, it is the Cleopatra trial. From these three trials, it is established that in early breast cancer, high risk, HER2 positive disease, addition of pertuzumab and trastuzumab significantly improved the PCR rate from 31% to 49% in neoadjuvant setting compared to Herceptin and chemotherapy alone. And in adjuvant setting, Affinity trial revealed that it increases the disease-free survival and overall survival and reduce the recurrence. And in Cleopatra trial, it is already established that addition of pertuzumab and trastuzumab with chemotherapy increases the survival. And Perjeta Herceptin plus chemotherapy is approved and recognized by international guidelines as the standard of care for patients with HER2 positive breast cancer. HER2 positive early breast cancer, pertuzumab plus trastuzumab plus chemotherapy is the neoadjuvant standard of care, and in adjuvant setting it is also standard of care in patients without residual disease after surgery. So this slide is showing that in neoadjuvant setting, when there is tumor size is more than 2 cm or node positive, then chemotherapy 4 to 6 cycle plus pertuzumab and trastuzumab. Commonly we use the TCHP combination, and then surgery is done. If it is clinically T1C and 0, then surgery upfront can be done. But after surgery, if it is node positive disease, then adjuvant pertuzumab trastuzumab, and if it is N0 disease in early breast cancer, if surgery is done upfront, then trastuzumab plus chemotherapy is the choice. After trastuzumab and pertuzumab plus chemotherapy, neoadjuvant therapy, after surgery, if PCR is obtained, YPT0 or TIS plus and N0, then pertuzumab trastuzumab based regimen is the choice in adjuvant setting. But in case of residual disease, then TDM1 is indicated. IV infusion Perjeta Herceptin is well established but can present challenges in patients and healthcare system. We all know these are relatively longer IV infusion, and that takes lot of time, and we need this intravenous, sometimes central venous catheter also. There are the problems of central venous, maintenance of central venous line is also there. Phesgo is the first formulation in oncology to combine two monoclonal antibodies, pertuzumab, trastuzumab, in one vial for subcutaneous injection. It contains same antibodies as approved for IV pertuzumab and trastuzumab, but has a different route of administration, that is subcutaneous. Phesgo is formulated with recombinant human hyaluronidase to allow subcutaneous administration of higher drug volume, that is 15 ml in loading dose and 10 ml maintenance dose. Phesgo is a ready-to-use fixed-dose formulation administered by subcutaneous injection in the thigh over approximately 5 to 8 minutes. What is the mechanism of action of pertuzumab and trastuzumab fixed-dose combination for subcutaneous use? We all know about the mechanism of action of pertuzumab, trastuzumab. That is not different. Only difference is the addition of recombinant hyaluronidase. This is the Federica trial, which is a phase 3 non-inferiority study assessing the PK efficacy and safety of pertuzumab trastuzumab subcutaneous versus pertuzumab trastuzumab IV. This is, in this trial, investigators choice treatment chemotherapy, DDAC followed by pertuzumab and trastuzumab intravenous along with the paclitaxel weekly 12 doses. And in other arm, after the chemotherapy, initial chemotherapy, dose-based chemotherapy or 3 weekly chemotherapy, subcutaneous pertuzumab trastuzumab combination was used and surgery was done after the stipulated doses of chemotherapy. And subsequently, the arm where IV pertuzumab trastuzumab was used, the maintenance was same, and in subcutaneous group the maintenance was same, and then there was follow-up. Primary endpoint was non-inferiority of cycle 7, that is pre-dose cycle 8, and secondary endpoints was non-inferiority of the cycle 7 in the serum level, trough level, and IDFS, EFS and DRF1. This trial also that revealed that primary endpoint plasma serum also maintained in the both groups same, and secondary endpoint also reached in the both are same. And safety profile also well balanced, equal, and incidence of adverse events were consistent with other studies that included pertuzumab trastuzumab IV plus chemotherapy. So this study showed that subcutaneous was non-inferior to trastuzumab pertuzumab IV based on cycle 7 pertuzumab trastuzumab serum concentration level, and PCR rate was also identical, and the safety profile was also comparable. Another study, that is the Francesca trial. This is a phase 2 study assessing the patient preference for IV and subcutaneous pertuzumab trastuzumab. Then, to summarize, 88% of healthcare professionals thought that subcutaneous pertuzumab trastuzumab was the quickest from the start of preparation to completion of treatment, and from when it was studied from all aspects, from healthcare professional, from patient point. So most of the patients preferred the trastuzumab pertuzumab subcutaneous form. So in this study, 85% of patients preferred subcutaneous pertuzumab trastuzumab and 14% preferred only IV. So this was the subcutaneous preference was more. The main reason for subcutaneous preference is the less time in clinic, more comfortable during administration. Patient satisfaction points were more patients were very satisfied or satisfied with subcutaneous trastuzumab pertuzumab combination, and most patients indicated that treatment had no impact on the amount of time they had to talk to their relative and finally the treatment they had more than enough time to talk to their nurse or doctor. And healthcare professional perception on time or resource impact, HCP indicated that subcutaneous pertuzumab trastuzumab had marked time savings and required fewer resources compared to IV one, and safety was almost equal. This is another study where time, cost and resources savings were studied, and finally it was concluded that the summary of this is the PATIMA trial where the cost and time analysis was done. Phesgo treatment resulted in significant time savings for patients and healthcare professional compared to IV, pertuzumab, trastuzumab, and in comparison to subcutaneous form. Use of several medical consumables and was reduced with Phesgo compared with other treatment in the study. Drug waste seen with reconstitution of trastuzumab IV vials was avoided with Phesgo and pertuzumab IV and subcutaneous. So preliminary safety data indicated that study treatments were well tolerated and consistent with the known safety profiles for each drug. For dual HER2 blockade, the advantages gained from subcutaneous versus IV for administration are in condition to dose from a fixed dose combination versus separate administration of each drug. Taken together with the efficacy, safety and patient preference data for Phesgo subcutaneous form versus IV pertuzumab trastuzumab, results from PATIMA further support the use of Phesgo versus IV form of pertuzumab and trastuzumab for the treatment of HER2 positive breast cancer. This is the recent white paper, shows the real world value of switching to Phesgo for patients and healthcare professional when it was studied from patient point, healthcare economist, oncologist, pharmacist, all parameters, all points suggested subcutaneous form is more convenient and less time consuming. This is Indian real world analysis, the efficacy and satisfaction among the HER2 positive breast cancer patients undergoing subcutaneous injection Phesgo along with chemotherapy. This is a case series, and it showed that there was no difference in response and efficacy, and safety profiles were also indicated, and most of the patients preferred subcutaneous. Phesgo provides benefits in cost, time and reduction of patient and healthcare professional burden. Shorter administration time, that is 5 to 8 minutes, and observation period of 15 to 30 minutes of Phesgo reduces the burden on patients, caregivers and provider. Phesgo has a less invasive administration, that is single subcutaneous injection versus IV, that is 2 separate IV infusion, freeing patients from the burden of IV related pain, bruising and irritations. Fixed dose formulation may help reduce risk of dosing errors, reduce drug wastage and increase availability of nursing pharmacy staff for other tasks. Reduced time required for drug preparation and administration with Phesgo versus IV has the potential to relieve strain on infusion centers. No new safety signals have been observed when switching from IV to Phesgo, that is subcutaneous form, and vice versa. Thank you. Thank you for the present hearing.
So thank you. That was a wonderful presentation and seems very tempting for all clinicians to go with. But I have a very small question. Is there any subset of the patient where we need to be very conscious before administering this drug because they have a fixed formulation, or any guidelines to the clinician or to the patient per se that yes, you have to be a little careful, or is it the same what we are using pertuzumab or IV trastuzumab like what we are using? So yeah. What's your say on that?
In IV trastuzumab we use the dose as per the body weight, but here it is a fixed dose combination. From the research, from the clinical trial, there is no difference, but personally I feel when the body weight is low, thin patients, so in those patients maybe I think if there is no problem in administering the IV formulation, that is I think if there are thin, low fatty patients, in those patients I think there may be some problem. So although the study doesn't reveal this problem.
So we need to wait and see
Yes,
our own
yes,
Indian experience
yes.
data, that how for frail, fragile, elderly
Yes.
patient, how it behaves.
Yes, another point is important point with the introduction of all the newer biosimilar and all those for a resource constrained country like us. This is not for all patients. Definitely, who afford and who can afford and who want, then we can offer. But otherwise, the other options are always there.
Thank you, sir. Our next session is online session. The topic is lessons from global models, the breast testing using radio frequency signals. My pleasure to invite Dr. Gianluigi Tibri from Italia.
Hello, can you hear me? Can you hear me?
Yes, yes.
Yeah, audible. Yes.
Okay, well, thanks very much for this opportunity to show some news about the use of radio frequency signal towards testing of the breast. I will share my screen now. Okay. Okay, I hope you can see my screen. So, I am Gianluigi Tibri. I'm a co-founder of one company in Italy, which is called EDT, which is developing this device which uses this radio frequency signal to perform testing of the breast. So, this is the sample of the talk. First of all, which is the problem that we would like to address with this radio frequency testing? As you know, breast cancer is the first cause of death in all women, and 30% of cancer are now diagnosed in women aged under 50. And recent studies shows an increase of prevalence of the cancer in the young women as well. Now, to reduce breast cancer mortality, mass screening is fundamental. However, usually mass screening is performed using mammogram, which is not suited for young women. So the next question was how it would be possible to make breast cancer screening more inclusive, potentially ideally also young women. And microimages has been recognized as one promising non-ionizing and non-invasive screening technology. So microimaging uses radio frequency signal in the band from 1 to 9 GHz. And we use a very low power signal, 1 milliwatt, which is usually 100 times less than on mobile phone, so it's totally safe. Why it works? It works because there is a contrast in the electric properties when we use radio frequency signal. The electric properties are the properties that are commonly constituted in different tissues, and basically there are two properties called the electric constant and the conductivity. And many studies show that there is a contrast in these properties when we employ radio frequency signal. So the idea is to use this signal to check if inside the breast there is one area in which there is this contrast, which may be connected to some anomalies such as malignant lesion. So the idea is to illuminate the breast using this signal, somehow trying to collect them, as we will show in the next slide, and then process this data to see if inside the breast there is a discontinuities in terms of the electric properties. We in Italy developed with one device, which is Simarca-Tennis, running many clinical trials around many different European countries. Here it's just a video, just to see how it works. The patient lies on the bed, inside there are two antennas that rotate on the breast, transmitting and receiving radio frequency signal. So no breast compression, and after 8 minutes the data are recorded. Which data? Basically we record the signal reflected by the breast. We recorded this big matrix because for each transmitting and receiving position we collect from 1 to 9 GHz, and this data may contain the information of the eventual lesion inside the breast. So the acquisition is that, as I mentioned, we in this moment we do not want to replace screening program, but we frequency signal are ideal to do test in young women, and also it's perfectly suitable for BRCA gene mutation, and as I mentioned, performance are good in dense breast. So in Italy we have already some private clinic in Tuscany, which are trying to implement this idea of doing the examination in young women, and in case it is positive, the women will go to further checks, such as a visit, ultrasound, and then the doctor will decide the following step. Also, very important thing is that the examination can be repeated with the aim of trying to see if the breast could be tracked throughout the years. In this way, the idea is trying to intersect the small changes in the breast, which can lead to a kind of alert. And this is the theme of our company. And again, thank you for this invitation, which gave me the opportunity to show what is new in the world of radio frequency signal imaging.
I'm sure wherever there is a reduction in the radiation level and the compression of the breast tissue, every woman is going to like it. And also quite impressed that the sensitivity is quite high in the high 80s, and the specificity for everyone is good. And then your point is well appreciated about the young women where the breast density is going to be different, and then the application of this technology is going to be great. Thank you once again. So
thank you very much.
There is one question, if you could just stay on.
Yes, sure.
Excellent presentation, Dr. Thaberi. The only question is that you showed the examination being done in the prone position, and then capturing whatever mound is protruding out. What about the lesions that are in the extreme quadrants of the breast, and the axillary tail lesions, and of course the axillary assessment?
Okay, yes, thank you very much for this question. Actually, the point is that the picture basically does not fully describe how the radiation of the antennas go, because if we think to the radiation beam of antennas, this radiation does not flow horizontal, like for example in X-ray. So the beam of antenna somehow capture the entire area of the breast, even if we cannot reach the axilla. So here we cannot reach it, that's it. But a little bit the radiation goes inside, so we can see a little the extension of that. So let's say entire breast is captured, but not axilla.
Thank you very much.
Okay.
Thank you once again, and we can close the session.
Thank you.
Much appreciated. Thank you.
Thank you. Bye. Bye-bye.
Thank you. We'll have the last session for the day, and that is a special lecture, which is a pre-recorded lecture by Dr. Christy Funk from US on modifiable risk factors for young breast.
Hello, everyone, and greetings from Southern California. I'm Dr. Christy Funk, board-certified breast cancer surgeon and medical director of the Pink Lotus Breast Center in Los Angeles. I'm also board-certified in lifestyle medicine, which makes today's talk particularly exciting to me. Why? Because today we're going to discuss how diet and lifestyle choices impact young women's breast cancer and health. First, a look at where the stats are trending. In 2020, breast cancer surpassed lung to become the #1 malignant tumor on planet Earth, with about 2.3 million new cases and 685,000 deaths worldwide last year. More expected this year, and even more predicted for next year. So clearly, breast cancer constitutes a major worldwide public health threat and remains a scientific, clinical, and societal challenge. Data from the Global Burden of Disease Study 2019 was analyzed and reported out last June that the incidence rate in this current decade, 2020 to 2030, is increasing, with the most significant rise seen in those aged 45 to 49, going from 80.94 in 1990 to 98.41 in 2030. So that's over a 22% increase in breast cancer incidence in just 4 decades. And cancers are occurring younger than ever. In fact, when we look at global trends in graph form, in those under 50, we see that since 2010, there's a steady uptick in cases under 50 here in North America and in Europe. But on all other continents of the world, it's just a straight shot upward in incidence for those under 50 from the 90s to the present. And sadly, only high socioeconomic status countries are enjoying a year after year precipitous drop in mortality, while the rest of our sisters on Earth see a steady and relentless rise in death. The World Health Organization's admirable response was to start the Global Breast Cancer Initiative, whose objective is to reduce global breast cancer mortality by 2.5% per year, thereby averting 2.5 million breast cancer deaths globally between 2020 and 2040. The 3 pillars towards achieving this objective are health promotion for early detection, timely diagnosis, and comprehensive breast cancer management. However, I would like to add a 4th objective, because these 3 are reducing mortality, meaning death from breast cancer that is getting diagnosed. So let's diagnose it early. But how about we never get it at all? The 4th pillar would be that we need to offer evidence-based health guidance starting in teenage years. We need to create and implement enhanced interventions and treatments to reduce disease risk. Why? The easiest cancer to cure is the one you never get. Now, is that realistic? Can we prevent cancer? No, we cannot. Not entirely. However, I get it. You can't play bingo with your life's choices and confidently say, like, there, I exercised, I ate right, I stressed less, and boom, I did it. I got 5 things right. Bingo, no cancer for me. But you can exert some enormous control over reducing your risk. How do I know this? Because only 20% of women with breast cancer have a family history of breast cancer. And in fact, only 5 to 10% of all women with breast cancer can attribute it to an inherited genetic mutation, such as BRCA, CHEK2, ATM, and the like. Now, I'm not diminishing the importance of global genetic testing to identify and appropriately manage these very high-risk individuals. I'm merely pointing out that these mutations do not account for the vast majority of breast cancer causation. DNA mutations like BRCA exist or they don't exist, and so they cannot explain the increase of 22% over 4 decades, nor can we blame mom and dad for why breast cancer is happening at younger ages every year. Just like these inherited genetics, there are other risk factors we cannot change in life. So I want to acknowledge them and then hyper-focus on what we can change. Breast cancer risk factors you cannot change are being born female, getting older, having a family history of breast and other cancers, having an inherited genetic mutation like BRCA, your race and ethnicity, having had radiation to the chest wall, say for Hodgkin's lymphoma prior to age 30, being of tall height, having dense breasts, having earlier menarche, which is the age at which you begin having your monthly menstrual cycles, and later menopause, a personal history of marker lesions, I mean precancerous changes in breast tissue, things that had the word atypia in them, or radial scar, or lobular carcinoma in situ, DES exposure in utero, and parity, which is how many babies you've had and how old you were when you birthed them. Now, as much as these conditions seem fixed, they are but seeds, capable of germinating within you, but your lifestyle and environment are the soil, the water, the sunlight that determine whether those seeds grow into flowers or weeds. You do have agency over your health destiny. The key to protecting yourself from breast cancer is to understand that the following daily choices you make unleash biochemical weapons into circulation that either stoke or choke cancer, fuel or fight cancer. Choices like nutrition, exercise, body weight, risky substances including alcohol and tobacco, environmental toxicities, emotional stress, fasting, sleep, microbiome alterations, and hormone therapies. All of those choices support a bath, the fluids and cells and hormones and growth factors that bathe, support, and fuel cancers, or seek and destroy them. You choose. Every time you eat or don't eat, drink or don't drink, move or don't move, sleep or don't sleep, think or don't think something, forgive or don't forgive someone, you're messing with the water. You don't